आप क्यों लगा?
Hi, Marius, can you hear me? Good morning.
Yeah, I could for a second.
Can you hear me?
Dear colleagues, please take your seats. Kalimera, good morning. Thanks a lot for making it. I would like to say just some highlights that yesterday we had 140 participants with physical presence. We had more than 500 following us at YouTube and more than 500 also via Microsoft Teams. So it was a truly European conference. Now it gives me a great pleasure to invite the Minister of Health of the Republic of Cyprus, Mr. Neophytos Harlambidis, to give the opening address of the conference. Thank you.
Good morning, everyone. What a nice place to have a conference, huh? It's a place and it's a city as well. Huh? Don't forget that I come from Limassol, so welcome to my hometown. I hope you have a pleasant stay here and enjoy the place together with absorbing all this knowledge. Κύριε Πατήγη, κύριε Σχίζα, αγαπητοί φίλοι, dear guests, esteemed friends from abroad, ladies and gentlemen, it is a great honor to welcome you to this pivotal conference organized by the Cyprus Presidency of the Council of the European Union, which addresses a crucial area of the EU Health Union. This gathering reflects our shared vision and collective commitment, bringing us together to exchange ideas and shape a stronger, more resilient and more promising future for the health of our Union and its citizens. We are at a defining moment for European health systems, one where policy ambition meets technological capability and where trust, interoperability and innovation must converge to deliver real value for our citizens. Recent experiences, including the COVID-19 pandemic, have demonstrated the vital role of data sharing, coordination, and digital readiness in building resilient and responsive health systems across Europe. This conference, Building a Trusted, Secure, and AI-enabled European health data space for a stronger European health union, reflects both the ambition and, of course, the responsibility ahead. At its core is the European health data space, a shared European vision to empower citizens with control over their health data, to support healthcare professionals, and to enable responsible data use for research and policy making. Combined with trustworthy artificial intelligence underpinned by the EU AI Act, this transformation offers a unique opportunity to improve healthcare delivery and outcomes across Europe. This vision is deeply aligned with one of our presidency's priorities, the one of promoting the effective implementation of the European health data space as a means of integrating health systems and completing the European Health Union. This priority reflects the shared understanding. Legislation, while essential, is only the first step. It also reflects the Presidency's commitment to building a unified, robust, and secure health data ecosystem within the EU, one that strengthens the delivery of health services through broader data exchange and drives innovation across the health sector including the responsible deployment of AI-driven solutions. Within this framework, our joint work is both essential and fundamental. Guided by evidence, our collective efforts must focus on 5 well-defined key pillars: trust, interoperability, innovation through the responsible use of data, cooperation and shared responsibility, and the development of truly citizen-centered European Health Union. First, trust. Citizens must trust that their health data are protected, used responsibly, and accessed transparently, and that AI systems are safe, explainable, and under meaningful human oversight. Second, interoperability, the enabler of both data sharing and AI innovation. Across Europe, we must move from fragmented systems to a truly connected digital health ecosystem, supported by common standards and cross-border infrastructures, such as MyHealth@EU, which already covers core services like e-prescription and patient summary connected with 9 member states. At the same time, we must acknowledge the challenges that lie ahead, including system fragmentation, the need to improve data equality, and the importance of strengthening digital skills and trust among both professionals and citizens. In this effort, the contribution of the European Commission, along with EU funding for responsive joint actions and projects, is of utmost importance. Third, enabling innovation through responsible data use. EHDs creates unprecedented opportunities for both primary and secondary use of health data. When combined with AI, this data can support early diagnosis, more personalized treatments, improved system efficiency, and stronger public health responses. However, innovation must go hand in hand with responsibility. The implementation of the European Union's artificial intelligence framework is crucial for ensuring that AI systems are transparent, safe, and accountable, while enabling access to high-quality, interoperable data through secure and well-governed environments. Fourth, cooperation and shared responsibility. The European Commission, member states, healthcare providers, patients, researchers, and industry all have a role to play in the success of EHDs. Under the Cyprus presidency, we are committed to fostering this cooperation and translating policy into action. Finally, a citizen-centered European Health Union, one that places the European citizen at the heart of our efforts. A citizen who can securely access and control their health data across borders. A patient who benefits from better, safer, and more personalized care. And a society that benefits from innovation while upholding fundamental rights. As you are well aware, the final projects meetings, XT-EHR and the TEHDAS-2 joint actions, were hosted in Cyprus this week, and it would be an omission not to acknowledge the catalytic role in shaping the content, directions, and outcome of the deliverables. At this point, allow me to recognize the dedicated efforts of the National eHealth Authority and all partners involved in the preparation of these meetings and, of course, of this conference, and the choice of the place and the choice of the city as well, Mr. Vatis. Their commitment and professionalism have been essential to their success. Ladies and gentlemen, the Cyprus presidency stands ready to contribute actively to this shared European journey, not only by advancing policy discussions, but by supporting concrete implementation and fostering close collaboration across member states. Together, we can build a trusted, secured, and AI-enabled European health data space, one that strengthens our health systems, enhances European competitiveness, and delivers tangible benefits for all our citizens. I wish you a fruitful and interesting, I would say, cooperation and discussions and meaningful contributions towards our shared goal for a stronger, more innovative and more resilient EU health union that places the patient firmly at its core. Thank you very much for your kind attention. Enjoy the rest of the conference. Please allow me to return to Nicosia for another meeting I will have in less than an hour, and I will need more than an hour to go there. So please excuse me. Please enjoy. All the best to you. Thank you.
Okay, good morning, everyone, and welcome to day 2 of the Ehds-Ai Connect 2026 conference under the Cyprus presidency. A warm welcome also to the people online. We already have 250 people joining online. Dear Minister of Health, thank you very much for that inspiring address and for setting the tone for today's discussions. We now move to our first plenary of the day. This session focuses on translating policy into operational reality, highlighting interoperability, governance, and concrete implementation results. It's my pleasure to invite our co-chairs to lead the session, Professor Christos Hizes and Dr. Andreas Neokleous. The floor is yours.
Good morning. I think this closing of Ehds-Ai goes on and on. Yesterday, the day before, but I hope today you be the last time you hear from us regarding Ehds-Ai. At least in this context, you see us in the implementation, of course, and we going to start the panel. We have many, more than the chairs, participants in this session, so we're going to call the first 6 to come, and the rest will be waiting there for their turn. Thank you, Andre.
Thank you, Professor. Welcome, everybody. I would like to call Dr. Daniel Carlson. Dr. Vanya is online. Anna is online. Esther Pilen, please. Irene Schiza. Nuno da Silva. How many are we already? And then Catherine Truner, Zoltan Falusi. If we don't have space, we can you can sit here in front, and we will give you the floor accordingly. Haralambos Karanikas, Giorgio Cangioli, Hinek Kruzik, Alexander Berler, and Eamon Cohen is online. Thank you.
Okay. Yes? Oh, thank you for the improvisation.
I'm the special.
Yes, of course. Finalizing everything.
Is anybody sitting? Do we have somebody sitting down? Bring another chair, or we are complete?
I think we are complete.
Okay.
Zoltan Falusi, I don't know if...
When he comes, we bring another...
And Catherine Truner, she's not here.
Yes. Okay.
Ah, Catherine.
Thank you.
And Irene is here.
Yeah, she won't miss the show.
Okay.
Okay. Now, I'm going to say something at the beginning. Our first slide, please. Okay, from vision to implementation, we said all this. The next slide, please. Okay, we enable cross-border interoperability. Just to say something about the specification in the artifacts platform. We develop and deliver the building blocks and guidance to the EHDS as a reality, to become a reality. We have taken the EHDS as a policy framework to turn this into, oh, thank you, I forgot. And set the vision and the rules to secure trusted and interoperable health data across Europe. In the other side, the implementation impact, and we envision this to be the deployment in the member states, enabling interoperable services and solutions, and improve the outcomes of all. Support existing technologies and structure, and enhance them. My Health at EU as a national service to become a reality, and most importantly, to become compulsory, that the EHDS stops offering this in Europe as a voluntary activity, but is now a compulsory. The 4 pillars, AHR, interoperability, and requirements. The format, which we want to enhance and build on it to be a FAR-based solution framework, which we demonstrated its practicalities and its applicability through the various activities we had and Connectathon and other gatherings. We set up the telemedicine framework. We cannot operate in Europe remotely. And if you remember the train, the locomotive will not take us from one place to another. We need the fast EHDS track to take us there through the telemedicine framework. And of course, conformity and labeling, very significant for having the standards, common agreement, common policies, in order to have the citizen trusting this network and leave no room for mistakes and securities. Andrea, you can continue with the rest of the introductory slides. Thank you.
Thank you, Professor. So, as a project, you understand that we had 50 more partners. That was very hard to coordinate, but thanks to all the goodwill of the people, and especially the work package leaders, that many of them are here. But we had to face multi-country coordination, as I said, and then the project was stakeholder-driven in the terms of we shared our work with the stakeholders And when I say stakeholders, it's not only the industry, but also the EU level stakeholders and others. And we received thousands of comments. I think it's about 13,000 comments from across our deliverables. That was a huge work for us, but at the same time, it was really helpful to make them better and to hear what these people want to say and the concerns and so on. So the deliverables were updated accordingly, and I think that was one of the most important parts of the project, this communication between the policy level and the specifications, the technical part, and what the real life is asking and is able to do. So, and then, of course, cross-work package collaboration. We had I don't know how many hours discussing to each other because, okay, one can think that these are different aspects of the regulation, telemedicine and the format and exchange of information and so on. But if you don't have this collaboration in making sure that all this ecosystem can work together, it's almost impossible to make it in practice. And finally, we created this artifacts platform that we will host the logical models, the FHIR implementation guides, and some other artifacts that will need to be there. So people can go and find everything in one place, even if some of them are not officially belonging to the project, or after the end of the project, we will have the specifications and everything there for easy navigation and to see what you can do, what you have to do. And the impact, of course, first of all, it's the citizens, European Union citizens, and hopefully later global impact. The healthcare professionals, the health systems in general, public authorities, research and innovation, primary use and secondary use will become one thing, hopefully in the future, and yeah, for Europe. So with this message, I don't know how I changed the slide. I would like to ask Vanya to give us an overview for the general requirements of EHR systems. Thank you.
For the introduction. If you can please put the slides up. Thanks. Just a second, I need to organize my screen a bit because if it's okay if I remove myself off screen so I can see the presentation, it would be easier. So hopefully you can still see me. One of the challenges of the work that we did in the joint action was to take from the regulation, which was just passed in the Parliament, the set of legal requirements set before the vendors and the member states when it comes to the development and implementation of EHR systems, and to translate those requirements into technical ones. So we went from policy and legal to technical specification level requirements for the key components of the regulation that require standardization. These are there's three groups of these. So one is the general requirements, interoperability and security and logging. Now each of these pillars affects different components of the EHR systems. Things like performance and availability of the systems, affecting safety and reliability towards data subjects, of course, standardizing cross-border exchange, alignment of the format, the exchange format, support for the common infrastructure that is currently available under the EHDSI, MyHub.eu, and of course, making sure that this does not interfere with the national infrastructures. Mostly focusing on things like consent and access control, data protection according to national laws, and similar aspects. One of the points that we've tried to undertake was to create a set of requirements, technical requirements, which would apply to all EHR systems across the EU, thus enabling local, regional, and cross-border implementations, and to also cover different deployment models. This was, again, in order to facilitate the implementation across the member states so that it doesn't interfere with their own national infrastructures. Next slide, please. That's Daniel already. Thank you.
It's Daniel, Isidoro. Thank you very much for this.
Thank you.
Daniel.
Do I move or do I sit down? And
Yes, you can.
yeah, okay. I can.
Okay.
So, logical models. I think I need to see the slides I'm talking to. That was not the one. There. Thank you. So most of us have read the regulation 1 or 2 times. And Article 15, first item, is about what the EHR exchange format consists of. And you see in the left-hand side column, we have harmonized data sets, coding systems and values, and technical interoperability specification. And when I go through this slide, you need to remember those colors because they have some significance. So we interpreted the EHDS regulation, and we started working on logical models corresponding to the harmonized data sets. We used as input several sources. So one of the main sources was the eHealth Network guidelines. That's the current consensus, what should be used for the voluntary sharing of health data across borders in the European Union today. But we also looked at ISO standards. We have the ISO IDMP suite of standards. We have International Patient Summary and other standards. We also looked at other standards organizations such as HL7, particularly HL7 Fire and DICOM, to inform the logical models. We also got a lot of, we were really standing on the shoulder of some giant European Union projects, and all the projects with X in the name, like XShare and X whatever, we used as input to devise these logical information models. When it comes to coding system values, we in the logical models, we stated a preference for certain code systems. And when it came to developing the technical, the implementable specifications underpinning the format, we collaborated mainly with HL7 Europe and IHE Europe to develop a set of FHIR implementation guides. There were already work started within HL7 Europe, and because of the previous eHealth Network guidelines developed, for example, for laboratory medicine. And I would just like to say that the Extended EHR Consortium worked together with stakeholders. We got a lot of comments, like thousands of comments on these logical models. But we also collaborated with the SDOs in both work on the logical models and implementation guides. Thank you. I will.
Thank you. Thank you, Daniel. Yeah, we are playing musical chairs now. You take that.
Yeah, you can change, but you can sit up. You know that you are after me again. So, good morning, everyone. Just few words because we have so many people. Just to emphasize the, let's say, the forward-looking strategy that Ehds-Ai decided to adopt for the part of the fire implementation guide. Instead of, as already mentioned by Daniel, instead of starting a new activity, he decided to sign an agreement with SDO like HL7 Europe, HE Europe, and other projects engaged in that domain, and to join their effort to actively contribute to this standardization activity. So the result of that has been that we can rely on a neutral space where a large number of not only the member state, but also EHR vendor, implementer, healthcare professional work together in order to create, since the beginning, this specification. The result of that, all the specification, as already mentioned by Daniel, just realized was the logical information model that has been agreed and decided by the EHR, and that implies that when you are going to validate and to make the conformance testing of your implementation against the fire AG, you are also assured that you are totally compliant with that model that has been defined by Ehds-Ai. So the result of that has been a set of fire implementation guide that has been developed and continually tested through also hands-on heaven, that has been already mentioned. The last one has been during the projectathon, Ehds-Ai projectathon. This also helped a lot to improve the quality and maturity of that spec. Obviously, we all know that this is not the end stop. It's a very important first step. We all know that we need to continue in that journey, that we need to continue this continued maintenance. And I really hope that this virtuous path that has been initiated by Ehds-Ai will continue also later on after the end of that project. Thank you so much.
Yes? Anna, thank you.
Yes, so
Floor
thank
is
you.
yours.
Yes, can you hear me?
Yes, yes.
Oh, good, thank you. So I'm here to say a few words about one of the prioritized categories that we were to look at. And across the board, we were, as my colleagues have expressed, there to establish the requirements and specifications for the EHRs to support the exchange and interoperability of the format. And for me and a number of other people, this was in regards to the patient summary. The patient summary has a long history. Patient summary started almost 20 years ago, which means that there was a lot of heritage to look at. We had a number of different sources. We had, of course, the guidelines that now has a couple of years on the neck. And we had My Health at EU. We had, as Daniel said, a number of projects that looked at this. There was actually implementations live and kicking, so it was in actual use at this time. We also had the IPS, which has evolved quite for a long time now. It started with the European patient summary, and then it evolved to the IPS. So we needed to look at that as well as part of our assignment. Another task was, as I said, that the patient summary had a lot of history. It's been implemented, it's been used, but it has been in a structure where the EHDS describes how this is going to evolve into a new generation. More in detail, it was about taking us from CDA documents to a more resource-based HL7 fire implementation. So that was the scope of the patient summary. And if you change the slide, please. This didn't come without hiccups. As many of you know, anything that exists is hard to change. So we did a quite vast investigation to look at the knowledge that we had about compliance, how ready are member states, especially those that hadn't implemented, how ready are we to comply and to be able to share this data of the patient summary today. And looking at that information in regards to where we want to get to, but also what is feasible, knowing what we knew of the readiness of the member states. So that was a long and quite extensive set of work to look at what could be done, and not to set us up to fail. We also looked at the code systems, as that was part of our task as well, and that didn't either come as an easy road. And this is a challenge I think we all struggle with nationally. We all have the wish and hopes to move towards fewer standards, the same standards, so we can speak the same language. But the twist here is that no one's really wanting to change anything in their own setting, no matter if this is locally, nationally, or whatever. And that has sprung quite a number of discussions within our work. And then the other part was that we had a huge dependency to all of the categories. The patient summary is quite broad. We cover a lot of different data elements, a lot of different contents. So anything we did on the patient summary had a direct impact on some of the other specifications and deliverables. So this required a very close work and a very close community within the extended EHR across the board. The patient summary could not work on its own, so to say, which is a good thing, of course, because that will make it easier to implement. And then, as I said, patient summary has been part of a CDA document solution, and now we needed to look at how can we bring that into a new generation of FHIR resources. But we did manage to get further, at least, on these issues. We took the knowledge that we had to build a stronger patient summary. We did agree that, yes, we can do quite a bit on the code systems, but we also need to make this a more strategic and political matter. So we addressed the eHealth network and its subgroups to ask for help to make some principles on what code systems to use so that we can ensure that the EHDS and its implementation is a success. So that work is still ongoing, partly a part of our deliverables, but also work that will be ongoing for this year. And we're really happy we did that because we can see that it then has a different weight. We have, as Daniel mentioned, we provided the logical models, we provided the implementation guides. We had a huge input from stakeholders. Almost 2,000 comments were dealt with during this period, which was a huge ordeal, so to say. So the work will continue. The work moves forward now to MyHealth.eu and to the EHDS negotiations and what will be the implementing acts. But in essence, the services, despite the project being done, the services are very much up and running in many places, and that involvement is going on as we speak. So thank you. Over to you, Insect.
Thank you, Anna. Two significant points I want to re-emphasize. CDA to FHIR, it was beyond our objectives. We had to touch it for internalization purposes, and also IPS. Many countries implemented IPS. It was not obligation, but we did. And again, we are knocking the door of internalization through XDHR. Thank you. Daniel, I think it's your next,
yep.
I think.
I think so too.
I'm pressing, let's see.
That's
oh, how we find it? Here you are.
There, I have a slide in between. Yeah, there. So, yeah. Help yourself. So we also worked on another existing service, which is also a priority category of the European Health Data Space Regulation. So it's e-prescription and e-dispensation. And there, as many of you know, there is existing legislation already before the EHDS. There is the Patient Rights in Cross-Border Healthcare from 2011, stating that member states should recognize each other's prescriptions and allow dispensing. There is also, similar to patient summary that Anna was talking about, there is an existing e-prescription and e-dispensation implementation in MyHealth.eu. So there are already many member states who already share electronic prescriptions and allow dispensations in pharmacies across Europe of European prescriptions. So that already exists, and we don't want to change. This is e-prescription is actually a service that is actually used by like real flesh and blood human beings and supporting their health when they're traveling or when they're living abroad. So some of the challenges that we faced was that medication and use of medication is typically highly regulated within the member states. So different member states have different legislations. For example, we have some examples, multi-line prescriptions, where one prescription can contain multiple medicinal products, and what the impact of that is. Generic prescribing is also something where the regulation differs between member states. Rules for substitution, like the roles and what different roles are allowed to do. For example, what can a pharmacist do differs in relation to a prescription and a dispensation situation. That differs between member states. We still managed to go forward. We created models that work not only for the cross-border situation, but also for the varying legislation in each member state. So, for example, we supported multi-line prescriptions in the extended EHR model, but that is not supported currently by My Health at the EU. So we worked on the prescription and the dispense information, but we also collaborated with the other tasks of work package 6 and 7, the other priority category tasks, to develop models for the medication domain. So medication is something that is used in all the priority categories, whether it's the medication summary or the patient summary or the contrast that is used for imaging studies. So there we worked. And we also supported the HL7 Europe MPD project in developing the FHIR implementation guides. There, thank you. And on to Hinek, I believe.
Yes. Hinek, please. Take this.
Thank you. Okay, the medical test results. The EHDS regulation gave us quite a broad task to cover because there are very different type of medications that we were supposed to describe and create these specifications, functional and technical specifications for observations that are being made in very different environments, in laboratory conditions at one hand side, but also for observations being made in the hospitals, in the ambulances, outpatient care clinics by different type of healthcare professionals, but even by patients themselves. So the task was to create a refined data model, of course, and that's, of course, common for all the technical work packages and tasks in it, or all the priority categories, to define the differences between the medical test results and the laboratory test results, actually to prove why we selected a particular coding systems to express the kind of observations being made, and actually to specify all test results comparability criteria. This is one of the semantic challenges that we faced. A part of course, the structural constraints for the observations. During that journey, we analyzed different sources for our work, OpenEHR, FHIR models, and also our previous work on the healthcare information models in the Cross Health project some 4 years ago already, time is running. And based on that, we have created a specification of the general observations and another set of specification that extended a little bit to the data set for the laboratory observations, with just some specific requirements. So that was the part covering the technical aspects. Of course, we were covering also the use cases and other parts of the deliverable, as we want to describe all the layers, or at least touch them, all the layers of the European refined interoperability framework. Well, what else to say? The outcomes, well, I thought that I have one more slide, but it seems not. So, to make it short, sorry? That's the other one. Okay, thank you. Okay, the outcomes and objectives I covered more or less. The outcomes are important, of course, and that's the specification for the implementation guide for laboratory result reports, which is to some extent applicable for also other type of medical test results, which are then influencing the specification of hospital discharge report, patient summaries, and others. I'm very proud that we really created a working capacities around this project, which are now composed from experts on semantic, laboratory medicine, information technologies, and this working group is now working around about 4 years, and I believe that it will be keeping going even after this project, because we all feel that this is necessary. So that's all from my side, and thank you for the floor.
You can sit there. Esther, please.
Good morning, everyone. It's a pleasure to be here. So, on the medical imaging studies and reports team, I will guide you through what we have done, starting with the focus we had in mind. That was mainly the patient empowerment, since the EHDS puts the citizen very much in focus. That's something what we had in focus from the start, because it's important that the patients will have access to their images and the accompanying reports. The second next important goal, of course, is also to have access on the images and the reports for healthcare professionals, and to enable them to find the right diagnosis for the patient, but also to compare previous taken images. And these could be maybe taken or performed in another country than the citizen's home country. And this is all to provide the best possible care. So it's really at the heart of our work that the accessibility to images and reports is achieved. And our task was to make the specifications for those making available of these images and reports in the so-called European Electronic Health Record Exchange format, or format in short. I'm sure you have heard it a lot of times already the past days. So the task of the team was to set up the specifications, the functional specifications, to be used cross-border, but as well in national settings, in order to provide efficiency and avoid fragmentation and duplication of efforts. And what is in scope? When we are saying images, that means that all DICOM recorded images or imaging studies are in scope, covering a wide array of specialisms. So from radiology, urology, gynecology, cardiology, and many other ologies. Next slide, please. There's one in between. Yes, and this is rather a crucial slide, and it has been emphasized already by a couple of the previous speakers, the stakeholder engagement, which is so important, because the users are the ones that need to implement the format in the end. And the healthcare professionals and the patients are the ones that should benefit from the images and reports being available to them. So having their input and hearing what was really needed from their sides was really crucial. And here we collaborated a lot with HL7 Europe and IG Europe, who have the communities of the users. So that was really a key asset in the project, I would say. And what we also did is connect with them on several like events. For example, both organizations organize projectathons, connectathons, plugathons, or any other athons. And we joined them to, in the early stages, be able to test the specifications that we had set up. And that proved really valuable to us to improve our specifications and get closer to reality. So in the end, it will be possible to have the information available at the point of care. Thank you.
Thank you, Esther. Who is next? I admire this technology here, this setup. It's incredible. It's Vanya.
Yeah, thank you, Christoph. And hello once again. So in the next couple of slides, I will be talking to you about the discharge reports work that we did. So the discharge reports is one of the new priority categories, or rather the new services that will be implemented by the member states as per the EHDS regulation. And similar to other colleagues, we were standing on the shoulders of giants, so there was a lot of work being done in previous projects, and also we had the EHN guidelines to build our work upon. One of the biggest challenges at first, though, was this scope, the enlargement of the scope. So we moved from the hospital discharges to discharges in general. So we've within our scope we had several different large use cases. Now that, as you can see on the slide, and again, the challenge was to basically, unlike the other priority categories, with the discharge reports, one of the biggest challenges was to accommodate all the needs across the member states, and first of all, find a working definition of a discharge report, because these documents typically are very much different, even sometimes in some cases in the same institution, but definitely in the member state, and then that more definitely across the member states. So with that in mind, we've identified a few usage scenarios. So similar to other categories, we've tried to define the technical requirements for the discharge reports, both on the national and regional level use, but also for the European cross-border exchange. Now, the specific of the discharge report is that one of its main purposes is by default to have this handover between different providers to support the whole life cycle of a person moving from facility to facility, and in some cases across the member states. So next slide, please. Another specificity of a discharge report is because it's a document that's supposed to be carried over first within the institution and then across different institutions, different facilities. We have several milestones within the life cycle of a discharge report, from generating it to making it available in a structured and validated format, then being exchanged and then retrieved and used by different actors across the system. We also defined the core actors, the producer, consumer, and the exchanger. So these were all aligned with the specifications and the requirements for the HR systems that I've talked about earlier, similar to other priority categories. And of course, the technical foundation of the discharge reports was pretty well aligned, or was based upon the format, the exchange format, of course, with close collaboration with HL7 and IG to define the interoperability standards for the documents and the resources that we will use and that we defined in the work package that we're working on, using standard terminologies and the structured narrative to support the specific information that is in the discharge report typically. Next slide, please. Although I think this was this was the last one, I think. Yeah. Thank you. Thank you again.
Thank you, Vanya. Earlier it was my mistake. I asked Andreas in between, let's have a 5 or 10 minutes discussion and give the chance to the audience to ask any questions or make any comments. And I forgot that there's a discussion in between. Therefore, we're going to have the discussion now. And if you have any questions, any remarks, we have microphones to give you the chance to say something. Please, let me give you the...
Thanks for the great presentation and all your hard work on the XDHR. So my name is Markus Kalliola. I'm in the coordination team of Tehdas 2.
We can't hear you.
Sorry?
We can't hear you very well.
Okay.
Loud.
That's better. Okay. So if you forget the exchange layer and all the technical aspects, and we think about the payload and the documents that you have provided, for example, on the medical imaging or patient summary or e-prescriptions and so forth, how close we are on the final documents after your work? So if you consider that we start the exchange on March 29, how much work there still needs to be done for these documents? How final they are now?
It's very technical. I think Hinek might help us in giving the answer. Yes, Hinek?
They are in the best stage that we can achieve. So from my point of view, the deliverables are final. Of course, now the implementation specifications, which are based on that, needs to be also not only created, but also tested. So even after the feedback from the implementers, we can speak about some stable versions, but they will not be very much different from those which has been published so far.
Hinek, any other comment or question?
If I can also say something on this,
Andrei.
Because you know the content of the documents is there, and who decides what is the content? Okay, we had of course the e-health network guidelines that it was the starting point, but one can say, okay, unstructured PDF, it's also okay, which is something that can be exchanged with no cost or with little cost. So the content is there. The problem now is how to, let's say, support the member states to actually implement it and be able to exchange. This is the hard part now, and this is what we have in front of us.
Thank you. Let's move to the next presenter. Yes, Andreas, please. I take the sentence.
So, thank you. In the conformity framework, we had to answer the question. We have, all this content of the format, which is huge. It's 5 categories. If you think of e-prescription and dispensation, it might be 2, so it's 6 actually. And then you have the requirements of EHR systems. You have the document exchange, resource exchange, and many other specifications. So the question is, do we need to implement everything for all the systems? Obviously not. Imagine that you have one device for the laboratory which extracts some laboratory results. Of course, you will not ask this system to construct a patient summary and exchange medical images and exchanging discharge reports and so on. So the question is, okay, we know the answer. We don't expect all the systems to exchange everything or to implement everything. And then the question is, what? What do we ask them to implement? And how? How do you classify your system as such that we need to implement only these specifications of the EHDs? How do we do this? So it was a huge question, and we spent many hours discussing this, also with people from the policy level, the eHealth network, the subgroups, but at the same time also with the industry. We discussed a lot with the stakeholders and within the project. We exchanged our mind many times. In the beginning, we made a complex way of classifying systems that then we simplified it because we saw that, from theory to practice, as you all know, sometimes it's a huge road. And nevertheless, now we know, at least we proposed as a project a way to do this. So, as I said, we have the systems. The system needs to be classified somehow into, this is what we call scoped conformance. So my system is only for making patient summaries and exchanging patient summaries. So we need to implement only these. And then we need to identify which profiles need to comply with. So I need to comply only with the interoperability profile for the exchange and for the patient summary and the relevant metadata. And then from this one, we go one step further and we say, okay, we have this huge document of patient summary or this huge document of discharge report. Do we need to implement all these elements? Do we need to send this to all healthcare providers, or can be even shortened? So this is what the tasks did, and they, in the last time of the project, spend a lot of time also defining this, because it's always difficult to decide. One can say this is important, one other can say no, it's not important, this is also important, and one can say everything is important. Or one can say, we don't care about the structured data, we only need to exchange PDFs. So who is deciding? And therefore, it's not always one answer. But, okay, we did our best and we have the obligations there. This is what we say, obligations. So you need to implement this, but you are, this is optional, this is, so the obligations are there. And yeah, that was the questions, and I think we took it one step further. I would like to call for the conformity, Haralambos Karanikas. Yes, thank you.
Of course, I want to add that about a year ago, we had no clue. It was a crisis in the joint action because of this issue. And during the last 9 months, we managed to find a solution. And of course, special thanks to Andreas for taking over this task.
Thank you. And I think on top of what Andreas said, I think we all understand that conformity assessment framework is not just specification. It's not just content that we need to satisfy and fulfill. Conformity assessment framework, one of the two parts is the governance. So the governance that is needed of how the conformity will be operate and what are the actual steps that the vendors they have to fulfill. And I have to emphasize especially the role of the vendors in the industry. All this will be theory if the vendors will not adopt prior procurement reinforce probably the specifications in the real world. So in the real world, the vendors are the ones, and I see Verena from MedTech, the vendors are the ones that they need to satisfy at the first level the implementation. 2 years ago in Athens, we promised to Verena and the other stakeholders that we will provide a clear structure, a clear governance structure that is in Work Package 8 deliverable 8.2 that has to provide clarity on the governance that will create the trust cross-border. And this is really something important. The second part, which was really important, and this is the previous slide, please. And the second part is to be clear what should be tested and the way that will be tested. So the testing logic that we tried and successfully satisfied during XTHR is to prove that from theory, from specifications, we go to real-world testing. And that was about the Projectathon event that happened in Brussels and proved that this conformity framework is not just theory, but it's reality. The other promise we had done to, again to Verena, was that we wanted to not to confuse the market. We wanted to make clear that we will not start from scratch. We will build on what the industry was used to do for years now and build on top of this. And I think, according to our deliverables, this is clear, and we hope that we kept our promise. The second important aspect of Work Package 8 concerns the wellness applications. And in the beginning, it was a vague issue. It was a discussion of how to relate the wellness applications in the Ehds-Ai era. And I think, again, successfully, we gave clarity to this dimension. Wellness applications data have a distinct role concerning the data priorities, and I think the approach that we have proposed is trying to mature the way that the manufacturers will build in the near future wellness applications that will complement healthcare provision. Thank you.
So use cases for deformment. When we started, all the teams, especially in Work Package 6 and 7, so for the 6 data categories of the EHDs, we all started in our own separate teams. And that was kind of a natural process because we built our specifications for those categories on the eHealth network guidelines. And the eHealth network guidelines are created by the eHealth network subgroups on semantics and technical interoperability. And they lay the foundation for example, My Health at EU. So that's the European infrastructure to exchange healthcare information across borders within Europe. So that was kind of our starting point. And I posted these blue squares that you see on the screen. These are all webinars created a year ago, something like that, where all these guidelines are explained by the experts who mostly are also the authors or one of the authors of these guidelines. So I really encourage you to go there if you want to know more about these guidelines and the use case descriptions that you will find in there. So that was kind of the starting point. So all the 5 teams working in their own field. And then after a while, we thought, well, it might be a good idea to have them compared on the use cases to be more coherent and have more consistency across the use cases where possible. So that's what we did. We had a couple of sessions with all the people involved in Work Package 6 and 7 teams. And we tried to find the commonalities and also the divergences, see if they were rightful to be there or maybe not. And if they were not really, there was no reason to diverge, we tried to converge again. Because in the end, we want to provide the specifications for the users that can be understandable and coherent as a total package. Another aspect I'd like to emphasize here as well is that like I said, the EHF network guidelines are focusing on the cross-border exchange of information on member state level. But the EHDS has very much the patient in focus. So that was also something we needed to look into. So how can we include the patient and information exchange with the patient in our use cases? And that's something we worked on and you will find in the format now. So these efforts were all done to provide better guidelines with better quality and meet the goals of the EHDS regulation in the end. Thank you. Who is next?
Thank you. So under the extended EHR joint action, Work Package 9 focused on the first steps for the telemedicine under MyHealth@You in a cross-border context. So it started by analyzing the existing member states' initiatives, pilots, policies, and also in terms of reimbursement schemes in order to provide a set of recommendations for the large-scale uptake of telemedicine in Europe. And with that, we understood that telemedicine is not just becoming a trend, but instead it is actually a structural shift in terms of how healthcare can be delivered. So therefore, we start the steps in terms of aligning it with the MyHealth@You. So we start by defining use cases. We start by aligning also the business requirements of the MyHealth@You infrastructure, and we came with two use cases: the teleconsultation between a patient and a health professional, and here we have the more mature use case. And also consolidated in most of the initiatives around Europe. And we also have the discussion between a patient's case, between two health professionals. So if you can move to the next slide. So as I said, we defined the actors involved to create the patient journey that consists in 4 different phases, and we also provided the technical specifications that were required to leverage this service as a supplementary service under MyHealth@You. And also, it is important to highlight that telemedicine is not just about convenience, but it is a real measurable value in terms of the access of care, in terms of the innovation of health systems, digital tools, and also in terms of the quality of the outcomes for patients, for citizens that are in remote locations. Thank you.
Confirm, please.
Can you hear you online, Zoltan?
Yes.
Okay, great, thank you. In Work Package 4, sustainability, we focused on a number of goals, as you can see. So we were tasked to map the present state of play of EHR systems and proxy services, and also map the current legal and policy challenges across member states, and to provide EHDS regulation compliant interoperability requirements. So how we went ahead with that was we analyzed the existing resources and literature, and we made two surveys, conducted two surveys. One was the state of the art for the EHR systems, and the other was for the proxy services. You will see the results of the latter in a minute. And we also provided practical recommendations thanks to our lovely colleague Lucia. So what we came up with in the end was basically a basis for further thinking as regards the state of the art of the EHR systems and and the proxy service implementation. So whether proxy as a service is available or not in member states, and we outlined the general principles of sustainability, the interoperability layers, and we also proposed future development regarding central services. And as I said, so there's an implementation guide in the deliverable for member states for tasks that are beyond quote simple compliance with the EHDS. So what else needs to be done on a member state level? Next slide, please. Thank you. So this is the result of the proxy survey. So we looked at whether basically there's a proxy service on a national level. And as you can see, the results show that the majority of countries, they do have some kind of proxy service, or it's in implementation, so it's in progress. And only a small minority still does not have. And yeah, I have to say this is it's as mid last year, so this could have changed. Thank you.
Hello, also from my side. Happy to share with you some of the results we have achieved in the Work Package 3 evaluation for the impact assessment. Yes, so we performed impact assessment by conducting interviews with partners and experts who participated in the stakeholder consultation process, which was performed under Work Package 2. With the help of our partner and subcontractor, Ehds-Ai. So the evidence and the results from the interviews, it shows that the deliverers, they represent a technical, coherent foundation for the implementation of the EHDS, of course, but there's still work that needs to be done. We have also determined some factors of success based on the interview results. First of all, the establishment of a stable European-wide semantic governance framework was mentioned quite often in the interviews. Second, the transitioning from the voluntary-based MyHealth.eu infrastructure to the mandatory infrastructure under the EHDS was also one of the success factors which was derived. Also, a clear migration and phasing strategy was often mentioned, with a stepwise approach instead of a big bang rollout towards the end of the implementation phase of the EHDS was one of the wishes. And last but not least, of course, transparent and iterative stakeholder engagement with the integration of stakeholder feedback into the outcomes in a very transparent way. So based on those interviews and our work, the results show that the deliverers could significantly reduce fragmentation and strengthen the European digital health ecosystem over the next decade. The deliverers, they provide a solid output and the groundwork for the interoperability across Europe. But of course, the realization depends on governance decisions and implementation effort and support beyond the project scope. However, deliverers have the potential to make this significant contribution with a lasting impact that we wish to achieve. Thank you very much.
My XTHR colleagues have already touched upon dissemination activities and also mentioned the thousands of comments. So I'm just going to provide an overview of XTHR dissemination activities and achievements. Key elements for XTHR dissemination and to ensure a broad visibility and continuous interaction with stakeholders were the XTHR website, social media, and participation in events. The XTHR website informs about XTHR objectives, outcomes, deliverables, governance, and also it's integrated with the artifacts and education platform, and this enables a transition from conceptual specifications to practical implementation and capacity building. The XTHR LinkedIn page was a key element to disseminate the XTHR activities, participation in events, also about collaborations and announcements of workshops, and active participation in high-level events, conferences, workshops from similar EU initiatives, and also participation in national stakeholder events were key to engage with target stakeholders and to ensure and raise awareness of the XTHR joint action. There's okay. After raising awareness, we engaged the stakeholders in a dialogue. So we asked them to share their perspectives and to contribute actively with their expertise to the joint action. So we turned them into partners of the joint action. And central achievement of XTHR was the large-scale and systematic involvement of stakeholders in the targeted stakeholder consultations. There were stakeholders from 28 countries involved, and in 12 workshops with all stakeholders, we introduced the XTHR deliverables that were shared for consultation. XTHR deliverables were shared, and then stakeholders had the opportunity to provide comments on the deliverables, and these comments were collected, and a lot of work was done by all the work packages to integrate the feedback received into the revised versions of the deliverables, strengthening the alignment of the content across countries and stakeholder groups. Another central aspect was to open a dialogue with stakeholders, developers, and academia, bridging policy, technical, and academia perspectives, and fostering a shared understanding. Key activities included the work of the EHR in EU Medical Curricula Working Group, clinical consultation meetings to gather feedback from clinicians, and the XTHR Projectathon to open a dialogue with developers for practical implementation of XTHR results. And a third key element were the coordinated activities with related EU projects, ensuring consistency and synergies across projects. The cross-EU project alignment enabled XTHR to bridge the specification development with the practical implementation, real-world testing, and also with ecosystem alignment. And to conclude, Okay. So XDHR has moved beyond raising awareness and dissemination to actively build the conditions for implementation through a structured dissemination strategy and continuous interaction with stakeholders. It was able to ensure that the outcomes are not only technically sound, but also understood, validated, and applicable across EU member states. So it has achieved a major thing, creating a shared implementation mindset across diverse stakeholders, countries, and domains. And it practiced not only cross-border cooperation, but also new friendships were formed across different member states. Thank you.
Thank you, Anne. Certainly there are more things to say. As we said the day before, yesterday, we had the presentation and the final ceremony of XDHR, where we presented all the work packages in detail and the collaboration. Today was just to give you a flavor, not work package presentation as such, but a flavor of the XDHR across as a joint action conclusion. So more to see in the website if you are interested. And we're going to start now the discussion, or continue the previous discussion, and receive questions and comments from you, and of course from the panel. If there was something you wanted to say and I interrupted you, you can take the floor now. And of course, it goes without saying that the online participants can ask us and make comments, and we can answer. Thank you.
Can I make the question for the online audience? Is it okay?
Yeah.
Can I make the question?
Yeah, of course.
Yes. So what will the conformity assessment look like for medical devices that claim interoperability with EHR systems?
Conformity.
Conformity
wants
assessment.
To take
Who wants to take?
You can take the microphone there.
I will try. Yeah. We were asked to clarify this several times by different stakeholders, and I fully understand why. I can express my personal opinion on this, but we are not the ones who can interpret the regulation. So I would expect the answer to be clearly formulated by lawyers, maybe, because if we would implement or expect that every device, let's say a laboratory device, is actually in an EHR system, it would mean that they would have to communicate using the exchange format. And in practice, that would destroy the market. That's my simple answer, and I think that the aim of the regulation was to create the interface for humans, for access of the patients to their data, for access of the professionals to the data of their patients, not to somehow regulate also the way how, for example, medical devices are communicating with information systems. However, if those devices have a software component, such a software component most probably would be understood as an EHR system and would have to comply with regulation.
Thank you.
Thank you.
Exactly, this is clear. If a medical device claims interoperability with an electronic health record system, they have to satisfy the same requirements for the harmonized components, for both harmonized components. So this is clear, I think.
All right. Do you have any other question online? No?
The member states have an obligation to establish the market surveillance authorities in the next couple of years that will monitor the compliance on the member state level. So that's also something to take into consideration.
say something? Alexander.
We covered that one, but I think I saw a hand raised somewhere there.
Yes, Andrea.
Hello, everyone. So my question is, do you think that the exchange format developed by the joint action will affect the way end users interact with EHR systems? So with your experience with current EHR systems, do you think that vendors will try implement this by changing the workflows of users, or will they try to find a solution, internal solution, like facilitating, let's say, AI tools to achieve this?
Daniel.
I think it's on now. Yeah. So this will this will be like determined by the actual requirements that are put on the interoperability components of EHR systems. So if there are requirements to, for example, to provide structured and coded data, that data would need to be entered by someone or something. So that would have an impact on the workflow. Now, this is a negotiation between Commission and Member States, and we have not seen the full outcome of that. So I do believe it has the potential to change, hopefully improve workflows, but the exact requirements are still to be determined.
Okay, I think that's a very interesting question, and I think I will pass the floor to Esther afterwards. But I think the important thing here is the discussion about the use cases, the EHDS use cases. So there are a lot of articles in the regulation that are about the patient rights. So we really need to rethink a little bit how we're going to reuse all these artifacts and things that we have created here in the benefit of the citizens. So the discussion about the use case has already started, and I think it's going to be a key component of how this is going to be implemented, of course, giving the freedom to the member states to align it with their national strategy, of course. So I think that's an important thing, and I'm pretty sure that Esther can complement this point.
Thanks, Alexander. Yeah, I think the reason that we gained so much input also from the users was to see how the workflows currently are. So the format should support the current workflows. Nonetheless, there will be a change that's to be expected because the patient is like in the center, and it might be the case that patients are getting more aware when the EHDS is progressing and implementation is going on. So more patients will be aware that they have the right to ask for their data, and that's something that will impact, I think, the current workflows. So there will be more patients throughout Europe asking their physicians to give them their data.
On the same issue, just one more comment. I think we have to move beyond the obligations and what we need to do because the law, the regulation. I think the framework of the European health data space provides an opportunity for the vendors to implement new services. They will give them the power and the input if they have access to the real world electronic health record systems. They will give them the data to provide new innovative services. And I think this will change the way healthcare provision is provided and the services, and it will help the market evolve along with the citizens' rights.
Giorgio, you can use this.
Okay, so just to continue the conversation that I started before about the good approach that EHDS follow for the engagement of the SDO, I think that you have done a very good job so far. The question is how we can go forward. We know that this is the first step. We need to continue. If we want to have something that could be useful, we need to have live specification. It's not just a thing that we can put on the shelf and say, okay, we have done, thank you so much. We have something that needs to be continued updated. And so the question is that, it's a question for all of us. How do you think we can take advantage of the good experience that we have so far? How we can continue to establish this good collaboration with this engagement of the stakeholder in the co-creation of the spec? How we can maintain that? I think that the activity, the collaboration, the tight collaboration we have with IHE Europe, try to not to duplicate things, but try to offer one single point of specification so that people will not be confused about what they need to look at. So it's a question for all of us, how we can take advantage of that good path that we have followed for continue the work about the format.
Thank you, Giorgio. I think Eamon is online. The floor is yours, Eamon, and very sorry not to have you here. Again, we said it. Please.
I know, Professor Christos. Thank you for the floor, and thank you for the invite to be part of this panel. I'm sorry I can't be there, but hope you have a wonderful couple of days. No, just in relation to the colleagues' comment from the floor in the adoption of the format in terms of the workflow. So based on the incredible work of the XDHR, as per Anne's slide earlier in this, the cross-collaboration with the different projects, just to make people aware of the I2X project, which will look at innovative ways that the format can be used by healthcare professionals without placing unnecessary burden on them. In terms of the data portability, as per Anne's slide, there's the XShare project as well. I'd encourage the audience and participants to look at that. And then obviously there's the My Health at My Hands project, which is looking at giving patients access to their information and expanding the My Health at EU infrastructure to encompass the wallet, the EUDI wallet. So those are three projects that are running in parallel that will continue the work of what has been developed here, delivered here within the XDHR project. And then just to go back to an earlier comment as well, if I may, Christos, there was a comment from the floor in terms of readiness of the documents in advance of 2029. So again, based on the huge amount of work that has been done by the XDHR project, the coordination team and the work package leads and everybody involved in the deliverables, just to make people aware from the My Health at EU perspective, the XDHR deliverables will feed into the applicable implementing acts that will happen. Those discussions will happen at the policy level, and the implementing acts will be determined by March 2027. Then from the implementing acts across the, for example, Article 15 dealing with the priority categories of data that was so well covered by our presenters here today, that then will make its way into the My Health at EU infrastructure. So as per the Minister's opening address, there are member states that are operationally live and invested time and resource in cross-border exchange of data. The thing about the European Health Data Space Regulation is we're moving from voluntary to regulation and mandatory exchange of these services. So in a state of readiness and preparedness for what has happened here in terms of all of the information that's been presented, it will make its way to regulation, implementing acts, and then into the My Health at EU infrastructure and the governance groups there in terms of change proposals. So that means then the member states that deploy the national contact points for e-health can test to the specifications at the test events that happen on a yearly basis in order for member states to go live with the services. So that's how the state of readiness will prepare, the chain of events that will facilitate the state of readiness for 2029 patient summary prescription and 2031 in terms of the other priority categories of data. So there is a number of different things that need to happen, and XDHR was foundational in that. Then we moved to regulation, policy, implementing acts, and then the subsequent change proposal within the My Health at EU infrastructure. And the last point I'll add, Christos, is in terms of the vendor preparedness, there is another project which is the support centre for the format. So that is tasked with supporting the vendors in a state of readiness in order for them to be able to comply with the specifications and the testing requirements that will be placed upon them as per the regulation. And back to you, Christos.
Thank you, Thank you, Eamon. Certainly, as you know, we have signed an MOU with the support center. We gave them the draft deliverables already, and we're going to give them, of course, the final deliverables. What I'm concerned about this is that the human capital developed in the joint action is not going to officially contribute to this support center. It is not, if it's a philological discussion, why we're not there. Somehow we're going to make ourselves available to Europe for contributing towards that. Having said this, I was already approached nicely today by somebody interested to see the next steps inspired from my keynote yesterday, and that made me actually very happy to hear that people are catching up, not from XDHR community, but outside the community, and this is very inspiring and encouraging to do this, to go the next step, secondary and primary all together and all this. Do we have any other questions from there? Anybody from the online participants that want to say something before I ask the panel here to conclude? No? Does anybody want to say something? No? Yes? Alex?
Just a quick comment on what Giorgio said. I think the next step cannot be voluntary. It has to be organized from the top or from the bottom. I don't know what's the approach, but for sure it has to be organized. Otherwise, if we keep a voluntary level, we will have more initiatives. And probably that may be good because in the future we may need another joint action, to merge these different specifications, different initiatives, but we can do more things in the future. So I think at the moment it's crucial, it's a challenge to have a structure that will maintain in collaboration with all key stakeholders the specifications and cannot be voluntary.
My comment, because what Christoph was saying is that we have this hard goal, that is to maintain specification for primary use. But we need to keep in mind that we are not isolated, and the work we are doing needs to be reusable for the secondary use as well. And this is also important. And how to guarantee that? We try to do some initial work in the cancer space, try to define a common cancer model that can set up some minimum data set that could be used for primary and secondary use. But I think that this kind of approach needs to be also adopted for other domain, and so they understand how this can be taken account when we are working for the primary use.
Yes, Alexander.
I really want to emphasize what Professor Schizas mentioned about the human capital, because you saw our little roadshow here and how we are, even with one chair less, we still manage to do the work correctly. I think this is something that we need to find a way to continue. So that's a good, let's say, good result of the project, that at the beginning it's about human interoperability. All the rest will follow. If we manage to work as a unique group all together, I think that we are going to achieve much, much more at the European level if we do that. And I would like to emphasize on what Giorgio said. So we have introduced the concept of a little bit this bottom-up approach, talking with the stakeholders and especially the SDOs. And this is an open forum when everybody can contribute, and then their voice can be raised to the whatever decision-making process that will be finalized under the new EHDS board, so that whatever specifications are created, at the end of the day, there will be still European specifications under the new regulation.
Thank you, Alexander. Yes, Hinek?
Oh, okay. In order. So in relation to the human capital, so there are groups. We are in a state of transition now from the voluntary system and the health network Iman was also referring to this, but to a situation where we have a EHDS board. And there is work now in setting up the new governance structure, and that would include groups, hopefully groups of experts, likely with a high overlap in individuals between extended EHR participants, and that is to be seen. And I think going back to the question about the impact, it is a political decision now. So extended EHR has provided like expert opinion on this, but now it's it's a political decision from the Commission and the member states, and like not like trying to rain on the parade, but we do have like the healthcare systems in the member states are struggling due to the demographic pressure, etc. So we need to, and there are alternative, like we have neighbors not as friendly as we like them to be. So we need to really show that what we can provide with the solutions proposed by extended EHR would actually benefit the healthcare systems, make them more effective. So that's and that's, I guess, up on the community to show that. For example, by aligning primary and secondary use. Thank you.
Hinek?
Yeah. Okay, so there is one aspect that I would like to mention. We have now the specifications on the table. So the real fun starts because we are now going to implement it. And the member states were participating on specifications, some of them more active, other member states, let's say, less active, but all the member states should be informed at least. But between those member states, there are huge differences. Some of them already have started with the implementation. And the first step of the implementation of these standards is to make them adjusted to the country needs. Other countries are still waiting, have not yet started doing anything in this respect. And I see one gap in this ecosystem. While the Commission created the support center for the suppliers of the information solutions, I don't see a clear support for the member states and their projects and their plans. But if they will not give enough support, they will not be able to fulfill the role that EHDS gives them. That's the duty, to ensure that patients will have access, physicians will have access, proxy services will work. And that's one doubt that I see from my side.
Thank you, Hinek. And finally, the last scene of XDHR will be played this afternoon at 2 o'clock. It's a room upstairs where the medical curricula session will take place. Irene is co-chairing this medical curricula session, and she can inform you a bit about. We're going to have people from abroad participating, and it's an exercise that XDHR has taken to educate people from the beginning. It's a very important and significant exercise to be done, and I invite you to participate and give your contribution there. Tell us, Irene, something about.
Thank you, of course. Yeah. Having said and done everything in XDHR, it's very nice and it's hopefully implementable. But after doing that, we need to inform medical students what they're gonna find in 10 years when they finish their undergraduate studies. So today, we're trying to build some themes just to incorporate at the European level what a new framework needs to be done and shared throughout the medical schools in Europe. So hopefully today we'll have a very nice discussion and some consensus.
Thank you, Irini. Andrea, do you want to say something at the end? Nothing. Okay. Hey, have a question.
We have Tapani Pija online who would
Finland.
like to say a few words. She was the head of unit in Sante in 2018. So we'll put
it is online. Yes.
Yes,
Happy
Mrs.
to have
Tapani.
you, Deepak.
We will give her 30 seconds.
He had a long career in the European Commission before, and we'd like to hear what he wants to say. No?
She's in the other link, in the online audience, not in the presenters link. So I think we're not able to get her online.
No.
No?
Okay.
Okay.
Well.
Okay. Can you send her the link, Mario?
For the next session, so we can conclude this session. And thank you very much, the presenters and you. And it's time for coffee.
Enjoy.
Okay, thank you to all the speakers for this insightful session. We'll break now for coffee and we have to be back by 11:10. Shorter coffee break. So people online, please go and grab your coffee and we'll meet you then. Thank you.
Okay. Thank you.
1, 2, check. 1, 2. Can you hear me on the stream? 1, 2. Hello. Stream test for the audio. 1, 2.
Can you hear me?
I'm just wondering if you can hear me now. I have an external mic.
Yes, we can hear you now. Can you hear me?
Yes, I can hear you now also well.
Brilliant, thank you.
So hello everyone, welcome back. We are moving now to our Plenary 6, Secondary Use of Health Data Insights from TechTask 2. Before we start, we will have online Mr. Let me pronounce it right, Tapani, to give, to say a few words. So, do we have Mr. Tapani online?
Yes, you do.
Hello and welcome.
Hello and good morning. My name is Tapani Piha, and I used to work in DG Sante as the head of unit responsible for digital health from 2012 to 2018. And I was listening this morning's session on the advances and the results of EHR joint action, and I was amazed. You have done by now some of those things that we were dreaming of in 2018 in the eHealth network. At that time, of course, we didn't know that the COVID is coming, and it's propelling all the development much faster than we ever thought in our dreams. Because, of course, the COVID pandemic had two results. One of them was that the digital health and telemedicine became a must for all health systems, and it also resulted in that the EU health policy got much more resources. I would like to say three things which I picked up from the presentations. One was on the communication team. The communication team was emphasizing that it was not only communicating the results, but also creating attitudes among member states and among the population, among healthcare professionals. And I fully agree that this change in the mindset is so important. I also was happy to hear that many friendship has been created. I myself realized that there was many friendly faces, Anna, Vanya, and Georgia, who were speaking in the morning session. The second point, which I would like to emphasize, was that there was mentioned that the results of this EU-level policy action are not only for cross-border change, but they are also for advancing national development. And I think that is one of those important things we see in many EU policies. And the third point is that I would like to congratulate the working group on sustainability, because those few recipes that you gave this morning, if your recommendations can be followed, I can see that this project will go ahead and be implemented in member states. And indeed, I would like to finish by congratulating Professor Sinas and the CISAS and the whole team for such a remarkable success. Over to you.
I will give the floor to Professor Schizas if he wants to say something to Mr. Tapani.
Thank you, Professor. I don't usually reply to positive comments and congratulations, but such a comment from a person with a huge experience in the European Commission affairs is taken as a very true compliment, and I thank you very much for your kind words, and also for the collaboration we had with Finland in this project. And I extend your comments and congratulations to all the team of XDHR, and I hope we will collaborate in the near future, struggling to promote the EHDs across Europe. Thank you.
Thank you so much, Professor Schizas. Okay, let's move on to our next plenary now, Plenary 6. This session will explore policy guidance and stakeholder perspectives on the secure and ethical ethical reuse of health data. Please welcome Naomi Wari, the Finnish Innovation Fund Sitra from Finland, and Sofia Peltola, the Finnish Innovation Fund Sitra, also from Finland. Thank you. Please take the floor.
Thank you so much, Melanie. Welcome also on our behalf to Plenary 6. In this plenary, we'll be focusing on the secondary use of health data and the work of the joint action towards European Health Data Space 2, or in short, Tehdas 2. So now you all know what the acronym stands for. On behalf of the entire Tehdas 2 consortium, we would like to thank the Ministry of Health and National eHealth Authority in Cyprus for inviting us to host this plenary and for showing us great hospitality during our stay in Limassol. We also want to congratulate the Cyprus EU presidency for this important and very topical conference. We are Naomi Vuori and Sofia Peltola, and we both work in the Tehdas 2 Joint Action Coordination Team. We will be guiding you through this session, and in this session our project partners will be presenting the work that has been done in the project. And in case you're not familiar with what Tehdas 2 is and what we do not worry, you will hear more in a little while.
As we heard from the Minister of Health earlier today, the EHDS legislation is only the first step. And with this Tehdas 2 joint action, we develop practical documents and guidelines, technical specifications that support the use of health data in line with the European Health Data Space legislation. So our goal with our work is to strengthen the preparedness for implementing the EHDS, reduce fragmentation in the secondary use of health data across Europe, and also support the European Commission in drafting the implementing act to support the EHDS legislation.
And in this session, you're going to hear short presentations of 7 draft guidelines that will soon be open for public consultation. We'll also hear short comments from representatives of our key stakeholder groups on each guideline to warm us up for the upcoming public consultation. But before we jump into these guidelines, we want to welcome our colleague Elina Drakvik, who is the project lead of Tehdas 2, to the stage to give you a brief introduction to the Tehdas 2 joint action. Welcome, Elina.
Thank you very much. Happy to be here today and talk about Tehdas 2 joint action. I will provide you only a brief overview because the focus of this session will be on the draft guidelines that we opened for the public consultation next week. So my name is Elina Drakvik, and I'm working as senior lead and project lead at Sitra, the Finnish Innovation Fund. Thank you for the introduction, Sofia and Naomi, and happy to represent the Tehdas 2 coordination team here today. I also want to thank on my behalf the Cyprus EU presidency for hosting this conference and bring all the different stakeholders and actors together, both here on site, but also online. So I will talk briefly about the timeline of Tehdas 2 as we are approaching the finishing of the project at the end of this year. I will also talk briefly about the status of Tehdas 2 deliverables, public consultation results, and then how you can be involved in the project and how you have actually already been involved in the project, because your voice matters. So, as Sofia was saying, Tehdas 2 is producing these concrete guidelines and technical specifications. They are aimed for health data holders, health data users, and most of them are for health data access bodies. So in these guidelines, through these guidelines, we are really preparing the ground for the implementation of the European health data space, and our focus is on the secondary use of health data. So Tehdas 2 started in May 2024, and now, at the end of this year, we are going to finish the project already, so time flies. But a key part of this project are these public consultations. So we really want to hear from you, because we know that through your input, we can make these guidelines and technical specifications more feasible and more relevant. And as my colleague Sofia was also mentioning, these Tehdas 2 guidelines and technical specifications, they provide input for the implementing acts that the European Commission is currently drafting. So very important work. And it's also good to celebrate what we have achieved already at this point of the project. So in January 2025, we had the first Tehdas 2 public consultation, and 4 documents were open for consultation at that time. And last fall, we had second public consultation where we had 11 documents open for consultation. And now next week, we are approaching the third and final public consultation, as we will have 7 draft guidelines there open. So this is a very busy slide. I will try to guide you through it. I'm not going to go in detail to all the different guidelines that we are producing in Tehdas 2. But the main focus is here, of course, that during the Tehdas 2 project, we are actually going to be delivering 21 different guidelines aimed for data holders, data users, and health data access bodies. And here we have mapped these guidelines along the different steps of the EHDS user journey. So moving from data discovery to data access, data preparation, then use of data and analysis in the secure processing environment, and then finalization of the project. So what is important here are actually the color codes. So these hexagons, for example, the dark blue hexagon, this means that these guidelines have been already published and they are available on our website. So please take a look at those if you are not already familiar with them. And then the light blue hexagon icons, that means that these guidelines are finalized, but they are not yet published, but they are about to be published soon. So in the coming weeks, we will put them on our website, and you can also familiarize with those documents. And in the focus of today, we have these guidelines that are marked with yellow hexagons. So these are the documents that will be in the third public consultation. So we also have in Tehdas 2 some guidelines that are more horizontal in nature. So they are not only part of one specific step of the EHDS user journey, but more cross-cutting in nature. So you can see them listed here, and here also the same color coding applies. So the light blue ones are the ones that are finished and to be published soon, and then the yellow ones you will hear more after my presentation. So very shortly about the public consultation results so far, based on these 2 public consultations that we have organized. In addition, that we have integrated your feedback as part of the documents and modified the documents based on your input. We have also included summaries as part of the final documents. And one common feature that has come out in these results of public consultation is that many stakeholders expect more specific guidance, especially related to more examples on use cases, but also more operational guidance in terms of processes. So really having hands-on guidance with checklists and decision trees and flowcharts. We have tried to respond to your feedback and taken that into consideration when that has been possible and within the scope of the document. Just very shortly about the numbers. It's always good to look at the numbers. In the first public consultation, we had altogether 350 responses and responses from 15 to 16 different countries. And in the second public consultation, we had altogether around 760 replies, and these were consolidated responses. So actually, the response base has been much broader than what is reflected in these figures. This is my final slide. So, of course, your voice really matters. And a key channel to provide your input is through these Tehdas 2 public consultations. And the third public consultation now will be open from 5th of May to 28th of June. And we have also organized 3 stakeholder work forums. So first one in Warsaw, second one in Copenhagen, and this one, now third one, as part of the EU Presidency Conference here in Limassol and online. And I think 3 is really the number here. We can see that we have also organized 3 topic-specific workshops. So one has been on ethics, one on collaboration, and the most recent one on IP rights and trade secrets. We've also had some ad hoc consultation, and in some countries we also organize meetings with the national expert groups to bring the local and national stakeholders together. And we are very happy about our wonderful external advisory board, who can even amplify the reach of Tehdas 2 more. And a final point, we are organizing as a bonus a final conference in November in Brussels this year, and we will share more information about that when the date for that conference is set. But we are, of course, happy to collaborate this joint journey with you, as has been highlighted yesterday and today. So we are really building the EHDS implementation together with all the different stakeholders involved. And you can follow us through our website and LinkedIn. And if you have some time, feel free to also participate in our evaluation survey. So you can find the QR code there in the bottom. Thank you very much.
Thank you, Elina, for providing an overview of the joint action. So without further ado, let's start with the guideline presentations. First up, we have Beatrice Barroche from Cienzano, who will present the draft guideline on a framework for collaboration. Welcome.
First of all, good morning. As Sophia pronounced very well, my name is Beatrice Barros. I work for Cienzano, Belgium, and I've been leading the work in this task very proudly. And today I'm here representing the great team that has been working in this document on our draft guideline on a framework for collaboration. Let me change. And so the question that guided the work and our discussions was really where in the secondary use workflow we need collaboration models and how can they be established and implemented. And as we already know from the document in Tehdas 2, of course we don't have a simple and clear answer to this question. It would be great, but we did try our best to provide very actionable recommendations and guidance on how to move these discussions further and how to identify real concrete action points for us to move into the implementation with this collaboration framework in mind. And so we target here a lot of different stakeholders. And this was actually a big part of this task that I wanted to highlight. It was not the usual task when we are 10 people really focused on a topic. We actually, through a lot of stakeholder engagement, extended the participation in this task to hundreds of people through the workshops that Elena just mentioned that had a lot of participation, through also a landscape analysis, through a big survey that we conducted, also very targeted interviews to refine this content. So we really were able to get a lot of rich feedback, and we hope this is now very well represented in this guideline. So in terms of content, as you may imagine, when we talk about collaboration, we could go through so many different angles because it's really a big topic and is so essential in the EHDS in very different layers. But in this work, we managed to have two key ways of looking into collaboration. So the first was based on specific topics, and here we focus on discussing challenging points where we see collaboration will be really essential. And we started by discussing ethics and how to establish an ethical governance framework. Then we also discussed collaboration mechanisms and models to make it work. And now in the last workshop we discussed how to safeguard intellectual property rights and trade secrets in the EHDS. And now you will find in the document the insights that we collected from all of the stakeholder engagement that we conducted, and we organize it as we always reflect on the key perspectives from the different stakeholders, because they do really have different perspectives on these topics, and that's what makes these activities so interesting. We also reflect on the challenges. We identify the key challenges in each one of these areas. And very importantly, we try to use all of these to set guidance and recommendations on how to move forward in this discussion. So this is the structure you will find for each one of these topics. Then in the second part, we looked into the stakeholders, and here we focus on very specific stakeholders, the research infrastructures, EU networks, and European projects that we already have in the health data domain. And here we were looking and working closely with ERICS and EDICS and different big initiatives that we already have, also with European reference networks, healthcare providers, so we really try to put a lot of representation and understand what is the landscape that we have now in the health data domain that shows us what type of services and functions are being provided to the reuse of health data, so we can learn from this experience and these infrastructures. And we also try to do the exercise of mapping this to the EHDS user journey that we all know for secondary use, and what, based on these, are the roles and engagement pathways that we can create here for this collaboration. And we also finish this with actionable recommendations to really build synergies and collaboration opportunities here with these different stakeholders. And so we highlighted here 3 key topics to further develop this guideline. The first one is, of course, a call for more feedback. We really want to extend now all of this feedback that we already collected through the public consultation. And our goal was really to provide very actionable working points, but we also want to understand, are we reflecting the complete picture of the challenges and opportunities? Do you see in your experience, in your work, other challenges, other opportunities, other ways to look into these problems? This would be a very important feedback. Also, when I talk here about research infrastructures, we hear a lot informal discussions. This is a very structured way to provide feedback, and this was a part of the work. We put a lot of effort into translating everything that we hear in the feedback into very concrete topics. So this here would also be very important to collect the feedback. Then the second point, I would highlight the amount of recommendations that we make in the document. We really always try at the end of each part of discussion to have actionable recommendations, and the goal is for them really to be actionable, so to really provide a direction and specific points to help us understand how to deal with these challenges and establish these models. So here it would also be important to understand from the implementation point of view, does these recommendations provide enough guidance? Do they need to be more granular? Help us hear a bit in the feedback on the practicability of it. That would be our main goal. And then I would also take the opportunity here to highlight one of the best lessons learned that we had in these exercises, which was really the amount of expertise that we have in Europe. And we saw during these days the amount of projects and infrastructure and best practices and knowledge, really shared knowledge that we have already in the health data domain and reusing data for research. And so this is something that I want to share because it was very enlightening to us to see here the tremendous opportunities that we have with the EHDS in secondary use to combine all of this knowledge and to have a space where we have joint discussions and we can leverage all of these years of experience and best practices. And so these would be the key points that I would highlight for us to move forward. And I hope with this that I was convincing enough for you to engage with the work that we have been doing, because that's the only way that we move forward, and to also share this with your member states, with the research infrastructures, with the different projects that you know in your countries, because we hear a lot about collaboration, we hear a lot about research infrastructures, and this is the channel to do so now, is where we are concentrating our efforts and really trying to provide very actionable ways to move forward in an harmonized way. And so I invite all of you to participate in the public consultation of this work and to help us move forward. And I also, just final words, thank to all of the people that were involved on this, not only the great team that I have with me working on this document, but also the amount of people that participated in our activities, and is truly reflected this rich engagement that we had now in the variety of contexts that we were lucky to have to work on these topics. So it was really a collaborative working model, and I hope it continues like this with the public consultation. So thank you so much. This is our guideline.
Thank you, Beatrice, for both providing a very interesting overview of the guideline and also all of the work that has gone into it, all of the preparations you have done to get to this point. From frameworks of collaboration, we will now move on to the next guideline. That is the draft guideline for health data access bodies on international and third country access and transfer of electronic health data, a very long title. This guideline will be presented by Fidelia Cascini from the Catholic University of the Sacred Heart. Please welcome Fidelia Cascini.
Good morning, everyone. It's a pleasure to be here. I'm Fidelia Cascini from Italy, and I'm very happy to see so many familiar faces. In this task, I involved in TDAS as the task leader, but I'm part of this very small but warm European family working for the implementation of the EHDS with several institutional cooperations and activities. So, what is the situation regarding third countries? We elaborated this guidance focusing the attention on two challenges. The first is related to the balance that HTAPs has to find in protecting citizens' rights, at the same time facilitating the access to data of the European citizens. So this is one of the most important activities that the HTAP has to face in the next years once will be open the access to the third countries and international organizations. The second challenge is that we found is related to the fragmented situation at the European level, because member states are using currently different approaches, especially after the interpretation of the GDPR in accessing and transferring data. So there are different rules and safeguards and requirements that are requested right now, and we explore these through a survey. What is the value of the guidance that we provided? The value is that we will make available practical recommendations for the HTAPS officer in approaching this kind of issues, and especially regarding two pathways. The first one is the authorized participation. So when a third country will be part of the HDS framework as an authorized participant according to the regulation and starting from 2035. The second pathway is related to reciprocity mechanism that could be implemented right now, so very shortly in time, and immediately after the availability of the implementing act. Further, the guidance explores the value regarding the interaction with the GDPR because EHDS add additional safeguards to the GDPR. It's not something that substitutes the GDPR for sure. So the main elements in the guideline, for sure the articles which are relevant in this context, which are the 75, 87, 88, 90, and 91. The evidence that we collected exploring the situation, the current situation at the member state level through the survey in terms of what are the ways that countries are currently used to exchange data or to permit the access to data at the European level, and the possible scenarios, so authorized participation and reciprocity mechanism. What could be the transfer and storage rules involving, for instance, SPE, which are located outside the EU, and also interdependencies with other TIDAS2 guidance, because this is an horizontal guidance because the access to data is something which is referred to many other requirements from the HDS regulation. So in this guidance, you can find also interdependencies with other deliverables. The pathways, the most important development of the guidelines are so the definition of the pathways, the integration of the third country as part of the HDS and the health data at EU infrastructure through the mechanism of the authorized participation, and that we will start from 2035, and the reciprocity mechanism under the Article 91 that will be shortly provided through the publication of the implementing act. Then we analyzed the safeguards because there is a need for further evaluation of the safeguards that the HDS can provide as an addition to the GDPR already existing safeguards, but also what could be structured technical and organizational measures that member states have to implement to guarantee the protections of their own data, health data, once a third country or an international organization is interested to access them or to transfer them. And finally, we need to find an assessment on and consistency on the criteria that are useful to create the reciprocity mechanism, especially when we talk about transfer of data, not only access to data. So the consideration at the end are that the recommendations provided in this guidance are not binding for the member states for sure, but they are useful for experts and for HTAP officers when they will deal with this kind of matter related to the access and transfer of EU data for third countries, and how they can manage the implementation of additional measures to complement and to make additional safeguards to the existing rules referring to the GDPR. And finally, it is useful that we can, through this guidance, to follow up in the future what could be the advancement of the member states in facilitating this exchange with third countries and international organizations, facilitating also an integration of this guidance with experiences, best practices, and an harmonization between the member states in approaching this matter. So at the end, as for other guidance, the call to action is please contribute with your comments with the integrations or suggestions through the public consultation, because this guidance will be very soon available to collect all your impressions and suggestions. And for the future, we hope that we will find a really harmonized solution at the European level, which is currently a challenge, especially comparing access data and transferring data towards third countries. Thank you very much.
Thank you, Fidelia, for this very insightful overview of the draft guideline. So next, we will hear from our stakeholders. I have the pleasure of welcoming first to stage Stamatiki Kritas, who is manager of Hellenic Biocluster and communication leader of the Innomed Catalyst project. He will give a front row comment on the draft guideline on a framework for collaboration. And then after that, we will welcome to the stage Gianluca Violante, Senior Manager for Digital Health Policy at Digital Europe, who will provide a comment on the draft guideline on international and third country access and transfer of electronic health data. But first, welcome Stamatiki.
Good morning, everyone. I wrote this down so I can actually be within the 2-minute framework. So thank you for this, for the comprehensive and well-structured draft. I'm speaking on the perspective of clusters and innovation ecosystems, and we strongly welcome the emphasis on collaboration, especially across such a diverse and multi-stakeholder landscape. The document rarely highlights fragmentation, uneven capacities, and the complexity of the multi-country challenges that multi-country processes that are the key challenges. From our standpoint, clusters and innovation ecosystems are already operating as the connective tissue between the industry, academia, healthcare providers, SMEs, everyone who is actually involved in the data health space. This intermediate role could be more explicitly recognized and leveraged within the framework. First of all, on collaboration models, we suggest strengthening the role of ecosystems as facilitators of early stage engagement, particularly in data discovery and feasibility phases. Clusters can help translate needs between data users and holders, reducing the insufficiencies that the document identifies in multi-country applications and the fragmented processes that you have identified. Secondly, regarding capacity and support, the draft acknowledges uneven preparedness across member states. Hence, again, clusters. Every member state has multiple clusters, so please use us as a scalable support structure, especially for SMEs and smaller data holders, but providing guidance, training, share activities. We are here to actually support that. This aligns well with the need for practical tools, templates, capacity building actions that you have highlighted in the document. And lastly, on innovation and IP, the balance between protection and usability is critical. Clusters can support trusted environments for pre-competitive collaboration, helping to de-risk data sharing while enabling innovation. And this is particularly relevant given the concerns of IP protection that have been raised. Finally, we encourage a stronger recognition of existing ecosystems and infrastructures. The document already notes that many capabilities exist across research infrastructures. Clusters complement these by bringing market uptake, scaling pathways, cross-sector integration, which are essential to translate the EDHS into real innovation, societal value, and scaling up, what we have been discussing yesterday. So in summary, we see clusters not just as stakeholders, but as implementation partners. And I can say that as Hellenic Biocluster and Inomed Catalyst and the Council of European Bioregions, a network of 50 clusters across Europe, we're here to support you. So please utilize us, reach out, and well done on a great document.
Hello, good morning. So first off, thanks to the presidency for the great event, and also to Ehds-Ai for the opportunity to do this quick reaction to the document, and of course to Professor Cascini for the overview of this important deliverable. My name is Gianluca. I represent Digital Europe. I cover our healthcare policy at the association. We are a trade association representing broadly the digital sector and digitally transforming industries. And we also have, of course, companies that operate in the medtech sector, pharmaceuticals, EHR providers. So we look at the whole EHDS with very much interest, both from primary use side, but also on the secondary use. Of course, this deliverable is very crucial and very aligned with what Professor Cascini was saying around the need to have a harmonized standards across the EU to avoid fragmentation. Because of the short time, I will just focus on two main points that I think are quite crucial. And of course, we will be responding with more in-depth analysis or comments. But the first one is the concept of the equivalence for reciprocity, for international access, for authorized participants in third countries. So this is, the document introduces quite an interesting idea or a good concept of equivalent level of protection, but not necessarily the same for granting this reciprocity. And indeed, this sort of, there could be further expansion on what exactly these criteria for, this concept of equivalence actually mean in practical terms, to ensure that, in fact, there isn't different standards applied across member states. And the second regards the international transfers of personal data. Of course, the guidelines refer to Article 90 of the EHDS that allows member states to include or additional protection measure, additional conditions. Of course, as mentioned, it would be quite helpful to have a harmonized approach here, so to ensure that international research can be can proceed in a coherent way, and because of course having different standards across member states might cause a level of fragmentation, and for instance, in multi-country access, that could create difficult dynamics in practice and make it more complex. So perhaps a way to do it would be to have an HDAP that is sort of assigning a coordinator role in this multi-country access that involve third country transfers of data, so that there is one standard applied. So this could be an idea that we could further elaborate in our consultation response. And finally, on a couple of, just one last point on the some of these points will, of course, be further clarified in the implementing legislation. So it will be crucial that the HDAPs and the member states, of course, look at the implementing acts and avoid sort of a gold plating of additional national measures to again avoid fragmentation and provide legal clarity for both users and holders. So yeah, that's all from our side for this additional and quick comment. Thanks again to the whole TEDS team, and yeah, we will be providing further clarity in writing in the consultation process. Thank you.
Thank you to both of our brilliant front row commentators for providing us with valuable stakeholder feedback. As our speakers emphasized in their presentations, feedback like this from the stakeholders are crucial to help us improve the usability and feasibility of our guidelines. We'll now continue with the guideline presentation. Our next speaker will actually present 2 draft guidelines. First, the draft guideline for data enrichment, and then the draft guideline for the data user navigating the catalog. Please welcome Anna Niemeyer from the Technology and Methods Platform for Networked Medical Research in Germany to the stage.
Thank you so much for your warm introduction. And my name is Anna Niemeyer, and I'm now going to present, first of the guidelines, the guideline on data enrichment for secondary use. And this is facing a lot of challenges in the beginning, and I want just emphasize a few of them. And what was our aim and a challenge as the same way was that it is more and more important in the science research to think about enrichment procedures and to getting data together, not only in terms of a linkage, but also in getting different sources together. So it was a tremendous goal to support reuse of data enrichment. And this was mentioned in the recital 57 of the EHDS regulation, but not defined in an article. So enriched data set derived variables and intermediate outputs contribute reproducibility and transparency to cumulative knowledge generation. The challenge, the ambiguity of the regulation and the not specific obligation and no mandatory workflow management leads us to give here a structure and try to provide a framework that can be used as an orientation. This is because the competence to regulate these processes is in the member state competence. So it is very important to have a more general and standardized procedures to omit the risk of fragmentation. That without a common framework, there's an enormous risk that inconsistent national procedures could not only hinder cross-border interoperability, but also the reuse of enriched data set at all. So the first value of this guideline, and we hope we get your feedback on that, is that we provide a shared understanding, explaining when and why data enrichment is valuable, and illustrating how it could be integrated into EHDS secondary use framework. It provides a non-binding, this is non-binding, the competence for the binding regulation is to the member states, but we try to make the bottom of a common understanding and for the harmonization. And so we have propose an exploratory framework to encourage consistent procedures across member states, supporting a coherent and interoperable EHDS ecosystem. And also, coming back to what Elena says, the practical guidance, we try to clarify what data enrichment is, where and when and whom it can occur, and the secondary use journey, and we provide some illustrative examples. We collected them from the expert groups we're working with and derived governance and technical considerations from that, as well as the key challenges we identified for implementation. So what's the main elements of the draft guideline? And you see here we tried a flow chart to help you to orientate on the different possible pathways that could occur. And first, we decided between, or we differentiated between the internal and the external data enrichment. Internal means the enrichment comes by the types of operation. So we have derived analytics, and on the other hand, the external is via defined external data sources which can be used for enrichment in the SPE. But the most important thing if you do some enrichment is to communicate what you did, to make it transparent and reusable at all. And this may necessary to define feedback components and loops. So we were envisioning three pathways. The first one will end because the enrichment is just only project specific and there's no value for communicating it, and so it ends there. The second one will be, we suppose the most common one should be used, and this is driving the algorithms and the description, standardized description of the done algorithm, and forwarding this in a regulated way to the HDAP and then back to the data holders so that the enrichment is reproducible. And the third pathway we think will be not so much used, will be the giving back the enriched data set in some specific aspects, so to reuse them by the data holder, which can only be done if this is finally regulated. Following these concepts of the conceptual understanding on one hand and the possible communication on data enrichment, we derived some governance and legal and operational consideration and trying to answer questions how enrichment can be integrated into governance, technical frameworks, including key legal aspects, sharing outputs and practical operational elements such as documentation and infrastructure. So what is left? What's needed now? What we need is standardization of communication, and this is something we want to know from you as a stakeholder group. So help us exploring options for standardization, standardizing communication regarding enrichment, which fit-for-purpose mechanism, and we should also be integrate and look at the quantum project, how we can derive some experience and insights from them. What we also need, and this is something we should always take into account, that if I do data enrichment on a data set, it's a lot of effort, and if I then provide the results for reuse, why should I? How could this be incentivized, and how could my work as a researcher be recognized by the community? So we need some kind of appropriate recognition and incentives and clear expectation for data users contributing the data enrichment because of their work, and we have to value it. And again, here the open question to the stakeholder group, please provide us with examples of and governance approaches to handle this. We already have some examples in the guideline in the end, so it's worth to read the appendix too, to illustrate how this could be handled and what our successful approaches can be. And of course, we need more of them to derive then standardization of communication and future approaches to data enrichment. So please have your say. help us to get more concise on this guideline and help member states to find a way to regulate data enrichment in a way that data users are motivated to do enrichment, internal and external enrichment. And of course, we want to know if are the proposed pathways, as well as the legal, organizational, and operational considerations, including the role as intermediaries from the EHDs, are feasible. And yes, thank you so much for helping us with it. The next one, and I just breathe a little bit, is the guideline for navigating the catalog of the health data at EU Central Platform. And this, why? We are all used to portals and dealing with surfaces or interfaces of software every day, but still, this is coming up something really new. And the challenge is to get all the people, not only us, but also scientific researchers, politicians, industrial researchers, to get to use the EHDs by first navigating the catalog, understanding what they are looking for and understanding what their results are. So the new infrastructures for data discovery, such as the Health Data EU catalog, are really high complex, and they have not only an interface that is getting to use to, but also what is to understand are the results I get from it. The value, we want to provide a non-technical, this is an important point, a non-technical high-level orientation to support users navigating this catalog ecosystem and explain how the catalogs in it are organized, what type of information is available, and how to identify and assess relevant data sets for research, innovation, and policymaking. And then we try to bridge the first contact with the portal until it gets to the formal application process. Well, this is a first contact, and this is a really vulnerable point of the secondary use journey. So what are the main elements of our guideline? We focus on the pre-authentication workflow. We map in a detailed way the discovery phase, covering keyword retrieval, dynamic filtering, coding systems, ICD-10, SNOMED-CT, and for the advanced users, we also explain the Sparkle queries. One of the, very important part of the guideline is the data set record interpretation. So what are the results I get and how to interpret it, how to proceed forward, evaluating provenance, governance, and technical interoperability. Then, to give an outlook on what comes next, we explain a little bit and introduce the basket functionality, which is only available after a formal login. And this guideline, we try to keep it short, but it's still long. And this can be daunting. Every one of you may read already some user manuals, and you really get bored in the middle of the page, and the first one. And so we try to condense everything to a 2-page quick guide, which is, I think, important because how did we get there? We did 11 semi-structured interviews with non-technical potential users of the EHDS health data portal and the EHDS itself. And we just throw them into, just use it, and we recorded how they tried to get along on this guideline. And of course, they struggled several times, and we just identified these points. And well, it was all over the member states at the same points where the people struggled to go ahead. So we condensed this and put it with graphical elements, as you can see on the slide, to just have it as quick as possible on 2 pages. So coming to the further development, so one of the next challenge I have to mention is this is still under development. So we working with a, not with a moving, but with an evolving target, and we several times following the releases exchanged the screenshots in the guideline and described more and less and put it again. So this was just a living document, and it is still a living document because it's the portal will still be under development until 2027, and the next release is just coming in, well, I think a week or 2. So it's still under construction, and you will if you try to go with the guideline through the portal, which I would wish you do, then you may find some screens that not fitting exactly. Just except this is due to the evolving of the portal and of the living document character. And of course, this will be updated after the public consultation, and we really need your feedback to identify if we put the right language, if we addressed the right points in the right way, and if we align also with your expectations of a user guide. And what we would wish for, and most of the users wished for, we talked to, is that the scope of these type of guideline will also tackle other aspects of the EHDS. And I think this is an important wish we should take into account. So it should be possible to give more non-technical instruction, guidance, and support to users who are not so used to use such portals. And of course, it would be very valued by the users if we could do some short videos. So like the younger generation, I know it from my son, that he is only learning by looking YouTube. And so this might be another point we should take into account to get this more common. So finally, again, have your say. It's really, really important. We need you, and it's essential to ensure the guidelines' operational utility within the EHDS framework and to validate the conceptual and linguistic clarity. Please use this possibility to review and respond and share your expertise, and especially on the quick guide. We put a lot of effort to get it on 2 pages, so help us and give us feedback on this quick guide. And thank you so much.
Many thanks, Anna, for presenting these 2 guidelines related to data enrichment and navigating the catalog. That was definitely more than a sprint, perhaps a 400 meters run. So now we would like to welcome our stakeholders to share their initial reactions to these draft documents. First, I'd like to welcome Panayotis Kolios, Assistant Professor at the Department of Computer Science and Chios Research and Innovation Center of Excellence at the University of Cyprus, who will comment on the guideline on data enrichment. And then, right after, welcome Apostolos Dimitriadis, Business Development and Innovation Manager at ICS Forth, who will share his perspective on the guideline for data users navigating the catalog. So first, welcome to Panayotis. Do we have Panayotis present here? All right, so let's move forward to the next front row comment. Apostolos, please, welcome.
Excellent, thank you. If I knew, I would have prepared a longer one. Anyway, it's very nice to contribute back because you're doing a very needed and a very nice work. And speaking also on behalf of Preciseo, the project that we are working, we have actually used a lot of your outputs in our own work in order to be able to provide better guidance also to our future beneficiaries. Anyway, now down to the comments. Allow me also to read. The document was designed with usability in mind, and this is quite evident. It delivers the necessary information it covers all aspects. It's very detailed, and the guidance is helpful, especially for users navigating the catalog, and especially for users that do not have strong technical expertise. So that target was actually reached, and it's very evident. I found extremely useful the inclusion of use case examples that helps the reader understand the functionality of the catalog for different user groups. So again, this is for the benefit of the ones who are non-technical, but in order to further enhance their value, it would be nice to link them directly with practical search workflows, ideally including step-by-step examples and screenshots. I think this is the comment that, the usual comment that you mentioned, Elena, earlier. So we need to link them with some screenshots so somebody really can identify which way they should go. I also found the section on Sparkle queries. I think it could benefit more from a bit further development. I understand that it's for non-technical users, but sometimes people have the examples and try to edit them somehow, even if they don't have the knowledge, and maybe it could be useful for them to have some examples on the Sparkle usage and maybe enrich it somehow. This is more or less what I had to say. Excellent job, thank you. I didn't have I wasn't sent, I think, the quick guidelines, if it's, I haven't seen them, but I think it's very nice to have them, because it's good to have directly the information, and probably a cheat sheet for Sparkle for some most common use cases. That's it. Thank you very much.
Thank you for the front row comments. It's not an easy task giving these concise comments on the guidelines, and we greatly appreciate you making sure that our stakeholders are being heard in the process of making the guidelines. Next, I'd like to invite Justin Ansot from the Belgian Health Data Agency to the stage to present the draft guideline for health data access bodies on linkage of health data sets. Please welcome Justin.
Hello, my name is Justin. I work for the Belgian Health Data Agency. I'm here on behalf of Pia Brinkman, who unfortunately couldn't be with us today. But I really want to extend my thanks to Pia for her really good work as this task lead, but also to all the other contributors of the task, the reviewers and authors. Okay, so the challenge with data linkage is that it's always different on a project per project. So the challenge of this task was to really balance the amount of detail while still providing recommendations that can be applicable for users. The value, yeah, I'm sorry. Also, the challenge is kind of addressing this problem as both a technical issue, a governance issue, an organizational issue. There are many aspects that you need to consider when you want to combine data sets together, when they come from the same data holder, but then when they also come from different data holders. This guideline focuses on combining 2 or more data sets at the individual level, through the use of either direct or indirect identifiers, and even when these identifiers are sometimes already pseudonymized. It offers insights into the possible linkage scenarios and the activities performed by the linking organization, use cases, and provide also templates that can be used by the actors. So the guideline is really aiming at supporting health data access bodies who kind of have this final responsibility of making sure that the data that the user is going to receive corresponds to the data permit. But it also is very useful for data holders when they are the ones performing the linkage, but then also for users, as in the EHDS, they are in the application, they have the possibility to submit a linkage schema, but also just to help them understand the considerations when linking data together. So the main elements of the draft guideline, these are the questions and the structure of the document. So first, yes, why, when, and by whom can data be linked within the EHDS? For this, we try to provide linkage scenarios by mapping the correct stakeholders, the HTAP, the user, the data holder, what happens if it's a trusted data holder, and then what kind of data are being linked. So you will see in the guideline that we organize this with directly the minimum categories of health data from the EHDS to understand which contain individual level data, aggregated level data, or both. How is data linked? This is maybe something that I was very surprised when I first started working on this guideline. In Belgium, we have the national registry number, so we have this very useful unique identifier, but it is not always the case. So the guideline addresses this issue by really stating the different kinds of identifiers that can be used, deterministic direct linkage with unique identifiers, but sometimes also deterministic indirect linkage when you use quasi-identifiers and a combination of these to create this link, but then also probabilistic linkage. A very important aspect when you are combining data together is the quality and accuracy of these linked data sets. So the guideline tries to provide recommendations related to the linkage process and how to assess the quality of the linkage and how to make sure that the data sets that come as a result of the linkage still maintains the expected level of quality, because sometimes it's something that is a bit hard to, anticipate when you are just planning your research, and how to then, once the linkage has been performed, assess the quality. How can role-based access to linkage process enhance privacy? We kind of go over several governance possibilities, for example, with the use of a trusted third party that is responsible for linkage. How are repeated or frequent applications possible within the EHDS? We just heard about enriched data sets, but something that we want to avoid is that we know these are very complicated processes on data linkage, that the work is not just redone every time for new research and you have to well, redo everything. So the guideline provides detailed scenarios, methods, considerations regarding data types, recommendations indeed for role-based access to linkage processes. And if you go through the annexes, I think it's really great because you will find like dataset description templates, detailed EHDS specific scenarios, but also real use case and examples from multiple countries on data linkage. So for the further development of this guideline, yes, the public consultation will open. I think that's maybe the most important. It's really important to hear now from other stakeholders because every researcher has most likely been, facing this issue of linking data sets together. And we want to know about your experience. What was difficult? How did you address this issue? And what do you expect from the EHDS to kind of solve these? I remember hearing about researchers who spent the first 2 years of their PhD just to try to get the pieces together, and linking data sets was very difficult. Quasi-identifiers and minimizing these quasi-identifiers. So when you don't have a unique identifier, a direct identifier, in order to perform the linkage, you might need more variables just to have that link, but then that goes a bit sometimes against the minimization principle of GDPR, so this needs to be properly addressed. And then lastly, the efficient communications between everybody involved in that linkage process. To facilitate the data linkage, it's still very important to have a good communication between all actors. We try to raise the findability of data sets, but still, not everything will be perfect from the moment the application is submitted. Communication is still really key. And we need to make sure that the data access application management system operated by HTAPs kind of supports this communication, and that the user can easily communicate with either the HTAP or the data holder when trying to link data sets. So have your say, participate in the public consultation. The public consultation questions are quite straightforward because this is a technical work package, so we like to be very specific, but you can also provide feedback on one session or one section or another. Thank you for your time.
Many thanks, Justin, for presenting this important guideline. Next, let's move directly to the next guideline, which addresses informing citizens about the reuse of their health data. Please welcome on stage Lorenz Dolansky-Akamanoukian from the Austrian National Public Health Institute.
All right. Hello, everybody in the room and online. Thanks for having me. Yeah, that's me, and a very long title of a guideline. Well, to keep it a little bit shorter, I'm talking about citizen information points. And this is not only about information. Information, well, that's the basic duty that HDEPs have to fulfill. But this is only the basis for creating and enabling transparency in several different dimensions, so to say, which again is the basis for trust. I would say this is not automatically creating trust. This is not like a trust machine, so to say, when you have this information and transparency, but it allows it. It's yeah, prerequisite to enable trust. And if you have that, then this is again the prerequisite for really creating this value that we are talking about and that we try to achieve with this. If our societies don't trust what's going on here, then still, and even if you have the perfect implementation in place and technically everything is working and data flows and data is evaluated and so on, then well, some sort of value will still be created, but to really feed this everything back and create this societal and public benefit and value that we aim for, yeah, will not happen without trust. I think so. This is a long introduction explaining why I think this is a very important guideline, although it's not a very technical one like some others. So maybe just, oh, can I go back as well? Yeah, maybe just quickly repeating the title of the guideline, because it, well, basically addresses what's going on. It's a draft guideline like all the others, and it addresses the health data access bodies on informing natural persons about the use of health data, the so-called citizen information point. So our target audience are the health data access bodies, and another detail I want to clarify, we use this label citizen information point. So we talk about citizens, but usually we quote it because it's not completely exact. So the regulation talks about natural persons, and it's something you have to keep in mind. And really make sure that you address everyone and include everyone. So not only the citizens in your own country, also citizens from abroad, also non-citizens have a right to be informed, have a right to navigate the space that we're creating. So this is a detail, but don't forget about it. So what is this all about? The challenge that the guideline addresses is described in the title, to guide the HDAPs in informing the natural persons about the use of health data. An interesting challenge in writing it was also that we actually have two target audiences. So we directly address the HDAPs and try to support them in establishing their citizen information points. But we always have to consider, and the actual target audience, the target audience of these citizen information points are the citizens and the patients and all the natural persons. And well, we cannot recommend anything valuable to the HDAPs if we do not consider this second target audience as well. Logically, we also have, like when you look at the value, the guideline tries to propose again, two groups there for the HDAPs. I mean, the easy part, so to say, is you want to be EHDS compliant, and we try to guide you in that. But as an HDAP, you also want to learn about good practices. You want to consider optional features. How can you improve? What else can you do to really increase and maximize the impact of what you're doing here? And one of the main impacts the HDAPs hopefully will achieve is to involve their citizens and yeah, to foster this understanding and engagement and all the things that we talk about. For the natural persons, for the citizens, well, you should know your right. At least you should be able to know your right, and that's what these citizen information points need to provide you with. You should be able to understand what is being done here, what's going on, how does it work, and with this understanding, then really start to build trust in that we're really trying to do the best and generate value for our societies. And I think another very important aspect is that it should also enable the broader public to really explore the results and see what has been done there. And some people will get curious and really involve themselves by seeing, that's a cool thing they did, I want to know more about it, or feel involved, like for example, I have a disease and I see what they're doing there, that's good, I really want that my data is used for these kind of things. And I think that's a good goal to achieve, to aim for at least. Now for the guideline itself, the main elements, well, in the structure that I provide here, you see another challenge that we had to address. So, okay, first we try to clarify what is an information point in this context. But then it was very important to really distinguish very well between the things that are mandated, what the regulation demands of HDAPs to do. So there is this chapter, what information shall be provided, This talks about the legal basis, the safeguards, individual rights, explaining the roles and who does what, so to say, in the setup, and also, as I mentioned, informing about results. And again, another clarification that was important to be exact in this guideline is that we don't, for example, the safeguards. Well, we don't explain the safeguards and so on. There are other places where this is analyzed. We talk about informing about this, and knowing about these safeguards is absolutely essential for building trust as a citizen. Then another section is, okay, now we know what we have to do. That's the bare minimum, so to say, but we really want to achieve something, we as an HDAP, for example. What additional information can be provided? What else can we do to increase our impact? So considering aspects of awareness, again, trust and engagement, as I mentioned. Also very relevant is the interplay with other regulations on European level, on national level. This guideline cannot analyze these and explain these details to the HDAPs, but at least point you to directions and so that HDAPs really are aware of what they all have to consider or should consider. And another very important aspect is, if you want to really reach somebody with all these informations, is how should you provide these information. So this is about accessibility, about language, language for all types of consumers, like lay language, down to maybe people who are not experts in the field, but are really interested also in the matter, and you have to address all of them. Also, structure is a thing. How do you structure the information? How do you structure like navigation through this landscape of information, visuals, the communication methods that you want to choose, and so on and so forth. So the second and third part, so I think in the chapter numbering it's even 4 or 5, but the additional information and how to provide this information, these are very wide and open fields, and for the public consultation I really hope for several comments who give us more direction in where to draw the line, where are gaps, where is it maybe too much, and so on. And we have another chapter, when should the information be provided, so there are some relevant timelines to consider for HDAPs, and this is also explained there. And to finish it, further development, well, the public consultation, we mentioned it a lot of times, we try in parallel to also gather specific input from citizens and patients and include that then afterwards, after the public consultation as well. Topics clarity, granularity, we already had feedback there that these are difficult balances between, you know, keeping it brief, but elaborate when necessary, keep it detailed, but leave the leeway that member states have. And landscape analysis is part of the guideline. I didn't explain it yet, but this is was a valuable source of input, but not at all representative, and not all so we try to learn from existing portals, and we want to expand this analysis and with several more portals to learn really from the best. And now for the final slide regarding the public consultation, I see there's a mishap in the slide, so you don't see the dates here, but you saw that already. And also sorry, this is the template slide, not the real one. Sorry for that, but I mean the message is the same. It is really, really essential, and we really need that feedback. I mentioned some of the aspects. Is it feasible? Where are the gaps? Where do we need more clarity? Where is it maybe too strict in your point of view, and so on and so forth. So really, please have a look. It's I think the benefit of such a non-technical guideline is that it's not too long. I think it's quite readable, so have a look at it and give us feedback, and also explain your perspectives, because this is a guideline where you really need to combine different perspectives, the HDAPs, the general public, and research communities, and so on and so forth. So waiting for your your input, and thanks for having me.
Thank you, Lorenz, for providing us an overview of this interesting guideline. Indeed, clear communication is essential to get the citizens on board and ensure they trust in the system. So before we move on to the stakeholder comments, we will have a presentation of one more draft guideline. The final draft guideline to be presented today offers guidance for data users on handling research outcomes. Please welcome to stage Chrysopieridou from the Karaiskakio Foundation.
Thank you very much for the introduction. My name is Chrysopieridou, and today I am representing the entire Task 8.3 team, whom I thank everyone for their input and their work towards this milestone document. So I will be touching upon our work, which basically focuses on the handling research outcomes under the EHDs. The challenges that we faced when drafting this document was actually the lack of clarity on how to handle these outcomes, which are generated from the EHDS secondary use, and the uncertainty that was found regarding the reporting obligations, the dissemination and transparency, as well as the interaction with GDPR and then the IP rights, and also the risk of inconsistent practices across the different member states. The value of this document is the clear structured guidance on outcome-related obligations under the EHDS, and we tried to support secondary data users in reporting and dissemination, managing IP and commercial outcomes, and of course promote the transparency, accountability, and legal certainty. The main elements of the draft guideline was to basically define the roles and responsibilities of the secondary data users, HDAPs, and data holders in relation to outcomes. Of course, outline the obligations to report results to HDAPs and ensure transparency whilst covering scientific policy and commercially relevant outcomes. We aim to explain the requirements for secure processing environments, anonymization, and prevention of re-identification when exporting results, and of course to distinguish between the use of data and the use of outcomes supporting innovation and commercialization while respecting EHDS transparency obligations. When it comes to further development of the guideline, we have separated our work into 4 different pillars. So starting with the legal and governance framework, we will further clarify the roles and the responsibilities under the EHDS, refine the distinction between data processing and handling of outcomes, then move on to reporting and dissemination of the outcomes and try to clarify the requirements for submission of results to HDAPs, then further guide on transparency and accountability and conditions for public availability, and then feasibly see if this is feasible for reporting timelines and level of details that need to be implemented. Moving on to safeguarding and compliance, we will focus on the practical implementation of secure processing environments, as well as ensuring effective anonymization and prevention of re-identification. And finishing off with intellectual property and collaboration, we will try to balance the transparency obligations and IP, clarify the use of outcomes in collaborative and multi-partner projects, and of course support innovation while maintaining EHDS safeguards. So we do invite you to have your say, because your feedback is essential to us in order to ensure legal clarity and consistency, to validate feasibility in practice, and of course to improve our guidance on secure processing constraints, reporting obligations, and the balance between transparency and IP. Please use the possibility to review, respond, and share your expertise. Tell us what is missing and and if, of course, the requirements are realistic and implementable. Thank you.
Thank you for providing us an overview of this guideline that is an important puzzle piece for data users specifically. Before we close this session, we'd like to hear from 3 more stakeholders and hear their first reactions to these documents. Igor Ruiz de los Mozos Aliaga from Nacertic will share his perspective on dataset linkage. After Igor, Bianca Pop from the European Patients Forum will share patient perspectives on the guidelines on the citizen information point. And finally, Enrique Bernal Delgado from the Institute for Health Sciences in Aragon will comment on the guideline for data users navigating the catalog. But first, please welcome Igor.
All right, good morning. It's a pleasure to be here and to give my feedback or feedback from some stakeholders to your great work. Indeed, it's a really good and steep document, and it's a really important guideline that is needed to link all our data together. It's not trivial, but you did a really good work mentioning scenarios, methods, considerations, and putting examples how to deal with this data, and even specifying the data frames, the time that it takes you to do all of this. So it's a really good standard. But since I think my job here is to be a little bit, to give some feedback, I try to do it. I'm bringing 3 comments. And as I've been seeing in all of this meeting, not everything is about the method, it's about the data. You even mentioned to use the identifiers and the importance of standardization and the data quality. But I think you need to enforce that. You need to put a workforce of curators that really enforce that this is done properly. I have the examples on my site of big databases like could be MBL, IGA, or GEO, more international one, that I have to deal several times to send my data there. And they are really tough curators, and I have to pass several rounds until I make my data online there. My second comment is that this needs to be a strong infrastructure. The model where the health data and the access bodies that you propose, I think, is the right one. But in practice, I think it will need a really, really strong infrastructure, scalable pipelines, and reproducible workflows. So you must enforce and think this ahead, because I think it's going to be kind of computationally demanding, and of course, to store all of this data, it will be a big challenge. And finally, but not last, it will be the interoperability of the data. Is essential, as needs to be aligned, like in any model standard, to really link the common models to the standards. And I bring it now to my side, to the genomic side, since in the genomic datasets, is mentioned in the scope on CEDAS and is mentioned in the scope of XT-AHR. But there's no clear integration, and there's the extra complexity. So I advise for the second round of the financing of these projects, really think on the genome as a key part of the health, and a really, really complex data set that we need to share and really research. In closing, you make a really strong foundation, but it needs some practical improvements, how to build all of this, right, and start building it properly. But you did a really good work, And I'm sure it will be a real-world success, all of your methods proposed in THEDAS 2. Thank you very much.
Hello, everyone. My name is Bianca Pop. I'm currently working as project officer at the European Patients Forum, who is a disease agnostic umbrella organization representing interests of patients, 150 million patients across Europe. So thank you very much for the opportunity to contribute and share our reflection regarding the draft guidelines on the citizen information point. We very much welcome the strong focus on patient rights, and this is essential for building a trustworthy and effective European health data space. So in this context, we encourage making full use of the existing resources, such as the extensive work that has been put in developing the Data Saves Lives practical toolkits, as well as webinars for patients and patient organizations that can support the EHDS implementation. At the same time, we would like to stress that further guidance and clarity is needed regarding the opt-out mechanism. And this is extremely important for our patients and patient communities. It's because patient needs not only to understand that they have the right, but also to know how to exercise these rights in practice. Second, we welcome the emphasis on informing patients about significant findings related to their data, and this is fundamentally about trust and transparency. However, we would caution against any approach where the implementation of the EHDS should be too quiet or in silence just because the information is too complex. So on the contrary, from our experience, the more informed patients are, the more willing they are to share their data. So in this regard, it will be important for the EHDS board, in consultations with relevant stakeholders, including patient organizations, to develop and work together in building clear guidelines on what represent clinically significant findings so that data users can act responsibly. And my last two additional points are really about the shift from patients to citizens in the context of the implementation of the European health data space. It's important to stress that not every citizen interacts with the healthcare system in the same way. Some people are occasional users, and we really hope that the European health data space won't create a framework that is dedicated to only the average users, but it's really trying to go beyond and address all patients' needs, including those that are less digital literate, as well as vulnerable patient groups and the elderly population. There are also patients, chronic patients living with disease, different diseases, so they really rely on the healthcare systems on a daily basis. So for them, healthcare is ongoing and it's a long treatment pathway. Therefore, our recommendation is to keep both perspectives visible and to refer to a patient and citizen information point. And my last point is very much in relation to Article 58 of the current regulation that foresee that member states shall inform the public at large scale about the role and benefits of health data access bodies. However, we did not see in practice large-scale awareness-raising efforts, so we really encourage the EU member states, in close collaboration with the Commission, as well as the relevant key stakeholders and the joint actions to really move forward and put a lot of effort in developing these campaigns in the next coming months. Thank you.
Hi, thank you for having me. First of all, my congratulations, Chriso, for the work done. I have to disclose that I've been reading across from the eyes of a data user. Actually, I'm a data scientist, so I've tried to figure out how I have to behave in the future with regard to the health data access bodies and the citizenship. So, and still, in this may be my first comment, still I see that is quite high level. So the level of detail of these guidance is not that much. So for a user, it's difficult to figure out how to behave. This is my first approach to it. And taking out from your main conclusions, I may have some suggestions for further development of the document, if it's of any help at all. For example, when you refer to the reporting of the outcomes, it is difficult to figure out how the outcomes you're referring to. We may think that are papers, we may think there are, I don't know, any digital object that you produce with the data, maybe an algorithm, maybe an enrichment of the data, the original data set, as for example Anna was explaining in the deliverable, or maybe a data quality assessment that the data scientist does when actually touch the data on the secure process environment. So according to that, I would suggest maybe to be more specific on the outcomes that you are referring to provide insight to those developing the implementing guidelines. For example, another point is, well, the user has to report to the health data access body and has to help the data access body to inform in order to get more transparency of the outcomes to the citizenship about what has been done with the data. For example, I would expect having in this document something about how to catalog the research outcomes in the DCAT AP specification. So if you look at the DCAT AP specification, there are some places, some derivatives from the control vocabularies in DCAT that allow you to put the research outcomes in. For example, you have is version of, or it comes from, as in the languages of provenance ontology within DCAT, they may help the health data access bodies to catalog the outcomes, and then anyone can see that this comes from this research. So these two elements, one is specify the type of outcome that you are referring to, because you have to, in the end, report on them differently. If it's an algorithm, is very much the importance on how you are programming and how transparent for another user is this programming. And in terms of the data quality assessments done by the data scientists within the secure process environment, then I may suggest that in Quantum we are developing a specification for fitness per purpose that actually was mentioned by Anna. And my final comment, maybe, in collaborative research, in what we call it federated research, well, it's true that the individual nodes in a federation, the individual researchers in a federation of researchers, they are, liable on the use of the data. But in terms of the use of the outcomes of the research, and if you differentiate so many outcomes, the obligations come from, multiple actors. So those that are actually programming, those that are doing the analysis, those that are doing the design of the research. So there are many obligations in many actors. So even though on the data, the liability remains in the one that is in the secure process environment, in the rest of the actions, actually, there are more responsible of the results. So I would maybe suggest in this collaborative contexts section to touch base on the multiple responsibilities in the governance of the research. And that's all from my side. Congratulations.
Thank you to our final front row commentators, Igor, Bianca, and Enrique, for representing some of our key stakeholders and making sure that their voices too are heard today.
We have now reached the end of the Tehdas2 plenary session, so stay tuned for the upcoming public consultations. We will share all the information and updates on tehdas.eu website. We are looking forward to hearing and reading your feedback. A big thank you to our presenters and stakeholders for sharing their comments and initial feedback. And now let's welcome the next plenary session. Thank you.
So, okay, we're moving to Plenary 7, Bridging Primary and Secondary Use, Integrating XTHR and TECTA's Results. Please welcome the co-chairs, Dr. Andreas Neokleous and Marcus Kalliola. Thank you.
Hello, everybody. Half an hour before we have lunch. What is the timeline just before we start? So from hour to half an hour, but I'm happy here to host this panel. Sorry? Okay, let's see how it goes, how enthusiastic our audience is after half an hour. So my name is Marcus Kalliola. Happy to be here today, again on the stage with all of you. I think it has been a very inspiring day so far. I'm here with my colleague Andres from XTHR. So would you like to present our topic for today?
All right. Thank you, Marcus. Thank you, everyone, for being here. This is a discussion that is not happening very often, and it is something that we should be doing, I think, from the beginning. But unfortunately, it was the case that primary and secondary use was seen kind of separately. You know, we had these two joint actions, one for primary use and one for secondary use running together. We also had national projects running for secondary use and for primary use before. So we want in this plenary to see how this, the primary and secondary use can eventually work together and join the infrastructures, but also the semantics behind it, so people can use primary use for secondary use and vice versa. And this is one of the topics, but we also want to see how the AI can fit into secondary use. Of course, this is something that obviously is the new topic now, and also the topic of the conference. And then we can talk about the trust and the citizens. We are talking about secondary use. We are talking about using the data from the citizens to do something else. Whatever this is, if this is for a good purpose, it's okay. But we are doing it. We are using the data. So we need to talk about the trust and the citizens. And finally, we can talk and discuss about what's forward, what is in the future, what's coming. Thank you.
Thank you. So now you know what we're going to talk about. The panelists, you know who you are. You can start addressing the stage. We have Professor Fidelia Cassini, Dr. Bianca Pop, Sarada Das, Dr. Maria Papanua, Dr. Michel Silvestri, and Dr. Konstantin Hyppänen online as a digital form. So, before we start shooting you with very difficult questions and make you uncomfortable, you get to introduce yourself very briefly about your background so that the audience knows where you're coming from. I think we could give the privilege to our online speaker first. So, Konstantin, would you like to introduce yourself?
Good afternoon, everyone, and I'm hoping I am audible. So my name is indeed Konstantin Hyppänen. I'm working in DG Sante of the European Commission in the unit C1, working on digital health with a focus on primary use. So I'm happy to bridge the gap from that side and to discuss today on the intersections with secondary and on the bridge we can build together.
Konstantin, and then we can go with the order that we have here. So Fidelia, first from your side. short introduction, please. Do you have the microphone?
Can you hear me? Yes.
Yes.
Good morning again. I'm Fidelia Cascini from Italy. I'm professor of public health, and I'm involved in several institutional roles at the national European level, and I'm really happy to participate to building EHDs for the future. Thank you.
Good morning also from my side. I'm Shahada Dash. I'm the Secretary General of the Standing Committee of European Doctors, CPME. We represent national medical associations. We've been trying to contribute to both joint actions and very pleased to be able to share some reflections. Thank you.
Hello everyone, to those in the room and online. My name is Bianca Pop. I'm currently working as project officer at the European Patients Forum. You have heard in my previous presentation what EPF is about. In my current role, I'm really working at the intersection of a few EU policy regulations, and I'm actually coordinating on behalf of EPF 3 EU-funded initiatives. Thank you.
Hi everyone, Michel Silvestri, Senior Advisor in the Swedish eHealth Agency, and I have a professional background both in primary use of health data and secondary use, I would say. I've also been involved in several of the EU projects regarding both primary use and secondary use, as well as projects on Nordic level preparing for EHDs. Thank you.
Hello everyone, I am Maria Papaioannou, and my recent work sits in the junction of primary and secondary use, as I worked as a project manager for a national project for the development of a prototype for the National EHR Data Bank of Cyprus, implementing provisions of the national health law. And now I work as a project manager for the direct grant for the secondary use of Cyprus designing and implementing the infrastructure for the secondary use with the establishment of HTAP and design and implementation of the 5 core HTAP digital business capabilities for Cyprus.
Okay, so talking about this, also in my introduction, of course, Maria, we have been working together for many years, also for primary use. So you are an expert also in primary use, if you forgot to say this. But anyway, talking about this in my introduction regarding the primary and secondary use, that it was seen as separate tasks. If we think about also in the regulation, different articles about primary and secondary, how can we now not see them as separate activities and see how primary and secondary use can actually work together?
So I think that we should begin to view the European health data space from the citizen's perspective, let's say. The health data of the citizen may move through different uses and governance route, but still remain part of the same journey, where the overarching goal is to promote better health and the citizens' well-being. And so from that perspective, I was thinking yesterday with all the discussions we had here that when data is generated for the citizen, we don't have a label saying this is primary use data and this is secondary use data, but rather we have data for the citizen. And what changes is just the context of the use and the actors involved and the governance, etc. But if we try to follow this journey of the data, we see that there is a continuum. So data are generated at the point of care with the citizen, and then data is shaped with different clinical workflows and EHRs and so on. And at a later point, the same data is reused for many secondary purposes like research and innovation and policy making, etc. So, but then the journey does not stop even with the reuse of the data. So the value gained from the use and all this evidence that carries with it comes back to the care to the care domain of the provision of primary use, and then we have better care and better diagnosis and better prevention and so on. For me, what I was also thinking about that the bridging primary and secondary is not one bridge; it's a system of bridges and the chain of handing over from data, care, generating data, and then reusing the data, and then back to better care. So in that way, there is no really a distinction of the activities, but only on the framework that we do these activities.
Thanks a lot. Anybody would like to react onto that? If I follow up a bit on this question, so the EHDs requires multiple nominations from the member state. You need to nominate the organization for primary use and secondary use. So should the countries nominate same organizations for these purposes, or do you think they should nominate different organizations, because then that, of course, then separates the activities even more? Any views from the member state representatives, basically Fidelia, Michelle?
It depends for sure on the member states. Sometimes in Italy, for instance, we will designate different authorities. One authority which will be the Digital Health Authority, and the other which will be the HTAB coordinator, because we will have different HTABs with the coordinator. And the idea is to distribute the efforts and the competencies, especially for the secondary use, because there are so many different data flows and all the background that is needed to allow access to data and release permit and evaluate what are the elements provided by the data user in requesting data access are so important that need a lot of people and resources. So we decided to find this solution to distribute and facilitate the implementation of the regulation.
Brief comment. I think that's part of the national autonomy or national competence. And of course, different member states have different organizations and different conditions for handling this. So I think you have to show respect to that. And then also very clearly, there might be quite different tasks for the Digital Health Authority in relation to the health data access bodies, for instance. So, yeah.
So we'll see. Okay, let's dive more into the technical topics. We had a good presentation today about the XDSR regarding the exchange format. And we would like to address the European Commission and Konstantin regarding the question. So how do you see the primary use and the exchange format benefiting the secondary use? Any views on that?
Yeah, so maybe I could start by saying that, first of all electronic health records are in the scope of secondary use. Of course, apart from data on people who opted out from secondary. Regardless of whether the data is or is not compliant with the format, the data also goes beyond the priority data category, so it's quite a wide set of data which is available for secondary use. And no, there is no specific right for a researcher to ask data in the format for secondary use, and there is no obligation for HDAPs to provide the data in the format, but of course it might be used in some cases if technically possible. And the main benefit I would like to highlight today is that the use of the format for primary use, for the provision of healthcare, it kind of contributes to the harmonization of data. Because when the data is following for the purposes of later creating the format a specific pattern, then there is a possibility that the format indirectly benefits secondary use. So in the long run, we could see the data that is more coded, more structured, more consistent, more uniform across member states because of the use of the formats. And that could really improve the possibilities for doing different types of research on that more harmonized and uniform data.
Thanks. But it seems a bit like a missed opportunity, because if we reach this interoperability within the primary use, would it be nice to be able to ask, let's say, from 5 countries, patient summaries in the same format and do research on that? Any views from the panel? How could we reach that possibility to use the standardization that we have already in place? Could there be a service from somebody, let's say a CRO, a private company doing these kinds of things, using the format, doing the harmonization for research?
Well, it depends on how you look at it, but of course it's you can have discussions about strategy, in what way to store the health data from the beginning, but also what possibilities you have to transform it or translate it into other formats, of course. And you and I, for instance, we've had several discussions about the OMOP, Common Data Model, for instance, as one preparation for secondary use. Others think maybe that you could directly go for another model, such as OpenAir, for instance. So there are different views on this, I would say. And I think that we have to be, at least from the beginning, a little bit agnostic when it comes to this. So, but be open for this, and that we really need to continue this discussion, of course.
But Fidelia, do you see any governance or interoperability arrangement that could be made to align better the primary and secondary use?
In my view, we at the member state level could use the model that we have in the EHDS for the central level. I mean, the EHDS board that we have with 2 parallel ways, which are one, the primary use, and the other secondary use. And the steering boards, the steering groups supporting both the primary and the secondary use. So we can think about a governance framework like that also at the national level to facilitate the interactions between Digital Health Authority and the HTABs, and to create groups of experts to support both the authorities in facilitating this kind of exchange. This from the governance point of view. Regarding interoperability, the situation is a little bit more complex because secondary use is completely different from primary use in terms of number of data sets and data categories that we need to standardize or we need to make usable, not only available. And we are just at the beginning of this process compared to the primary use, where we have already 6 priority data categories and we are working for standardize them. So for sure we will start using the primary categories of data, categories for primary use for the secondary use, but it's not enough, and we have to work a lot to standardize so many different data categories for the secondary use. But it's challenging, but really interesting for the future. Thank you.
Thank you. Then, of course, there's the role for healthcare professionals on all of this, and we have heard about that, for example, yesterday on Krista's presentations on the potential standardized data capture side, and I think we have heard also about the data quality side a lot. So what are the incentives for the clinicians and the primary use to really do good quality data that fits also for the secondary use purposes? Sarada, on your thoughts on that?
I think our members have been citing motivations very similar to what has been mentioned here already, that there's a kind of virtuous circle between high quality primary use data and translated into secondary use. Professor Srisas yesterday put it as data quality is an active patient care, which I think is a very good way of looking at this. And for CPME, we've really also been underlining this clinical first element. So as yesterday I was saying, this is really doctors' role to ensure data input into electronic health records is of high quality, so it can then be fed upstream. In this context, however, we also really point out the resource limitations of doctors being able to provide data for secondary use. And that's something I think also looking a little bit at the discussions we had now on the forthcoming guidelines, which is important to continue. how will the data be captured by data holders who are exempt from having to provide data for secondary use? This is foreseen in the legislation. Legislation also foresees data intermediaries as a kind of assistance in this process, and it would be very useful also to have greater clarity of how this will be rolled out at national level. So we really think there's a lot of value to ensuring that doctors can focus on providing high quality primary use data as much as possible. But then also looking, of course, the doctors in another role as researchers, what is their access point to secondary use data? And one question that has been arising here, and I saw to some extent be very interested in the guidelines that will be coming, it's on how will this data, once reported, be contextualized? How will it be checked for comparability? And how will kind of the nuance, which of course is always present in data collections, be conveyed once this is standardized and made available also to other data users?
Yeah, I think this is not a new topic. How to create incentives for the healthcare workforce to report on health data better and more. I think, for example, in Sweden, this has been discussed a lot with the quality registers. I don't know if the audience knows, but Sweden has quite good quality registers, and it is an additional burden for the healthcare workforce. So how do you see it in Sweden, and have you had discussions on this topic?
Well, to start with, the quality registries, we have more than 100 of those, and many of them go back several decades with longitudinal data. So we often refer to them as a gold mine of information and knowledge, and also in a way perhaps benchmarking between different healthcare providers, also driving quality in a positive manner. But the other side of the coin in this case that you indicated is that several health professionals complain because these quality registries, they are not standardized according to the platform they are on. In many cases, it has been for years and decades maybe that healthcare professionals, doctors, nurses and others have to manually register data, maybe double register, maybe triple register, and of course that's crazy. And in this case, with the possibilities of EHDs and AI development and everything, we should really be careful not to put any extra burden on the health professionals, rather the opposite. And that's why the Swedish government has given my agency a couple of government assignments looking at how to make this an automatic process, getting the health data from the EHR systems directly into these registries, for instance.
Great.
We agree very much. We call this the once only principle, and would be very pleased to see some suggestions on how to achieve this.
Well, Michelle will make it happen, so. All right. Fidelia, regarding still the secondary use and how then that could improve the primary use, I think that's another topic that has been perhaps less discussed. We just heard about the DATAS2 guideline on this refinement of data, but there's also the data quality and utility label. And we have Enrichment here, who is actually leading the Quantum project, which is developing this label. Is there an opportunity that the secondary use actually brings more value to the primary use also, and we get the better data sets because we have done something with the data?
Yes, for sure. The two things could be supportive for each other. The idea should be to create the data quality as a clinical asset. I mean, something which is recognized as an element so important to improve healthcare and provision of care in general by the member states, by the data holder, and to facilitate this kind of exchanges. But it is not immediate because it is an indirect effect which is not for sure an obligation of the EHDs, and it couldn't be, because when we talk about primary use, according to the treaty of the functioning of the European Union, we are talking about something which is under the control of the member states. So everything that we can produce and support as a guidance to improve the healthcare system and the functioning of the healthcare system is something that has to be approved by the member states. And at the local level, there's a need to create a good awareness of the importance of these. And technically, this could be solved because when we collect data from a primary entry data sources and we are analyzing if there are gaps or incompleteness, it's easier to understand if they are not quality data or there are something to improve. But the problem is how these gaps or how these quality on the opposite is evaluated as an important asset to provide healthcare. So at the local level, policymakers should invest in this to incentivize data holders to improve these and to use these messages from the secondary use to the primary use.
Okay, thank you. I would like to ask Michelle, let's go back to AI. So the question is AI the perfect use case for bridging primary and secondary use? What about the precision medicine? And when other people's health data is needed to diagnose a patient? So what is the role of EHDS here?
Well, I think that if we're talking about AI and EHDS, AI and training, AI models, training algorithms, etc., that is part of the secondary purposes mentioned in the EHDS regulation, right? So it's good to provide the possibilities to do that according to this new regulation. On the other hand, it's interesting because this is one of the areas I would say that is in the gray zone, an overlap between primary use and secondary use. When you're on the way to develop and later on also implement a new clinical tool of this kind. And then it gets a little bit more complicated or even complex since you have different kinds of regulation for well, actually having an effect on this. You have the AI Act, for instance. You also have the medical device regulation and the EHDS and also others. So I think quite often it seems as if this is one of the areas where there are unclarities that may hinder also the development. So that it's very clear that we need guidance, legal guidance, regulatory guidance when it comes to these things. But it's a good use case or driver for doing this anyway. Getting back to what you mentioned or you asked about precision medicine, it's also interesting because another of the secondary purposes is that you will be able to use health data from other individuals or patients to improve quality of healthcare. And you could interpret that as kind of personalized healthcare, personalized medicine or precision medicine, so that if you are a clinician, for instance, and you have a patient in front of you, you suspect maybe that this patient may suffer from a rare disease, and then you see that it would help if you could get access to other patients' health data to compare in a way. And in that case, again, it's good that the EHDS regulation will provide this possibility. But I've discussed this with some of the top, both researchers and clinicians in precision medicine in Sweden, for instance. And of course, we see it as a problem that it's part of the secondary purposes, because the question is then, okay, so this clinician, does he or her have to apply for access according to the regular processes for secondary use? because then the waiting time might be several months, even up to 1 year. And that's not realistic when you have this patient in front of you. So these clinicians and researchers, they say that a maximum of 2 weeks maybe, not more than 4 weeks, or depending on the health status of the patient, of course, as soon as possible. So that's a challenge to handle, I think.
Okay, thank you, Michelle. Anyone wants to comment on this, maybe? Okay.
Maybe just to echo, because you've mentioned the AI, and indeed it adds an extra layer. There is still a lot of uncertainty regarding the secondary use, and AI is indeed adding extra challenges. So from our perspective, we think it's really important that we really preserve the AI safeguards that are reflected in the AI Act, also in the light of the digital omnibus for artificial intelligence.
Right. Thank you. So I would like to ask you, Fidelia, about predictive, preventive, personalized, participatory, P4, and precision medicine. Rely on continuous learning from data across care and research. Does EHDS actually enable this learning loop?
I would say that EHDS creates the preconditions to do that, but it's not enough, because it is a regulation which provides governance and responsibilities and infrastructures, but it's not a framework that can go so deeply into the local context of the implementation of the healthcare services and the provision of services and the improvement of health of single person. But these preconditions are essential, and we should imagine a future where there is an integration in real time of the results that are from the secondary use in the primary use, in terms of information available for doctors, for instance, to update guidance that are useful to provide healthcare services, and also to provide warnings regarding emergencies. So think, for instance, the next future we are facing an increase in infections, healthcare-related infections, and antimicrobial resistance. We will have provisions for 2050 where we will have millions of deaths related to these conditions, likely those which are now related to cardiovascular diseases. When you look at these public health situations, which are so challenging, and you think about the value that results of research from the secondary uses of these large amounts of health data which are available through the EHDS can help the member states in directing new policies for the improvement of healthcare services, in addressing doctors' guidance, in evaluating the clinical settings and the risks related to these specific clinical settings. This is something which we should and we have to use in the next future for the benefit of the European Union. So the EHDS is a precondition, but a lot of work we need to do at the member states level and with the vision for the future.
Yeah. Yes, to speed up a bit. Okay. So I would like to ask Bianca about the citizens. They are an important factor in the linkage between primary and secondary use, right? Is there a risk that when patients hear about the possibility of their data being used for secondary purpose, will they avoid healthcare services, you think?
Thank you for your question. That's a valid question. Indeed, there are many, many risks, and this is actually happening because there is, again, lack of clarity on the opt-out mechanism. So patients really want to understand, they want to kind of be in full control full control over their data. They need to feel confident. They need to know who can access it, for which purposes. And then linking to the secondary use of data, in our recent conversations with our patient community and patient organizations and membership, we understand that there is a bit of unclarity regarding the public health as it's now stated in the current regulation, because as we know, data can be used for other purposes. Public health is a key element and part of that list. For instance, in France, there is this data permit, which means that researchers or other organizations can access the data from patients, but this is how this is happening actually in practice. There is really an ethical and scientific review, an independent review by the organizations, and then we understand that there is still a bit of unclarity whether EHDS is actually having an impact and adding like any limitations on how this will happen moving forward. The same concern was mentioned from the Netherlands. We've been told that sometimes we make assumptions that everyone knows and every member state have a common understanding and the same approach to public health interest, which obviously cannot. Maybe it might not be the case. So it's really important, and our key recommendation from the patient organization group would be to really have a shared common understanding of what do we mean by public health, so we really overcome any misuse of data.
What about Sarada? If you think about the healthcare workforce, then is this bridging between primary and secondary, is this an issue for doctors? Is it a risk that they will, when they hear more about the secondary use and the data being used more and more, is there a risk from that perspective?
As I mentioned yesterday, our members are looking at how the security safeguards are being put in place around data. This is a very real concern, and also very much aware of, we discussed now citizens' information points, but of course doctors will also be approached by patients asking what this is about, and we're very pleased to also be cooperating with EPF on clarifying a little bit how to best relay this information at the point of care. So I think that also giving doctors a lot of information on these more, let's say, technical security safeguards will be very useful. On the other hand, of course, the potential to benefit is huge. I mean, this is also our main objective of contributing. It's not to have a beautiful technical exchange infrastructure, but it's really to have the benefits in the end. So I think that, for example, mentioned registries, of course, the potential is to have much better filled registries, and we see now that also the level of data in registries is very different. Even with high coverage, it might be not clinically very useful data. So this really gives the potential to have great wealth of data to look into, and indeed these kind of ideas of how to get it to primary care, primary use level quicker is an interesting one to look into.
Thanks. We are now 6 minutes over the initial timeline, so we are 9 minutes left on the panel. We were granted 15 minutes over time. Thanks for that. I want to address Konstantin, you, and let's speed up a bit on our initial planning of the panel. I would like to address on you on all the, let's say, all the future topics from the Commission viewpoint. So let's say standardization. Can we expect more standardization for primary use coming from the Commission? There's also possibilities for adding new data or new standardization in the EHDS for the Commission. There's also the new MMF coming. People are, of course, eager to hear about the future of the joint actions, potential collaboration between primary and secondary use. There's also the EHDS governance taking place. So if you could address sort of where's the future taking us from your viewpoint. And after you, then I would like to ask Maria, Michelle, and Fidelia to maybe reflect from the member state point of view the future. But Konstantin first.
Thank you very much. It's a very big question, of course, to explain what's going to happen in the future, and I'm not sure if I will have all the answers about that. But speaking of further standardization and further structuring of data, especially at the point of data collection, I think we should keep in mind that, first of all, both structured and unstructured data is useful for both primary and secondary use. It's always a hybrid in effect. And what we will probably observe in the future is more use of new technologies, because they are developing very quickly, different AI technologies that can help structurize the data, but they can also help get better use of unstructured data. And I think we are learning by doing when we develop different technologies for processing the data, and this field is very rapidly developing right now. And of course, both types of data will continue to be present, both structured data and unstructured data. In my previous comment about helping to harmonize semantic meaning and coding of data is still beneficial actually for both types of the data sets. One tool which we haven't yet used, there is a possibility in the EHDS regulation to determine data quality requirements in the section on primary use, including semantics, uniformity, consistency, accuracy, completeness of data, and that could be a useful tool for improving further harmonization, standardization of data. Now, of course, the next steps in the future is to ensure the implementation of the European health data space, both primary and secondary, and supporting countries through different collective learning activities and EU-funded projects. There are multiple projects doing that. Capacity building, both for primary and for secondary. The joint action next DHR that concluded yesterday in the event and officially today has also contributed to this. And of course, there are debt-funded projects like Expand the Age or XShare or secondary use projects that are supporting different actors involved in the implementation activities. So we will see more of support. I will just mention that on 10th of April, a new call was published under Digital Europe program about building capacity to deploy the European Health Record Exchange format, but also to deploy the reuse of health data under EHDS. So it's about both primary and secondary use, and it's quite a significant amount of funding which is allocated to this call. The budget is 14.4 million, and the application deadline is on 1st of October. So we will see more development efforts and more collaboration, of course, between different member states and collective learning, which we are trying to support through the projects that I have outlined.
Thanks a lot, Konstantin. And let's go for the member state view. Do we have enough collaboration for the future now that the joint action ends, or what do you see the future bringing? If we start from Fidelia, then Michelle, and then Maria. And perhaps we also give the stakeholders then after that a possibility to comment whether the stakeholders are involved enough. But be brief because the food is waiting.
We hope for sure to increase the family of the EHDS and to cooperate strictly with the stakeholders which are essential for building this project. So they are very welcome, and this is the starting point to increase all the discussions and the comparison of different words to improve for the future.
And I just want to add that I think it's good that we now have a clear direction towards implementing and using FHIR as the standard for exchange of health data for primary use. And in addition to that, if we're talking secondary use, I'm glad also that in Sweden we now have a new initiative, OMOP for Sweden, so that we can also improve our awareness and skills when it comes to that kind of common data model for preparing for secondary use. But as I mentioned earlier, I think that also we have to be open for other strategies, such as open air, advocated by some people, for instance. Again, an agnostic approach to this seems to be appropriate. And of course, in these kinds of international collaborations that we have, as my colleague Daniel Carlson mentioned the other day, it's like democracy. It's messy but beautiful at the same time. So I think that we have to navigate in such a landscape. Just a few words about data quality as well. There are no clear requirements according to the EHDS regulation regarding data quality for secondary use, for instance. But I think that the proposal for a Biotech Act with the part describing a data quality accelerator, that could be an additional incentive added to the EHDS regulation, driving quality in a positive direction. Thank you.
So I would really like to highlight, for this question specifically, the value of the two projects that you two represent, XTHR and TEDS2, and because you exactly showed us how this collaboration between different member states can bring products and outcomes that can act like implementation assets for all the member states that are implementing EHDS. So, and especially for member states like Cyprus, my home country, with lower readiness, let's say, for EHDS, it's a very important part to have all this output and to integrate it to our infrastructure from the very beginning, as for the primary and the secondary use infrastructure we have just started. And I would also like to highlight the importance of the European Central Services as well, again, as a member state with lower readiness, and what we receive and the support and how we can exploit all this outcome for building interoperability. And another point I would like to point out is the value of this collaboration that brings also responsibility and accountability between the member states that participate to this kind of initiative, let's say, and with somehow we implement the union, the word union in the European Union, so we share the responsibility, we take accountability, and then we can go back to our country and implement and make integrate the results. And another point is the involvement of the national decision makers in all this, in these future collaborations. I would like to see, it was also stressed out yesterday, that there is a missing part. The implementers are active and engaging with this, the EHDS implementation, and then they see the barriers, they see the challenges, they identify the risks and the needs, and then there is a gap of communication with the national decision makers, and I would like to see future collaborations to involve as part of their responsibility in these initiatives. And so we have all these shared assets, as I mentioned in the beginning, being implemented and funded and integrated in the national infrastructures. Thank you.
I'm sorry, but I think we already used now all the overtime that we had. We are already 1 minute over the overtime. Do we allow us to still continue for another minute? Thanks so much. So let's then give the stakeholders then, Sarada and Bianca, still the last word on this. So for example, in joint actions, the stakeholders cannot directly be partners. So how do you see, have you onboarded you the correct way, and what would be the future of the collaboration with the stakeholders on the EHDS?
I must say that we've been really very positively received, and all of our input has been positively received, but indeed our limited resources have made it overwhelming at times. And I think that there is much more interest beyond CPME out there to contribute to this. So I think thinking about new ways of involvement or making it more possible for stakeholders to be involved would really also improve everyone's joint objective of making this work. These examples of having national level replica of kind of stakeholder consultation, and we saw here in Cyprus Medical Association, I think these are very good examples. I also agree this morning the comment was raised that this cooperation will not continue on a voluntary basis. It should be somehow entrenched as a part of the continued development, and also having a single point for stakeholders to contact might be useful. I think that those were good things. If I may, I would also say, please do not waste all of this effort. Become a stakeholder yourself and reach out to those negotiating now the political translation of all of this work. I think that is really key. I see already in the legislation discussions around obligation on data holders, etc., that are really can be much more informed by everyone who has been involved now, not to lose all of this great work that has already been done over so many years.
And maybe very briefly from my side, patient involvement is extremely important, because we are not talking about any personal data, but health data. So that as we move forward, we really think that so the key issue is not about whether patient and patient organizations are consulted, because this is already happening. It's really about making sure that their perspective is fully reflected and embedded when making decision, informed decisions, policy decision making. So maybe one last comment from my side. It's very much related to the EHDS board. So it would be important that patients are not just again consulted and providing input and feedback, but really playing a role in the secondary use governance structure as well. And the useful reference here is really the EMA approach, where patients are not just consulted, but really playing an active role in the decision-making process. Thank you.
Thank you very much. I think we for a new joint action to integrate primary and secondary use.
A new joint action to integrate both primary and secondary use is the request. Thank you very much. I would like to thank the panel and the plenary. We can close the plenary. Thank you, Marcus, and we can go for the lunch.
We thank the co-chairs for their coordination and the speakers. We can now move for our lunch. The lunch is served in Aura restaurant. If you go outside, you can take the stairs and go to level -1. I kindly ask you to be back by 2:30 so we can start on time. Thank you.
Europe is stepping into a new era of digital health, one where your health data can follow you wherever you are. At the Ehds-Ai Connect in Brussels, experts from across Europe came together to test the systems that will make this a reality. The European Health Data Space is an EU regulation that will be rolled out step by step to allow cross-border healthcare by 2029.
Our vision is the one to create a European space for the data to flow, but not for flowing for nothing, flowing for the benefits of the European citizens. In first place, to give them access to their health data wherever they are in the member states, but also in another member states.
Behind this vision lies a major challenge. That's what we call interoperability.
Every country has its own national system with different, first of all, languages, different standards. In order to be able to have the citizen travel around, these should talk to each other.
But what precise information should be shared and how? These technical questions are shaping Europe's future health system, with answers only expected in 2027. Over the past 30 months, the Ehds-I project has brought together health authorities, industry leaders, and IT experts to design, test, and refine solutions that could underpin this new framework.
We have identified the general requirements for EHR systems. We specified the technical requirements, which are very important at this stage. Now we know what the EHR systems have to comply to.
We described the requirements for the exchange format and also for the metadata system, which must be implemented in the EHDS.
And then we have the conformity framework, where we specify how the systems will test and make sure that they are compliant with EHDS.
These new tools were tested during the Ehds-I Projectathon here in Brussels. For several days, developers, healthcare providers, and manufacturers worked side by side, ensuring they can securely exchange health data in compliance with the regulation.
Testing events, they are helping both communities, the users, in seeing if they have built specifications that are of good quality and that can be implemented, and the vendors to start preparing themselves for what is coming up.
Putting all the manufacturers together and provide them a place where they will work together, experience together, test the one against the other, is how they will learn about the EHDS and how they will improve the system and be ready for 2029.
Significant progress has already been made with the foundations laid by the Ehds-I joint action, but building a truly connected European health system will be a long journey. Its success will depend on continued collaboration with member states and stakeholders, innovation and trust, placing citizens at the heart of digital health in Europe.
Our vision is the one to create a European space for the data to flow, but not for flowing for nothing, flowing for the benefits of the European citizens. In first place, to give them access to their health data wherever they are, in the member states, but also in another member states.
You are taking your holiday in Cyprus, in a beach. Suddenly you are feeling pain, a chest pain. Your record, while they giving you the first aid, will be readily available for the doctor.
Dr. A sends the clinical data of one patient or of one citizen to Dr. B, and Dr. B receives this data, and in theory he should be able to practice medicine by only reading this information.
So the citizen will feel secure without borders to have a better medical treatment.
Interoperability is key. You cannot have the exchange, the cross-border exchange of health data without interoperability.
Countries have their own national implementations.
With different, first of all, languages, different standards. We don't want to replace the systems and just evolve them in these standards.
We have so many different types of stakeholders. Finding the common ground and finding the common solutions which actually acknowledge all the different types of actors. That is the big challenge.
Work in a coherent framework, and everybody has to respect the regulation, mostly on privacy and also on clinical meaningfulness of the data exchange.
We're sharing e-prescriptions and patient summaries already today. It was a voluntary system, now it's a mandatory.
The main objective is to ensure the highway for the data stream will support better care pathway and better care.
European Commission, in collaboration with the governments, they are currently preparing the implementation acts, and this will be known the soonest in March 2027. We are trying to contribute and influence as much as we can to try not to reinvent the wheel so much.
We don't wish to reinvent the wheel. We need a pragmatic approach to these rules and to make a system that actually delivers for citizens and innovators. We are at full speed working on its implementation, but the time is very short. And we need actually all these inputs from different angles, different communities, to bring the EHDS to a reality.
It's a joint action funded by the European Commission to define and develop the guidelines and implementation acts for the implementation of the European Health Data Space Regulation. The development of systems that they talk to each other to exchange data while the citizen is traveling within Europe.
The regulation is defining what needs to be done, and then XTHR really specifies the technical specifications for how this will be done.
So we had to extract from those legal articles what would be the meaningful technical requirements.
We have identified the general requirements of EHR systems. We also specify the format, this EHRXF.
Which is the standards that will make this data flowing really across border.
We specify the clinical content, what we call the logical models.
Meaning the definitions, what information need to be shared.
We felt that IHE Europe and HSF in Europe really need to come together because it's a big challenge to really come to implementable specification.
The HTHR logical model is based on HL7 FHIR resources that are used along those 6 healthcare priority domains, as we call them. Lab reports, medical imaging, discharge reports, patient summaries, e-prescription and dispensation.
And IHE having the IHE methodology to create implementable specifications, use case based.
And regarding the transactional part, meaning the transmission of that content between the different actors, we have a work group which is an API work group.
XTHR was the bridge between policy and implementation. The main achievement is to give a clear picture of how this will be done and how this will be feasible in Europe. And I think it is clear, without surprise to the vendors, without surprise to the market.
It is bringing together member states experts, but also experts from different communities, manufacturers, vendors, to identify the central piece of the future, the system of tomorrow.
The XTHR was a project did assemble the opinions of the various member states.
The overall approach and overall specification has been agreed with the industry.
All of those guidelines, the technical specifications that come out of the work packages are going to inform the decisions on the implementing acts in the future.
XTHR gave a building block that all the European member states can start from. We have a starting point, it's a great basis, it's at the grounds.
So we are talking about an ecosystem that is being set up, and this is key for EHDS implementation.
We have the specifications. My understanding is that it is of high quality, but this is in paper. So now we are currently checking in practice.
What we mostly test is the adoption of what we call the European Electronic Exchange format that should be somehow adopted by all.
The test cases are mainly pushing or retrieving documents from a repository.
They can start interacting with the DTE. So not only on the workflows, so not only on the sharing of the document, but they can use DTE also for checking the conformance of the document.
Bringing all the participants together, all the manufacturers, provide them a place where they will work together, experience together, test the one against the other, is how they will learn about the EHDS and how they will improve the system and be ready for 2029.
Testing events, they are helping both communities, the users, in seeing if they have built specifications that are of good quality and that can be implemented, and the vendors to start preparing themselves for what is coming up.
We identified some gaps in our application. This is a great opportunity for that. It is always to identify them before and not after.
When you finally get into the test tools and talk to different companies, there are always small things that appear that you
Oh, yes, it should be like this, and then you fix it and test it again.
The projectathon gives us an extra opportunity to be on the forefront of developing new content that can later be rolled out for data exchange through the European Union.
The testing events have a special role because they really gather the implementers of the specifications. They are also a way to try and fix something that is still in progress.
We can also help clarifying possible pitfall or gap that we have in the specification, so increase the confidence and the maturity of the specs.
We are testing our specifications and we will receive the feedback.
You need feedback, and you need to get the feedback and maintain and improve the spec.
We deliver something that it is testable and it's ready-made for mass production and widely adopted across the European Union.
The deliverables of the THR, they're going to be adopted by the technical committees that are preparing the implementation acts, and this will, let's say, forge how the regulation is going to be made operational.
Our hope is that the Commission and the Member States will pick these specifications up so that proven specification can be used by the vendor community.
There is still some work to do, but from my perspective, we are like at least 80 to 90% complete. And as to my knowledge, there are no real big gaps here. It's only more like fine-tuning.
I think that the initial objectives have been met, even though we need to consider that further refinement and maintenance of the specification are needed.
The exchange format is described. The data flow will be seamless for these data sets.
There are other projects like I2X or Share or other innovative projects that are relying on the specification that are developing.
The specifications we're working on are never ready. They need continuous updates, feedback from the market.
The exchange format can be expanded, needs to be expanded to cover all the data categories.
The European Commission has launched what we call the Exchange Format Support Center. So most of those EXTHR specifications are going to be somehow continue to be maintained and extended.
The sustainability of the changes must be controlled with a correct roadmap.
There needs to be some sort of governance bodies that will continue working in this. I believe that this needs to be somehow professionalized in the future.
There is a gap between the medicine and the technology, and this is where we need to work really.
The safe and secure and well organized implementation of the regulation. These are the big challenges.
We need meetings between different member states. The success happens on local implementations and local deployments.
It goes to the member states because they need to implement infrastructure. It goes to the vendors who need to make their systems compliant.
The next step prior to having the implementing acts ready is to see how those can be transferred into specification and implementation guides.
We should not leave these results in deliverables. We should proceed with implementation.
We need to also educate the patients and the citizens and how to interact and work together.
We need now to disseminate.
The citizens which are getting this empowerment must be educated.
So they engage the healthcare professionals.
This is not the end. This is it's the end of extended EHR, but it's the beginning of the European journey.
Europe is stepping into a new era of digital health, one where your health data can follow you wherever you are. At the Ehds-Ai Connect in Brussels, experts from across Europe came together to test the systems that will make this a reality. The European Health Data Space is an EU regulation that will be rolled out step by step to allow cross-border healthcare by 2029.
Our vision is the one to create a European space for the data to flow, but not for flowing for nothing, flowing for the benefits of the European citizens. In first place, to give them access to their health data wherever they are, in the member states, but also in another member states.
Behind this vision lies a major challenge. That's what we call interoperability.
Not every country has its own national system with different, first of all, languages, different standards. In order to be able to have the citizen travel around, these should talk to each other.
But what precise information should be shared and how? These technical questions are shaping Europe's future health system, with answers only expected in 2027. Over the past 30 months, the Ehds-Ai project has brought together health authorities, industry leaders, and IT experts to design, test, and refine solutions that could underpin this new framework.
We have identified the general requirements for EHR systems. We specified the technical requirements, which are very important at this stage. Now we know what the EHR systems have to comply to.
We described the requirements for the exchange format and also for the metadata system, which must be implemented in the Ehds-Ai.
And then we have the conformity framework, where we specify how the systems will test and make sure that they are compliant with EHDs.
These new tools were tested during the Ehds-Ai Projectathon here in Brussels. For several days, developers, healthcare providers, and manufacturers worked side by side, ensuring they can securely exchange health data in compliance with the regulation.
Testing events, they are helping both communities, the users, in seeing if they have built specifications that are of good quality and that can be implemented, and the vendors to start preparing themselves for what is coming up.
Putting all the manufacturers together and provide them a place where they will work together, experience together, test the one against the other is how they will learn about the EHDs and how they will improve the system and be ready for 2029.
Significant progress has already been made with the foundations laid by the Ehds-Ai joint action, but building a truly connected European health system will be a long journey. Its success will depend on continued collaboration with member states and stakeholders, innovation and trust, placing citizens at the heart of digital health in Europe.
Our vision is the one to create a European space for the data to flow, but not for flowing for nothing, flowing for the benefits of the European citizens. In first place, to give them access to their health data wherever they are in the member states, but also in another member states.
You are taking your holiday in Cyprus, in a beach. Suddenly you are feeling pain, a chest pain. Your record, while they're giving you the first aid, will be readily available for the doctor.
Dr. A sends the clinical data of one patient or of one citizen to Dr. B, and Dr. B receives this data, and in theory he should be able to practice medicine by only reading this information.
So the citizen will feel secure without borders to have a better medical treatment.
Interoperability is key. You cannot have the exchange, the cross-border exchange of health data without interoperability.
Countries have their own national implementations.
With different, first of all, languages, different standards. We don't want to replace the systems and just evolve them in these standards.
We have so many different types of stakeholders. Finding the common ground and finding the common solutions which actually acknowledge all the different types of actors. That is the big challenge.
Work in a coherent framework, and everybody has to respect the regulation, mostly on privacy and also on clinical meaningfulness of the data exchanged.
We're sharing e-prescriptions and patient summaries already today. It was a voluntary system, now it's a mandatory.
The main objective is to ensure the highway for the data stream will support better care pathway and better care.
European Commission, in collaboration with the governments, they are currently preparing the implementation acts, and this will be known the soonest in March 2027. We are trying to contribute and influence as much as we can to try not to reinvent the wheel so much.
We don't wish to reinvent the wheel. We need a pragmatic approach to these rules and to make a system that actually delivers for citizens and innovators. We are at full speed working on its implementation, but the time is very short. And we need actually all these inputs from different angles, different communities, to bring the EHDS to a reality.
It's a joint action funded by the European Commission to define and develop the guidelines and implementation acts for the implementation of the European Health Data Space Regulation. The development of systems that they talk to each other to exchange data while the citizen is traveling within Europe.
The regulation is defining what needs to be done, and then XTHR really specifies the technical specifications for how this will be done.
So we had to extract from those legal articles what would be the meaningful technical requirements.
We have identified the general requirements of EHR systems. We also specify the format, this EHRXF.
Which is the standards that will make this data flowing really across border.
We specify the clinical content, what we call the logical models.
Meaning the definitions, what information need to be shared.
We felt that IHE Europe and HSF in Europe really need to come together because it's a big challenge to really come to implementable specification.
The XTHR logical model is based on HL7 FHIR resources that are used along those 6 healthcare priority domains, as we call them. Lab reports, medical imaging, discharge reports, patient summaries, prescription and dispensation.
And IHE having the IHE methodology to create implementable specifications, use case based.
And regarding the transactional part, meaning the transmission of that content between the different actors, we have a work group which is an API work group.
XTHR was the bridge between policy and implementation. The main achievement is to give a clear picture of how this will be done and how this will be feasible in Europe. And I think it is clear, without surprise to the vendors, without surprise to the market.
It is bringing together member states experts, but also experts from different communities, manufacturers, vendors, to identify the central piece of the future, the system of tomorrow.
The XTHR was a project did assemble the opinions of the various member states.
The overall approach and overall specification has been agreed with the industry.
All of those guidelines, the technical specifications that come out of the work packages are going to inform the decisions on the implementing acts in the future.
XTHR gave a building block that all the European member states can start from. We have a starting point, it's a great basis, it set the grounds.
So we are talking about an ecosystem that is being set up, and this is key for EHDS implementation.
We have the specifications. My understanding is that it is of high quality, but this is in paper. So now we are currently checking in practice.
What we mostly test is the adoption of what we call the European Electronic Exchange format that should be somehow adopted by all.
The test cases are mainly pushing or retrieving documents from a repository.
They can start interacting with the DTE. So not only on the workflows, so not only on the sharing of the document, but they can use DTE also for checking the conformance of the document.
Bringing all the participants together, all the manufacturers, provide them a place where they will work together, experience together, test the one against the other, is how they will learn about the EHDS and how they will improve the system and be ready for 2029.
The testing events, they are helping both communities, the users, in seeing if they have built specifications that are of good quality and that can be implemented, and the vendors to start preparing themselves for what is coming up.
We identified some gaps in our application. This is a great opportunity for that. It is always to identify them before and not after.
When you finally get into the test tools and talk to different companies, there are always small things that appear that you, oh yes, it should be like this, and then you fix it and test it again.
The Projectathon gives us an extra opportunity to be on the forefront of developing new content that can later be rolled out for data exchange through the European Union.
The testing events have a special role because they really gather the implementers of the specifications. They are also a way to try and fix something that is still in progress.
We can also help clarifying possible pitfall or gap that we have in the specification, so increase the confidence and the maturity of the specs.
We are testing our specifications and we will receive the feedback.
You need feedback, and you need to get the feedback and maintain and improve the spec.
We deliver something that it is testable and it's ready-made for mass production and widely adopted across the European Union.
The deliverables of EHDs, they're going to be adopted by the technical committees that are preparing the implementation acts, and this will, let's say, forge how the regulation is going to be made operational.
Our hope is that the Commission and the Member States will pick these specifications up so that proven specification can be used by the vendor community.
There is still some work to do, but from my perspective, we are like at least 80 to 90% complete, and as to my knowledge, there are no real big gaps here. It's only more like fine-tuning.
I think that the initial objectives have been met, even though we need to consider that further refinement and maintenance of the specification are needed.
The exchange format is described. The data flow will be seamless for these data sets.
There are other projects like I2X or XShare or other innovative projects that are relying on the specification that are developing.
The specifications we're working on are never ready. They need continuous updates, feedback from the market.
The exchange format can be expanded, needs to be expanded to cover all the data categories.
The European Commission has launched what we call the Exchange Format Support Center. So most of those EHDs specifications are going to be somehow continue to be maintained and extended.
The sustainability of the changes must be controlled with a correct roadmap.
There needs to be some sort of governance bodies that will continue working in this. I believe that this needs to be somehow professionalized in the future.
There is a gap between the medicine and the technology, and this is where we need to work really.
The safe and secure and well organized implementation of the regulation. These are the big challenges.
We need meetings between different member states. The success happens on local implementations and local deployments.
It goes to the member states because they need to implement infrastructure. It goes to the vendors who need to make their systems compliant.
The next step prior to having the implementing acts ready is to see how those can be transferred into specification and implementation guides.
We should not leave these results in deliverables. We should proceed with implementation.
We need to also educate the patients and the citizens and how to interact and work together.
We need now to disseminate.
The citizens which are getting this empowerment must be educated.
So they engage the healthcare professionals.
This is not the end. This is it's the end of extended EHR, but it's the beginning of the European journey.
Europe is stepping into a new era of digital health, one where your health data can follow you wherever you are. At the Ehds-Ai Connect in Brussels, experts from across Europe came together to test the systems that will make this a reality. The European Health Data Space is an EU regulation that will be rolled out step by step to allow cross-border healthcare by 2029.
Our vision is the one to create a European space for the data to flow, but not for flowing for nothing, flowing for the benefits of the European citizens. In first place, to give them access to their health data wherever they are in the member states, but also in another member states.
Behind this vision lies a major challenge. That's what we call interoperability.
Every country has its own national system with different, first of all, languages, different standards. In order to be able to have the citizens travel around, these should talk to each other.
But what precise information should be shared and how? These technical questions are shaping Europe's future health system, with answers only expected in 2027. Over the past 30 months, the Ehds-Ai project has brought together health authorities, industry leaders, and IT experts to design, test, and refine solutions that could underpin this new framework.
We have identified the general requirements for EHR systems. We specified the technical requirements, which are very important at this stage. Now we know what the EHR systems have to comply to.
We described the requirements for the exchange format and also for the metadata system, which must be implemented in the Ehds-Ai.
And then we have the conformity framework, where we specify how the systems will test and make sure that they are compliant with EHDs.
These new tools were tested during the Ehds-Ai Projectathon here in Brussels. For several days, developers, healthcare providers, and manufacturers worked side by side, ensuring they can securely exchange health data in compliance with the regulation.
Testing events, they are helping both communities, the users, in seeing if they have built specifications that are of good quality and that can be implemented, and the vendors to start preparing themselves for what is coming up.
Putting all the manufacturers together and provide them a place where they will work together, experience together, test the one against the other is how they will learn about the EHDs and how they will improve the system and be ready for 2029.
Significant progress has already been made with the foundations laid by the Ehds-Ai joint action, but building a truly connected European health system will be a long journey. Its success will depend on continued collaboration with member states and stakeholders, innovation and trust, placing citizens at the heart of digital health in Europe.
Our vision is the one to create a European space for the data to flow, but not for flowing for nothing, flowing for the benefits of the European citizens. In first place, to give them access to their health data wherever they are in the member states, but also in another member states.
You are taking your holiday in Cyprus, in a beach. Suddenly you are feeling pain, a chest pain. Your record, while they're giving you the first aid, will be readily available for the doctor.
Dr. A sends the clinical data of one patient or of one citizen to Dr. B, and Dr. B receives this data, and in theory he should be able to practice medicine by only reading this information.
So the citizen will feel secure without borders to have a better medical treatment.
Interoperability is key. You cannot have the exchange, the cross-border exchange of health data without interoperability.
Countries have their own national implementations.
With different, first of all, languages, different standards. We don't want to replace the systems and just evolve them in these standards.
We have so many different types of stakeholders. Finding the common ground and finding the common solutions which actually acknowledge all the different types of actors. That is the big challenge.
Work in a coherent framework, and everybody has to respect the regulation, mostly on privacy and also on clinical meaningfulness of the data exchanged.
We share e-prescriptions and patient summaries already today. It was a voluntary system, now it's a mandatory.
The main objective is to ensure the highway for the data stream will support better care pathway and better care.
European Commission, in collaboration with the governments, they are currently preparing the implementation acts, and this will be known the soonest in March 2027. We are trying to contribute and influence as much as we can to try not to reinvent the wheel so much.
We don't wish to reinvent the wheel. We need a pragmatic approach to these rules and to make a system that actually delivers for citizens and innovators. We are at full speed working on its implementation, but the time is very short. And we need actually all these inputs from different angles, different communities, to bring the EHDS to a reality.
It's a joint action funded by the European Commission to define and develop the guidelines and implementation acts for the implementation of the European Health Data Space Regulation. The development of systems that they talk to each other to exchange data while the citizen is traveling within Europe.
The regulation is defining what needs to be done, and then XTHR really specifies the technical specifications for how this will be done.
So we had to extract from those legal articles what would be the meaningful technical requirements.
We have identified the general requirements of EHR systems. We also specify the format, this EHRXF.
Which is the standards that will make this data flowing really across border.
We specify the clinical content, what we call the logical models.
Meaning the definitions, what information need to be shared.
We felt that IHE Europe and HSF in Europe really need to come together because it's a big challenge to really come to implementable specification.
The XTHR logical model is based on HL7 FHIR resources that are used along those 6 healthcare priority domains, as we call them. Lab reports, medical imaging, discharge reports, patient summaries, e-prescription and dispensation.
And IHE having the IHE methodology to create implementable specifications, use case based.
And regarding the transactional part, meaning the transmission of that content between the different actors, we have a work group which is an API work group.
XTHR was the bridge between policy and implementation. The main achievement is to give a clear picture of how this will be done and how this will be feasible in Europe. And I think it is clear, without surprise to the vendors, without surprise to the market.
It is bringing together member states experts, but also experts from different communities, manufacturers, vendors, to identify the central piece of the future, the system of tomorrow.
The XTHR was a project did assemble the opinions of the various member states.
The overall approach and overall specification has been agreed with the industry.
All of those guidelines, the technical specifications that come out of the work packages are going to inform the decisions on the implementing acts in the future.
XTHR gave a building block that all the European member states can start from. We have a starting point, it's a great basis, it's at the grounds.
So we are talking about an ecosystem that is being set up, and this is key for EHDS implementation.
We have the specifications. My understanding is that it is of high quality, but this is in paper. So now we are currently checking in practice.
What we mostly test is the adoption of what we call the European Electronic Exchange format that should be somehow adopted by all.
The test cases are mainly pushing or retrieving documents from a repository. They can start interacting with the DTE. So not only on the workflows, so not only on the sharing of the document, but they can use DTE also for checking the conformance of the documents. Bringing all the participants together, all the manufacturers, provide them a place where they will work together, experience together, test the one against the other, is how they will learn about the EHDs and how they will improve the system and be ready for 2029.
Testing events, they are helping both communities, the users, in seeing if they have built specifications that are of good quality and that can be implemented, and the vendors to start preparing themselves for what is coming up.
We identified some gaps in our application. This is a great opportunity for that. It is always to identify them before and not after.
When you finally get into the test tools and talk to different companies, there are always small things that appear that you, oh yes, that should be like this, and then you fix it and test it again.
The Projectathon gives us an extra opportunity to be on the forefront of developing new content that can later be rolled out for data exchange through the European Union.
The testing events have a special role because they really gather the implementers of the specifications. They are also a way to try and fix something that is still in progress.
We can also help clarifying possible pitfall or gap that we have in the specification, so increase the confidence and the maturity of the specs.
We are testing our specifications and we will receive the feedback.
You need feedback, and you need to get the feedback and maintain and improve the spec.
We deliver something that it is testable and it's ready-made for mass production and widely adopted across the European Union.
The deliverables of EHDs, they're going to be adopted by the technical committees that are preparing the implementation acts, and this will, let's say, forge how the regulation is going to be made operational.
Our hope is that the Commission and the Member States will pick these specifications up so that proven specification can be used by the vendor community.
There is still some work to do, but from my perspective, we are like at least 80 to 90% complete, and as to my knowledge, there are no real big gaps here. It's only more like fine-tuning.
I think that the initial objectives have been met, even though we need to consider that further refinement and maintenance of the specification are needed.
The exchange format is described. The data flow will be seamless for these data sets.
There are other projects like I2X or Share or other innovative projects that are relying on the specification that are developing.
The specifications we're working on are never ready. They need continuous updates, feedback from the market.
The exchange format can be expanded, needs to be expanded to cover all the data categories.
The European Commission has launched what we call the Exchange Format Support Center. So most of those EHDs specifications are going to be somehow continue to be maintained and extended.
The sustainability of the changes must be controlled with a correct roadmap.
There needs to be some sort of governance bodies that will continue working in this. I believe that this needs to be somehow professionalized in the future.
There is a gap between the medicine and the technology, and this is where we need to work really.
The safe and secure and well organized implementation of the regulation. These are the big challenges.
We need meetings between different member states. The success happens on local implementations and local deployments.
It goes to the member states because they need to implement infrastructure. It goes to the vendors who need to make their systems compliant.
The next step prior to having the implementing acts ready is to see how those can be transferred into specification and implementation guides.
We should not leave these results in deliverables. We should proceed with implementation.
We need to also educate the patients and the citizens and how to interact and work together.
We need now to disseminate.
The citizens which are getting this empowerment must be educated.
So they engage the healthcare professionals.
This is not the end. This is it's the end of extended EHR, but it's the beginning of the European journey.
Europe is stepping into a new era of digital health, one where your health data can follow you wherever you are. At the Ehds-Ai Connect in Brussels, experts from across Europe that will make this a reality. The European Health Data Space is an EU regulation that will be rolled out step by step to allow cross-border healthcare by 2029.
Our vision is the one to create a European space for the data to flow, but not for flowing for nothing, flowing for the benefits of the European citizens. In first place, to give them access to their health data wherever they are in the member states, but also in another member states.
Behind this vision lies a major challenge. That's what we call interoperability.
Every country has its own national system with different, first of all, languages, different standards. In order to be able to have the citizen travel around, these should talk to each other.
But what precise information should be shared and how? These technical questions are shaping Europe's future health system, with answers only expected in 2027. Over the past 30 months, the Ehds-Ai EHR project has brought together health authorities, industry leaders, and IT experts to design, test, and refine solutions that could underpin this new framework.
We have identified the general requirements for EHR systems. We specified the technical requirements, which are very important at this stage. Now we know what the EHR systems have to comply to.
We described the requirements for the exchange format and also for the metadata system, which must be implemented in the Ehds-Ai.
And then we have the conformity framework, where we specify how the systems will test and make sure that they are compliant with EHDs.
These new tools were tested during the Ehds-Ai EHR Projectathon here in Brussels. For several days, developers, healthcare providers, and manufacturers worked side by side, ensuring they can securely exchange health data in compliance with the regulation.
Testing events, they are helping both communities, the users, in seeing if they have built specifications that are of good quality and that can be implemented, and the vendors to start preparing themselves for what is coming up.
Putting all the manufacturers together and provide them a place where they will work together, experience together, test the one against the other is how they will learn about the EHDs and how they will improve the system and be ready for 2029.
Significant progress has already been made with the foundations laid by the Ehds-Ai EHR joint action, but building a truly connected European health system will be a long journey. Its success will depend on continued collaboration with member states and stakeholders, innovation and trust, placing citizens at the heart of digital health in Europe.
Our vision is the one to create a European space for the data to flow, but not for flowing for nothing, flowing for the benefits of the European citizens. In first place, to give them access to their health data wherever they are in the member states, but also in another member states.
You are taking your holiday in Cyprus, in a beach. Suddenly you are feeling pain, a chest pain. Your record, while they're giving you the first aid, will be readily available for the doctor.
Dr. A sends the clinical data of one patient or of one citizen to Dr. B, and Dr. B receives this data, and in theory he should be able to practice medicine by only reading this information.
So the citizen will feel secure without borders to have a better medical treatment.
Interoperability is key. You cannot have the exchange, the cross-border exchange of health data without interoperability.
Countries have their own national implementations.
With different, first of all, languages, different standards. We don't want to replace the systems and just evolve them in these standards.
We have so many different types of stakeholders, finding the common ground and finding the common solutions which actually acknowledge all the different types of access. That is the big challenge.
Work in a coherent framework, and everybody has to respect the regulation, mostly on privacy and also on clinical meaningfulness of the data exchanged.
We're sharing e-prescriptions and patient summaries already today. It was a voluntary system, now it's a mandatory.
The main objective is to ensure the highway for the data stream will support better care pathway and better care.
European Commission, in collaboration with the governments, they are currently preparing the implementation acts, and this will be known the soonest in March 2027. We are trying to contribute and influence as much as we can to try not to reinvent the wheel so much.
We don't wish to reinvent the wheel. We need a pragmatic approach to these rules and to make a system that actually delivers for citizens and innovators. We are at full speed working on its implementation, but the time is very short. And we need actually all these inputs from different angles, different communities, to bring the EHDs to a reality.
It's a joint action funded by the European Commission to define and develop the guidelines and implementation acts for the implementation of the European Health Data Space Regulation. The development of systems that they talk to each other to exchange data while the citizen is traveling within Europe.
The regulation is defining what needs to be done, and then XTHR really specifies the technical specifications for how this will be done.
So we had to extract from those legal articles what would be the meaningful technical requirements.
We have identified and the general requirements of EHR systems. We also specify the format, this EHRXF.
Which is the standards that will make this data flowing really across border.
We specify the clinical content, what we call the logical models.
Meaning the definitions, what information need to be shared.
We felt that IHE Europe and HL7 in Europe really need to come together because it's a big challenge to really come to implementable specification.
The HTHR logical model is based on HL7 FHIR resources that are used along those 6 healthcare priority domains, as we call them. Lab reports, medical imaging, discharge reports, patient summaries, e-prescription and dispensation.
And IHE having the IHE methodology to create implementable specifications, use case based.
And regarding the transactional part, meaning the transmission of that content between the different actors, we have a work group which is an API work group.
XTHR was the bridge between policy and implementation. The main achievement is to give a clear picture of how this will be done and how this will be feasible in Europe. And I think it is clear, without surprise to the vendors, without surprise to the market.
It is bringing together member states experts, but also experts from different communities, manufacturers, vendors, to identify the central piece of the system of tomorrow.
The XTHR was a project did assemble the opinions of the various member states.
The overall approach and overall specification has been agreed with the industry.
All of those guidelines, the technical specifications that come out of the work packages are going to inform the decisions on the implementing acts in the future.
XTHR gave a building block that all the European member states can start from. We have a starting point, it's a great basis, it set the grounds.
So we are talking about an ecosystem that is being set up, and this is key for EHDS implementation.
We have the specifications. My understanding is that it is of high quality, but this is in paper. So now we are currently checking in practice.
What we mostly test is the adoption of what we call the European Electronic Exchange format that should be somehow adopted by all.
The test cases are mainly pushing or retrieving documents from a repository.
They can start interacting with the DTE. So not only on the workflows, so not only on the sharing of the document, but they can use DTE also for checking the conformance of the document.
Bringing all the participants together, all the manufacturers, provide them a place where they will work together, experience together, test the one against the other, is how they will learn about the EHDs and how they will improve the system and be ready for 2029.
The testing events, they are helping both communities, the users, in seeing if they have built specifications that are of good quality and that can be implemented, and the vendors to start preparing themselves for what is coming up.
We identified some gaps in our application. This is a great opportunity for that. It is always to identify them before and not after.
When you finally get into the test tools and talk to different companies, there are always small things that appear that you, oh yes, that should be like this, and then you fix it and test it again.
The projectathon gives us an extra opportunity to be on the forefront of developing new content that can later be rolled out for data exchange through the European Union.
The testing events have a special role because they really gather the implementers of the specifications. They are also a way to try and fix something that is still in progress.
We can also help clarifying possible pitfall or gap that we have in the specification, so increase the confidence and the maturity of the specs.
We are testing our specifications and we will receive the feedback.
You need feedback, and you need to get the feedback and maintain and improve the spec.
We deliver something that it is testable and it's ready-made for mass production and widely adopted across the European Union.
The deliverables of XTHR, they're going to be adopted by the technical committees that are preparing the implementation acts. And this will, let's say, forge how the regulation is going to be made operational.
Our hope is that the Commission and the Member States will pick these specifications up so that proven specification can be used by the vendor community.
There is still some work to do, but from my perspective, we are like at least 80 to 90% complete, and as to my knowledge, there are no real big gaps here. It's only more like fine-tuning.
I think that the initial objectives have been met, even though we need to consider that further refinement and maintenance of the specification are needed.
The exchange format is described. The data flow will be seamless for these data sets.
There are other projects like I2X or XShare or other innovative projects that are relying on the specification that are developing.
The specifications we're working on are never ready. They need continuous updates, feedback from the market.
The exchange format can be expanded, needs to be expanded to cover all the data categories.
The European Commission has launched what we call the Exchange Format Support Center. So most of those XTHR specifications are going to be somehow continue to be maintained and extended.
The sustainability of the changes must be controlled with a correct roadmap.
There needs to be some sort of governance bodies that will continue working in this. I believe that this needs to be somehow professionalized in the future.
There is a gap between the medicine and the technology, and this is where we need to work really.
The safe and secure and well organized implementation of the regulation. These are the big challenges.
We need meetings between different member states. The success happens on local implementations and local deployments.
It goes to the member states because they need to implement infrastructure. It goes to the vendors who need to make their systems compliant.
The next step prior to having the implementing acts ready is to see how those can be transferred into specification and implementation guides.
We should not leave these results in deliverables. We should proceed with implementation.
We need to also educate the patients and the citizens and how to interact and work together.
We need now to disseminate.
The citizens which are getting this empowerment must be educated.
So they engage the healthcare professionals.
This is not the end. This is it's the end of extended EHR, but it's the beginning of the European journey.
Once again, test.
Thank you all for coming back. I hope you enjoyed the lunch. We will move on with Plenary 8, HDS-related projects cluster on primary use. I would like to welcome our co-chairs, Dr. Alexander Berler, Strategic Business Development Director, Ehds-Ai Catalyst, and Professor Henrique Martins, digital health expert from Portugal. Please take the floor.
So thank you very much, Melanie. So we are almost there. I think we have been a little bit of victim of the superfood and the super lunch that we have, so we will start slow. But nevertheless, and I think we have a super panel here, which in fact is the future. Okay, so what's next? So XTHR is ending, TEDA's pretty much same roadmap. We have now to plan the next, and we have a bunch of very interesting and very important projects that are continuing the work. So we will focus on those projects and discuss with those. Enrique, do you want to say a few things?
We don't have that much time for our panel, so let's give time for our panel speakers, but I'm very happy. And I think the only thing I want to say is that it's getting out of fashion, this primary use, so we need to rebrand it. So also welcoming your suggestions on the rebranding, so we keep everyone stimulated.
Okay, so let me invite to join us here Mrs. Catherine Chronaki, HL7 Europe, from HL7 Europe, and ICShare Scientific Coordinator. Thank you very much, Catherine, for being here. Also, we have online Zoltan Lantos from the Department of Health in Ireland, representing the My Health at My Hands project. I see Zoltan, he's there already. Also, from I2X and SHIA, how do you call it? SHIA project, we have also Professor Enrique Martins. I would like to invite also Alexia Preveza from IDICA, representing the EUVAC project about the European vaccination card. Also, the Assistant Professor Efthyvolos Kyriakou for the ECAN Plus project, also a very important project, and Professor Anne Mon from Gravitate Health. Please take, and we're sure we can start soon. So with that, the idea is to briefly present those projects. Each project will have 5 minutes to present itself and say exactly what are the important things they are already delivering and what is the things that they will deliver in their continuation and what we can expect, so that then we can make a good discussion about how those projects can support the primary use of data implementation, as we are now entering slowly in the implementation phase. So with that, I would like to invite Catherine to present the very important project XShare, the yellow button, and many, many other very important things. Thank you, Catherine. So here is the...
Well, it's a great honor to be here in Cyprus again. I've been working with Cyprus for the more like 20, 30 years now. And it's moving to be here to address in this important event in the context of the the presidency. So what I would like to cover in the next 5 minutes or so is what Ehds-Ai is about, and maybe invite you to join me in a call for action. So what is Ehds-Ai? Ehds-Ai is about what is in for me as a person, as a patient with EHDs. What is the value that citizens like you and me can capture from the EHDs? And this is about having access and control of our data. Yeah? So this is what it is. And the question is all my data, all my health data. So Ehds-Ai came in to expand the format beyond the 6 categories and say, what else do we need besides patient summaries and prescriptions and so on? Is there something else that we care about? Think about it, and maybe you can contribute there. We have a large consortium, 40 or so people, an ecosystem in itself, and we have a vision that we have a button, and this is my first recommendation at the end. We would like the implementing acts to have this idea that patients are empowered and citizens are empowered so that they can do something and get their data in a computable format, in the format. And we experiment with HL7 Fire as a proxy for the format. There are 3 pillars in Ehds-Ai. The first is the button, and this is part of my recommendation, as I said. Something that you can do to get your data in computable form. The second is the hub, the sustainability pathway that is based on collaboration and collaborative action, including also SDOs. And we have already established an entity, Ehds-Ai, that will last beyond the end of the project. And the last one is the industry label, something that we can recognize that a certain app or a certain portal can give us back our data. We also are thinking what and how. And the how is download, one-time share, linked options. But the most important thing is what else. And if you think about the priority data categories today, they are all passive. They are like an archive. So essentially, the EHDs is dead. What do I mean by dead? We haven't seen the return on investment yet. What can we do? Why does the EHDs deserve these huge investments? And I got the inspiration actually from our colleagues in Denmark when they said that every person deserves a care plan. Every citizen in Denmark has the right to a care plan. So what does this mean? It means that if you do a screening program and you find that somebody has high hypertension, then you give them a care plan. And that's their right. So what I would like your support with is to make a motion before the implementation acts close that we do have care plans. We do have care plans, not only as part of patient summaries and discharge report, but as a unique thing that you can use. We also have Marina, and Marina is the face of the EHDs. And this is here, in the 1 minute, I would like to share with you what a person like a teacher, 40 years old, can do in the EHDs. What is the importance of this thing that we are spending so much time on? She finds out she has hypertension, and then what she can do? She can go online. She can get her data. She can see how the data vary over time. She can find clinical trials and new medicines that apply to her, and she can enroll. And more importantly, she can be a catalyst. She can be a catalyst for her neighborhood and for her children. So Lao Tzu said that the journey of 1,000 miles begins with a first step. What I would like to share with you is that we indeed take this first step, work with the button, work with these new priority data categories like the care plans, and essentially give people what they need, give people the care they need, and really, really implement the European Health Union. Thank you.
Thank you very much for keeping the time so that we have enough time for discussion. I would like now to pass the floor to Zoltan, who is online. So, Zoltan, I hope that you can present My Health at My Hands in 5 minutes so that we can keep it as a landmark for the discussion afterwards. The floor is yours.
Of course. Thank you, Alexander, and good afternoon, dear colleagues. Thank you for the opportunity for joining remotely. And the My Health at My Hands project will extend the current My Health at EU infrastructure and service package, adding the Ehds-Ai wallet and the wallet ecosystem, and provide access to all European citizens. At least the technical capabilities will be available by early 2029, and 2/3 of the European Union has been involved and joined this initiative. So the wallet will offer a unique opportunity to citizens. And when we consider, on the next slide, we can say that when we consider the EHDs regulation, the wallet will facilitate, the next slide please, the wallet will facilitate to exercise our rights as natural persons in primary use. So the wallet will support the citizens' rights, data insertion, data control, consent management, and many more. And it's important to highlight that the Ehds-Ai wallet and the complete infrastructure is person-centered by design, because transactions are always initiated by the wallet. So the wallet-based transactions will always designed by the initiation of the individual, and this has several implications. And the next slide will present the highest level architecture. Here we have the infrastructures, national infrastructures on the right-hand side, called authentic data sources within the Ehds-Ai wallet framework. So here hospitals, EHR systems, as Catherine referred to, all type of data sources can be included, and in the wallet infrastructure there will be issuers. We already know that half of the member states will initiate and use one central issuers. Some others will be using distributed system or hybrid system. So an issuer will issue a so-called credential, a document which can be stored in the wallet, and different type of credential document types will be available according to the trust framework. Public authorities like national healthcare, national e-health contact points will issue public electronic attestation of attributes, and these credentials documents will refer to the data points. On the other side, so-called relying parties, so data consumer bodies will be implemented, and the relying parties can act as a hospital, and in the relying party, health professionals will consume the data. And here in the wallet, so-called data pointers can be included. So not the data itself will be included in the wallet, rather just the reference to the data source, and from the relying party, the data source will be connected. Or, for example, for immunization card, data itself will be included and stored in the wallet. And there are two types of connections and data transaction. One is the so-called proximity, in-person data transaction, where no online connection is needed, rather near-field communication or Bluetooth low energy connection is needed. And the other one is the remote online transaction. So here we have two additional layers And we learned in the first year of the preparation, the first year of the project, that context will be very important. And when we refer to the care plan, as Catherine mentioned, context is key, and at the issuer side and the relying party side, the context management will be key when the wallet infrastructure will be integrated into MyHealth.eu infrastructure. So I need to highlight here that the additional layer will be context aware, and all the transactional situations will be informed by the context. And at my last slide, so the next slide please, I refer to another approach. So the wallet can be considered as a gateway to our digital twin. When we populate and accommodate the European health data space properly, it will host our digital twin as well, and the wallet will act as a gateway, a connector to our digital twin. And when we consider the AI use, AI assistant will assist us during, for example, a care plan. A context-aware AI assistant can very well support us when the wallet infrastructure is well designed and properly added to the extended MyHealth.eu infrastructure. Thank you.
Thank you very much, Zoltan. So indeed, that was difficult to say all what you are doing in 5 minutes. Now I would like to make even a more difficult task. Ask Enrique to use 5 minutes to talk about 2 projects.
Thank you. Oh my God. The big challenge is to see my slides so far away. That is the biggest challenge. Okay, so that's one slide for me. It's the new acronym just created for today, I2SHIA. So this is a mix of 2 projects, I2, X, and SHIA. So very quickly, what is I2X? It's an implementation project. We like to call it me and Zoltan's sister project. They started in the same day, same funding approach, 50-50, which means that we are starting to have, in our case, more companies, also healthcare professionals, providers, and professionals, my CPME represented here and also in the room, to really implement the format. Now, you wonder, right? Yesterday and today, you were hearing about implementing acts and about the role, the important role of the joint action, and yet here's a project that has already started 1 year ago, implementing what has not yet been published, you see? And that is the capacity that we have for being creative in Europe. So we will have, I would say, the first 10 or 12 demonstrations, real demonstrations of the format implementation. Of course, we have to work with existing information. Next year, we will have more solid information. And the second aspect about this project, very briefly presented here, and you can then follow it through the key R's and all of that. Let me just jump for that. Is to convey 2 messages. One is that everyone's welcome. So open consortium approach. We are onboarding I think 10 more associated partners, but we're also creating this concept of special interest groups in industry and providers. Our vision for testing, and we have already provoked IHE to change their methodology or be changed by our methodology, is to start having pair tennis. So the next Connectathons, Projectathon or I2Xathon, we want to have a company and the respecting healthcare provider, or the healthcare provider and the respective EHR vendor, to come together and test against the other pair. So we want to test one hospital in Greece and their vendor with one hospital in Portugal and their vendor. That's how we believe. For doing this, because not all vendors are in the project and not all healthcare providers are in the project, we created these 2 groups so that we can start onboarding more people. So I'm going to skip all of this. So if you're interested in following the project, you can follow the QR, you can just take a photo or ask for the slides from the organization. Regarding SHIA, and there's several colleagues here in the room helping us out. It is the first, I would believe, to say, it's correct to say, it's the first Erasmus grant that we have been able to funnel to interoperability education. Of course, there's other projects hanging around in the Erasmus world, but also funded by ADEA on capacity building. And we've heard recently from Konstantin that there will be more calls from capacity building. Some people say, it was not me that said, that we will implement the electronic health record exchange format, we will implement secondary use, we will implement European health record, health data space at the speed of capacity. Eric from OECD loves to say this, at the speed of trust. But you can trust something, but if you're not ready to do it, you're still hesitant, right? So it is at the speed of capacity. And there is a significant problem of capacity. So in SHIA, we are basically putting together, I would say, the best knowledge, the best brains. We're calling them SHIA faculty now. We're going to invite several of you in the room to be part of our SHIA movement in terms of producing. What do we produce? We produce micro-content learning blocks, small educational pieces. Think of them like that. Maybe it's a video, maybe it's a PowerPoint, maybe it's some sort of interactive online thing that can be used online, can be also blended on face-to-face teaching. And the idea is to build the capacity on the topics related first to the format and the 5 domains, but then through our needs assessment, we came to the conclusion that we need to be more broad, we need to include things like data quality, cybersecurity for interoperability, and even overall European health data space legislation, what is the format, so these types of things. So you can follow this project. We are eager to have more delivery potential partners. So we have already also expanded the consortium to have partners that are helping us produce content. And then, of course, we need to deliver these contents, not just online, but on site, and not only on undergrads or master education, but, and most important, perhaps more important, on lifelong learners. So doctors, nurses, IT technicians, developers in companies. What are we doing? These are the educational pieces you can quickly read, more specific to the format, more specific or more general to interoperability. And I'm going to just invite you to also be part of the SHIA community of practice. And I want to tell you one thing, the project I submitted last week has no more new communities. It calls for a community of communities because every project comes up with a new community of practice or excellence, and I think we have too many communities by now. But in any case, thank you very much.
So thank you, Enrique. I think there is a lot of food of thought, and this community of communities, I think, is probably a good point of discussions afterwards, because we are also a community here. So a lot of communities. Now, I would like to move to the next one, also a very important one, which is the EUVAC project. And I would like to ask Alexia Preveza from IDICA to present the important work there. Thank you.
Good afternoon. I'm Alexia Preveza from IDICA. And today I represent the EUVAC project blueprint, our strategic roadmap for cross-border digital vaccination service under EHDs framework. EUVAC is an EU for Health funded initiative aimed at modernizing immunization systems. It focuses on high-level technical specification for a unified vaccination history service. Consortium. Our strength lies in 12-country consortium driving the standardized exchange of data. Greece, through IDICA, serves as the project coordinator. The paradigm shift. We are moving from a past where vaccination data was an optional, next section of a patient summary to a future where it is a standalone service domain. Why a standalone? This approach allows for frequent updates and dedicated management without interfering with broader health records. It ensures data integrity and real-time availability for routine and emergency care. The technical core. The technical core of UVAC is built upon the IHL 7 FIRE R4 standard. This ensures that our services are scalable and future-proof across all EU member states. Our work is fully aligned with the EHDs regulation, specifically addressing the priority categories of personal electronic health data. The semantic engine. We utilize international standards like SNOMED for diseases and Ehds-Ai Connect for vaccines, ensuring that a record from one country is understood in another. Security, trust, and legal compliance. By exploring my health attitude infrastructure, we provide the highest level of security and GDPR compliance for the European vaccination card. Let's say use case 1, clinical exchange and continuity for care. Use case 1 enables a healthcare professional abroad to retrieve a patient's verified vaccination history via the My Health Attitude network. Citizen from country A requests treatment at a facility in country B. Healthcare professional requests vaccination history, requests routes via NCP-B to NCP-A through My Health Attitude. Data is charted and transmitted back securely. History is instantly present on HP systems. Clinical provides informed treatment. The testing, batch testing, pre-production testing, connectathon drugs to target Web 10 routine operation. Use case 2, citizen empowerment via the UDI wallet. The wallet, citizen presents personal identification, credential at point of care, the validation, the retrieval, verified health facilities, instantly retrieves vaccination history via My Health Attitude. Use case 2 focused on giving citizens access to their own data through mobile application, digital formats. Use case 2.2, securely cross-border vaccination verification offline, enable a healthcare professional to securely verify a citizen European digital vaccination card without real-time My Health Attitude connectivity. Citizen generates a passive European digital vaccination card via national infrastructure. HP scans the QR code locally using the desktop web UVAC verifier application. No My Health Attitude network connection is triggered. Acceptance of CP089, the critical milestones. We have reached a major milestone with the adoption of change proposal, make vaccination history operationally ready to Wave 10 implementation. Wave 10 pioneers, the pilot nation Greece, Spain, and Cyprus, establish the LIVE blueprint for the rest of the European Union. In collaboration with projects like My Health and My Hands, we are integrating vaccination records in the EU2 Digital Identity Wallet for secure identification. Roadmap and pilot implementation. Current development, implementation leader, Greece, Spain, Cyprus. Impact beyond borders, delivering the EHDs vision, continuity of care, citizen empowerment, joint public health monitoring. Expected eHealth network is in action, acknowledge, formally recognize the UVAC functional requirements, technical specification, and the necessity of the CPO 89, standalone service shift, consult, provide EHN policy, guide on semantic, guidelines and review the proposed draft requirement catalog, commit, align national deployment strategies and organizational resources to support the Wave 10 rollout. The blueprint supports QR codes for offline verification and selective disclosure, allowing citizens to share only the necessary proofs while protecting their privacy. The blueprint's ready. We call upon EHN and HMSEC members to support the approval of change proposal, collaborate on Wave 10 integration and ongoing EU-DI world implementation, together with transition vaccination history, form an optional fragment on a standalone pillar of European digital health. Thank you for your attention.
Thank you very much, Alexia, for presenting this, I think, a very important project that is one of a real European use case. Okay, and it's an after-COVID effect, hoping that we won't have another COVID coming up, but next time I hope that we're going to be much more ready. Now, let's go to another project, which is another important domain, which is cancer. I would like to invite Efthyvoulos Kyriakou to present the ECAN Plus project.
Okay, so I have 5 minutes. I'll be fast. Okay. Okay, thank you. So the next project is the ECAN Plus joint action. I'm Efthyvoulos Kyriakou. I'm from the Cyprus University of Technology here in Limassol. Together with us, we have Robe from Sciensano. We are the leaders of ECAN Plus. Thank you for being here, Robe. Okay, let us start. What is the ECAN Plus? Okay. ECAN Plus is the second project. Initially we had ECAN, now that we went to ECAN Plus. This is a flagship project related to digital oncology and cross-border health data exchange. The aim of the project is to bring the benefits of digital health to all citizens, patients, and healthcare professionals in order to improve cancer care and prevention across Europe. The idea is to develop a framework to test and pilot the integration of digital tools. In brief, in the ECAN Plus, we have 23 countries, 81 institutions. It's a 4-year project, and the budget is 25 million. Okay, the vision of the project is the equitable access to digital health in cancer prevention and care, secure health data cross-border exchange, practical strategies to transform the digital health ecosystem around cancer. The objectives now of this joint action is to implement a comprehensive training program for digital skills development, one of the objectives, to enhance the digital collaboration among cancer centers, to explore the clinical applications of telemedicine in different cancer care settings. That is I guess that is the larger objective, and to bolster the preparedness for the European health data space implementation. This is another challenge that we are discussing for the project. Okay, this is an overview of the project. I'm not going to describe the work packages. Just in brief, the leading partner is Sciensano from Belgium. We are leaders of work package 8, which is the one that is at the bottom. That is the work package that is actually building the digital infrastructure of that project, of the project. We have work packages working on digital skills and digital literacy, work package working on cancer center communication, work package working on the application related to patients in order to cover the the needs that I had shown before. Okay, the main activities now. ECAN started approximately 1 year ago. Now we are going to move to year 2 from the beginning of May. Okay, the main activities are the digital skills training program to enhance that area, health data exchange and use cases by setting up virtual molecular tumor boards and test the protocols about these cases. The telemedicine implementation pilots, we are starting that phase hopefully beginning of around next October, if everything works okay. So the idea there is to test the framework on patients in different groups. We selected groups of patients that are active, under active treatment, patients that in palliative care or survivorship settings. Okay, as I said before, ECAN Plus is based on ECAN. We are updating what was done in ECAN, and based on that experience, we are actually evolving to a new framework and a more concrete way of approaching things. So the idea is to create a framework that will be able to cover the needs I had said before. Okay, and we expect to help in the improvement of care, reduce inequalities. One of the tasks was to include countries that have limited access to technology in order to try and reduce those inequalities that we have in such countries, and increase the preventive behaviors among the general population that we have in all European countries. Now, as I said before, the improvement of care and research through these applications is the main objective of the ECAN Plus project. Okay, that's it. Thank you. I'll try to be fast.
Okay, and let's move to the last one, which is also very important, related to the medication domain. So I would like to invite now Anne-Mon to talk about gravitated health and the important developments there.
Thank you. Thank you for the kind invitation to participate in this event. I will speak about Gravitate Health, empowering and equipping Europeans with health information for active personal health management and adherence to treatment. We are a public-private partnership, 45 members covering the full value chain. And what I will talk about today is Gravitate Health, and also how we can illustrate by our work, exemplify things that can, and improvements that can augment the European health data space priority categories, and I will explain you why. We are 45 partners, and we are from 15 countries or so. 12 of those partners are private. This work is all, I should also acknowledge that some of this work started in Expand the H and was boosted there. So Gravitate Health's public-private partnerships contribution in a nutshell. Allow me to draw your attention to the two pictures to the left. This is the tools and the artifacts that we usually offer patients to help them to manage their own health and do effective self-management. It's either a PDF or it is a paper copy. The point being, the point being that this is static resources. What we've done with Gravitate Health is to introduce focusing mechanisms to personalize or tailor this information, and that is a challenge because we are dealing with regulator-approved information and statutory sources. So in the GLANS that we have developed, tested, is a set of rules that's based on information coming with the patient summary category under the European Health Data Space, adding preferences and context of use. And I also recall that Zoltan mentioned that. We have worked with the electronic product information or the paper in the pack, health education material, and using the international patient summary as a window to a person's health information or health circumstances. And what we've done is to make examples of personalized, relevant presentation, either taking the structure of the product information and make it easier to navigate, highlight sections, augment sections with pictures or videos, and we've also experimented with AI-enabled summaries, large language models summarizing the content of the EPI. This is done in a way that is also the full source a click away, so that we're helping people navigate in the regulator-approved resource. We're about to end our testing. Testers says that this is easier to read because the papers have, as we know, small prints, and the copy may not be up to date either. And it's nice, others say that it is nice with the personalization and also that they have always updated information and that they can look at this in different ways. The personalization aspects and thinking about the use value of the European Health Data Space cross-border service e-prescription, e-dispensation, and adding the product information that's coming in many languages and with additional material as a strategy to mitigate reported problems from the implementation of e-prescription, e-dispensation in some markets. Translation, having access to information in the language of choice rather than as a complement to the language of the jurisdiction, is a strategy to equip us with more helpful information for self-management. This is also augmenting and amplifying the work and the processes of shared decision-making between patients and their providers, or in the dispensation scenario. So here's illustrated how you foresee cross-border, acknowledging e-prescriptions cross-border, dispensing information, having access to the database of product information in the language of choice, and you can also layer the GLANS functionality over the product information. This is contributing to equip us to fully benefit from the services that comes with the European Health Data Space. And I would also just quote one of our informants saying, there is no harm in a citizen-centered service in multiple languages. So this is also adding to the multilingual environment in Europe. So Gravitate Health has been and will, with our outputs, we will continue to be a catalyst for change, bringing patient-friendly product information and other statutory resources to augment European Health Data Space primary use services and bring this into the real world. We will have and host a closing conference. Gravitate Health, as a catalyst for change and as a testbed, is coming to an end. We are still engaged in digital labeling. But if you'd like to learn more, come to Brussels June 4th to join us for our closing conference, and then let's also discuss how our contributions can help bring real value of the EHDS primary categories, acting on experiences and driving change. Thank you.
Okay, so I think we have made a round of all the projects that we have. And I think, Enrique, you agree that we have a lot of things to do. I understood from the different discussions, community of practice, training programs, use cases, pilots in different cases. All the projects have some of those. So we already have about 10, 15 use cases that only from those projects that are there. So now the idea is to make the discussion between you, but also with the people in the room. And I think we maybe should start also, Zoltan is online. Most of the projects, they have some relation with the citizens, with patient services. So I think that the first part that we should discuss is how do we put the regulation into motion for the benefit of the citizens. And I would like to start maybe with Catherine, because I think you have a lot of things to say, and then pass the floor to Zoltan and anyone else who would like to say about that. And Anne, of course.
How do we get patients? Yes, I think this is a big challenge, in fact. You saw Maria. We tried a year ago to create an initiative, an adoption kit for citizens. And the feeling that I have, and I try to be critical because Ehds-Ai is now finishing up in November, it's very hard to engage patients. We are kind of locked into a cycle of the technology, of the digital, of the regulatory, of the semantic, and we miss the return, the low-hanging fruits, the things that would have an impact to citizens. And that's why I'm fascinated with care plans, because this is what takes the past, you know, all the exams that you make or the patient history, and look into the future. So what? You answer the so what question, yeah? So I had this lab exam and that was read. So what? What do I need to do now? And then speak with your health professional and have a dynamic kind of a care plan where you set goals and you follow up. I think this is one very simple thing that will engage us. And look at it from the perspective of policymakers as well. You have a screening program, all right? So you found so many people that had the problem. What do we do? How much it costs? What kind of interventions are we going to make? And does these interventions pay off? Do the people become healthier? Do you shorten the cost or you know, the cycle of the disease? So these are some thoughts about making it matter for the citizens. Thank you.
Thank you, Catherine. Zoltan, maybe, because we should not forget Zoltan that is online. Zoltan would like to...
Thank you, Alexander. I joined Catherine at the end that when we consider end-user values, patient value and citizen value, as I presented during the Ehds-Ai sustainability task, the end-user value must be evaluated, assessed. So health technology assessment, quality assessment need to be implemented. So whenever we implement a use case, cancer care, for example, or medication support, specific digital service, I would take this way, digital service, we should always describe the value, what we are able to create. And as Katrin mentioned, in Denmark, all citizens should have a care plan. The end-user value and the social impact must be evaluated. So joining Katrin in their considerations, we need to define the methodology, how to assess social impact and end-user value, quality, for example. And when we were in Athens at the Athens Digital Health Week, we had a panel where we agreed with Anne that, for example, for medication support, we need to find the low-hanging fruit. So whenever we embodied a person like Maria or any other citizen, we can easily identify the immediate benefit what digitally assisted medical support can provide. So we can formulate this as design thinking or reverse engineering. We exercised this at our annual consortium meeting 2 weeks ago. We ourselves are participant in the consortium, embodied specific use cases, specific personas, and when we acted as personas, it was obvious what a digital service can support and provide. So this is the way we need to define personas, define use cases, and evaluate, assess social impact and personal benefit. Thank you.
Thank you, Zoltan. Anne?
Yeah, thank you. I would like to say that if we get this right, and I will illustrate examples of right afterwards, there are endless opportunities. And by right, I mean that we should have services that are, if we really want to equip the citizens, we should have services that are developed with and on the premises and with the citizen as in mind as the primary user and not the secondary user of information that's produced by others. I would like to draw the attention to one of the deliveries from Gravitate Health. We have partnered European EPF, European Patients Foundation, and they have prepared a report on patients' voice with 10 clear recommendations for what we can do. I would like to add that taking literacy, health literacy, digital literacy, and building the capacity by combining personal health information, preferences, context of use with trusted information comes with a huge potential. And because the question is, as we open up for the EHDS services, and you can have the yellow button, or you can have the patient summary, or you can have the labs, what are you going to do with it as a citizen, as an empowered citizen of and a civil society member? So then thinking carefully about this, how are we developing the services that truly equip those the citizens, the patients? And of course, the foundation here is that we respect patient choice. There are some that cannot have enough of digital, like one of our ambassadors, Maria, that I showed you. But we also know that there are people that are hesitant, and we should make sure we cover that. We should have trusted services, and we should allow people to have a say in how they would maintain their integrity. So many opportunities if we get it right, but we have also to have systems in place of where do you put these things. We have the wallet, we probably need something more, but again, yeah. Thank you.
Thank you, Anne. So I'll pass the floor to Enrique, but I think you mentioned two important things that we can discuss after. Digital literacy, I think Enrique can follow up on that. And the infrastructure, so we have a lot of things that we can reuse. So that's maybe the second point that we want to talk, and then maybe Alexia can talk about a few things related to the vaccination card, because it's reusing all this infrastructure. So, back to you.
I just wanted to add two things. One is this idea that if we don't do it with the patients, we're not doing it for the patients. So, for example, in Chia, we had an interesting discussion in the kickoff meeting whether we should build blocks, learning blocks for patients. And we decided that it was out of scope, and that as long as we did a good job in implementing and helping implement interoperability, we were actually doing a good job for patients. On the other hand, in I2X, we found that, again, while the focus is implementing the format in a way that it is easy to use for professionals, we came to the conclusion that if doctors are happy using their electronic health records and not getting even more irritated because now there's this additional thing, they will do a better job for their patients. So I want to highlight this. However, in Expand EH, which is not here featured, but anyway, it's connected, we also learned two things. We do not have, you mentioned we have a lot of infrastructures, we do not have a patient engagement infrastructure. We have IPF, we have 2 or 3 European level infrastructure associations. When we go to each country, we lack basis. We get meetings. In Madeira, we had 2 patients showing up, and they tried really hard. I think they even went into the streets and tried to get them into the room. We tried an engagement session that was a little bit more successful in Athens and so on. So we need to find ways, not just to measure, as Zoltan was saying, value for patients, but how do we go? So in Expand, we had to go language by language. We did online meeting in Portuguese, in French, in German, and on total maybe 40 patient associations. But we need help. And where do I think the help is in the national digital health agencies and in the new HDAPs to be formed. These national level institutions should have or have access to patients and patient interaction. And we need to find a way to go back to these institutions during the project and test our ideas with hundreds of patients. We're not doing this yet in any one of our projects, hundreds of patients. This is what large companies that deploy solutions online and they get 2 million in one day, this is what they have done in the past. They have found a way to interact with millions of users, and that's why their products come sharp to the market. So we haven't found how to do that. Maybe we need another project. Or we just need to change our attitude and work with those that have patients. Hospitals have thousands of patients. Primary care centers have even more patients. So, and then there's patients here. We rarely, for example, use our staff in the project to test the project technology, which is something that many IT schools do. You know, they put all their PhD students to do the thing. Anyway.
All very valid points, I guess. We need to pilot more and interact with all of us, the citizens, right? So, Ephthybulos, I think in the cancer track, it's all about patients and citizens, right? And you have a training program. So I want to see a little bit the synergies on the training thing, the capacity building, which I think is very important, both on the provider side, but also on the citizen side, as Enrique really mentioned, and Anne as well said the same thing.
Yes, yes. Hello? Okay. Yes, I agree with all the comments that I have here. Okay, some of the things, the things that were said before, I mean, in order to make a system useful, it has to be done according to the needs of the patient, and acceptability is the first thing that you have to do. So, in order to achieve that, we have to ensure all the things that are happening. Now, about the synergies between projects, this is something indeed that several projects are doing similar things. So this is something that we have to, we have to put some more effort to do that. I mean, by just doing common meetings or exchanging things, or for sure a lot of things can be used or should be used from one project to another, or between projects, the infrastructure, for example, that is being done or being developed in a project, and all these things. So indeed, that's a gap that we have to take care of.
Okay, so I guess you will work with SHIA project to do this micro-training for the cancer patients. So I hope that's a good point. Now, this is more or less what we call project synergies, and all of you are somehow collaborating one way or the other. There was MOU signs with different projects, especially with XTHR. So I would like a bit to focus on the inter-project synergies, because we need to work in a cluster way. And maybe, Alexia, you can say a few things, because you have worked in parallel with both XTHR and My Health at My Hands, which means that then Zoltan can say a little bit, a few things about this cross-project collaboration, and also with the sister project I2X. So then, Alexia, Zoltan, and then back to you, Enrique.
Okay. I think that interoperability goes beyond technology. It requires alignment, governance, and trust, while keeping the citizen at the center through accessible and user-friendly service. They can accelerate implementation by focus on scalability, interoperability, and integration to a national system, while supporting adoption by healthcare providers.
Okay. Zoltan, do you want to extend a little bit the discussions and the common work, and also how you are reusing things? I mean, you are one of the major reusing of European architecture, 2 architectures at least.
Yes, the collaboration with EUWAC is very smooth by now. We have regular meetings, and we always harmonize the steps, and also harmonize what we represent to the MSAC committee, so the My Health at EU infrastructure, wave-specific coordination is also in place. So we established a common working group. So this is key, to establish a common work group. When we consider the sister project I2X, we have even a common work package, work package 3, the testing environment is a common work package. We cross-reference to other projects, so we can say that we have a common work package in the 2 projects. So the key is the established working group, where we are able to discuss all details and get aligned, and regular meetings and joint development, joint testing is needed. So when we consider the approach and the operation, this is key to establish common working groups.
Enrique?
Thank you.
So project interoperability is an issue, okay? It's a legal, organizational, semantic, and technical. Very fast. Legal, we are doing MOUs, finally. And you know, it seems that it was always the case, but it's not. It's something relatively recent. Maybe a few years ago it started. Now it's almost common law. Organizational, we are starting to have meetings where we try to schedule the events in different weeks of the month, of the year. So we had a shared Excel. We might need to share it with more projects. We even had 1 or 2 meetings with some projects. And the Commission has changed attitude a lot. The Commission is now demanding these cross-border, cross-project conversations a posteriori of the grant agreement, which is an issue, because I think one of the problems of us redundancy, and sometimes redundancy is not necessarily bad, but in any case, is because when people are writing the project, they are not aware, or they don't do a diligent work of knowing what projects are out there. But also, they cannot do a diligent work because sometimes there's a delay between a project being submitted, the project starts, the project puts their things on a website. Maybe it's 1 year. So maybe it's not that we didn't want to know about these other projects starting, is that there was no way of us to know. And then we realized that we wrote in our work package X task Z, which is actually the same as the other one. So that's the second dimension. Then the semantics dimension. I'll give you an example. Being part of a few of these projects, I decided to run a meeting between ex-chair colleagues on care plans, I2X colleagues, including myself, on pathways, care pathways, and I think it was Zoltan as well, on their pathway whatever, care whatever, okay? We were all talking about the same thing, you know, patient journeys, patient pathways, care plans. Of course, they have slightly different things, but we need some sort of common semantics when we're describing these things. And so we are finding our way. The best way is to discuss. So we've had 2 of these meetings already, trying to find synergies. And that brings me to the final one. The final one is the investment, the lost T. The technical, we now have an infrastructure. I think Zoltan has done a great example. Because we have MyHealth.eu, because we have others, we now can orbitate around existing infrastructure. And we plug and play more things into that infrastructure. We started talking about government-to-government data exchange, the open NCPs. Now we talk about peer-to-peer, using the wallet, using the button. And I think most people do not have this in their brain, how there's maybe 2 or 3 people that could get together and write the blueprint of the architecture, beyond the official architecture, the new coming architecture. And finally, the I, money, investment. Most projects do not budget any person months for inter-project work. Then in the middle of the project, we email them and say, so let's have a meeting. Let's put our work package leaders to talk to each other. Oh, we have no resources for that. So here's a project with 24 million and another project with 19 million, and they cannot take 1 hour a month to talk to each other. This is bullshit, okay? This is bullshit. I'll repeat, this is bullshit. It's a duty of the coordinator to take time to talk with any other project. It is a responsibility. It is our irresponsibility to deliver non-interoperable solutions out of our interoperability projects. This is complete nonsense. And stop blaming the Commission. It's not the Commission's fault. It's not the Commission that writes the project, and it's not the Commission that criticizes the deliverables. It's actually experts, which happen to work in other projects which are also not interoperable with each other. So they put a different hat and they sit as readers of our project and they argue that that deliverable is not good enough. So in conclusion, I think we have a lot to do for the primary use of our own project. That's a personal suggestion.
So Enrique, you touched an important point, which is human interoperability and project interoperability. Now I would like to pass back to Catherine, because EHDS is a little bit more in advance, so there is more knowledge there than maybe in some other projects. And there is an open call going on as well. So maybe it's a good opportunity for interoperability in that sense, on one hand. And there was also the other magic word that Enrique mentioned, is the care plan. So because to touch on one of the 2 important things in EHDS. And then I will make a similar question to Anne.
So yes, in fact, I had to make a difficult choice when I created this talk. Today we had a revisit of the open calls. It's about 400,000 euros that Ehds-Ai is giving out to companies that will implement the yellow button. And in fact, the way this is organized is that we are seeking companies that will put in their app or on their portal the yellow button of their choice. And depending on the number of priority data categories that are able to download, share, upload, they will receive a complementary amount of money. To do that, they have to go through the process of an online testing through the IHC online facility now, and then an evaluation through a committee. What is important is that if they have a solution that involves patients, they will get extra money. And there, the question is how many people you will involve, how they will involve, and testimonials. So if you know companies or hospitals that have such a portal and they have a patient-facing component, please let them know there is some funding from them. I would like also to take the opportunity to speak again about care plans. And I was very much impressed by your presentation on EUVAC and also, on your presentation about cancer and ICANN. And I noticed something that goes back to the previous session we had about primary and secondary use. I don't know how many of you in the audience noticed that both of these projects are projects that are about population health. They are public health projects in the context of prevention. There is a gap there. There is a gap that I feel the need to share with you all. There's a gap about the action, yeah? So you had in your slide preventive actions. What about therapeutic actions? How do we connect to those? Because this is the part for me that could optimize the health system, that could use the data to make care better and measure care, measure the impact of programs. Same thing with the vaccination. You were talking about vaccination history. This is the part about the past. What is your patient summary up to now? What are the labs that you had in the past? It doesn't say anything to the mother that has a young child and is facing in front of her a set of vaccinations, right? This is the part that I would like to see, and that is another type of care plan. And it talks about the future, and it talks about effectiveness of health system activities. And I think this is where we will capture the low-hanging fruits from the HealthDS.
Thank you, Catherine. So I think now we deserve to ask Efthybulos and Alexia to give a response so that we make it a little more interactive. And then Anne, of course, I have not forgotten you.
Okay, so I'll start with that, about these are very nice comments indeed. And okay, I'll talk about the project that we are involved with, Rob, and the idea is not to set something only for prevention, but this is something that will be set up to support the patients, and mainly that is the case. Perhaps I didn't give too much attention there, and to support and show the usefulness of these tools for the newcomers, if I could say that, or improve them and show them how these things could improve. I mean, something that was discussed before, the flow that we have in the process. So that is the idea, and I agree with you that these projects should pay too much attention there, and that is indeed a very good comment.
I would say this is exactly where UVAC can make a difference by fostering collaboration, building trust, and enabling practical solutions that member states can usually adopt and scale.
Okay, so Anne, you are very experienced and you are leading until July, but I guess you have already started a new one, these public-private partnerships. So I think I would like your expert opinion. How can we involve this public-private, so that we, as Enrique mentioned, we need to generate some investment, something new?
Well, I was expecting a little bit of a different question, so let me start by inspiration from the other speakers also on this panel. I think it is important that we shouldn't only look at health data in isolation. We should make sure that there are sufficient resources for sense-making. Essentially, an EHR is an accumulation of the past. A care plan, the way I was taught, is a future-looking document. And I think that distinction is crucial. When we talk about, but the third element here that I would like to bring in is information from trusted sources. And I would stress trusted sources. I align with the recent WHO communication on and a call to collective effort to be active, go to action on fighting misinformation. Because if we should know which vaccine to take, which sign, cues, symptoms, personal experiences to pay attention to for ourselves or for others, to differentiate if this is a thing that we can prevent or if it's something we need help immediately. Think about cancer. Think about the sudden the development of cancer. Think about making sure that you follow the vaccination plan. You need the information of why is this a good idea, and you need the evidence that this is safe. So to public-private partnerships, I like that. I've been working and been coordinating one for 5.5 years. We just had the kickoff of a new one. They are both on digital labeling. And this is an example of a carefully developed, regulated, specified, trusted source that we could put to use. And with the public-private partnership, and these, the challenge that has put forward to us to put this information to use also comes from the industry and the producers. So creating these private-public partnerships, pre-competitive spaces, fleshing out aspects that needs to be solved by everyone. It's a little bit like infrastructure. So keeping that in mind, and then of course the complexity of a public-private partnership increases because there are very different logics in those projects. So the clarification, making concepts, testing ideas, bringing them forward for future exploitation is a good thing for a private-public partnership if it's a pre-competitive thing. I think we face the same challenges as anyone else when it comes to exploitation of project outputs, because that is when you really also need to focus the attention. Get them into the programs, and the project is one thing, it helps. But right now, if anyone in the room also has good ideas, please come up to me afterwards on how can we collectively continue to bring these outputs. And it's very often common goods, European Health Data Space, liberating the health data, adding other resources. It's common goods, and how can we collectively put that to better use? I think that's how far I can get now. Thank you.
So I think we covered a lot of ground. Now I would like to see if we have some questions from the audience, and we have also the Mentimeter, so we can maybe bring the QR code of the Mentimeter while some people might want to ask the panel a question. Okay, let's start with the Mentimeter, and we go back there. So the first question is, what is the biggest contribution of the EU project to the EHDS implementation? It's too far.
Then I'm not so much a fan. I always like to have conditions, and you can hear that I have long answers.
So it seems that we have a winner to this one, right? So we want to use the projects as an accelerator to accelerate the adoption of the regulation, right? And to increase the member states' readiness. So I think that's an important role. So, Kostas, should we proceed to the next question? So what is the biggest barrier to moving EHDS projects from pilots to routine use? That's a difficult one. Okay, I think here again we have one that is a little bit more striking out, like the integration into the national infrastructure. So I think that's an important one, and it has also been discussed also in EHDS. We discussed about that. So how do we relink all these specifications and the technical work with the real life things that are happening in the member states? So how the regulation will influence, in fact, the real implementation, and also we need to see how all these projects and so many others that have not been there. So, a question. Do we have a mic? Okay. So,
thank you, and sorry for the intervention. Just to mention that they are already interconnected to the national infrastructure because they were pilots, and we just needed to, we can have the previous slide.
Yeah.
From pilots to routine use. So if they are pilots, they are already integrated into the national infrastructures, right?
You're right.
So, just to mention it. Thank you. I voted for the, can we have the slide again? Adoption by healthcare providers, in my opinion.
Yeah.
And patients, if you ask me.
But I would say that some pilots actually are piloted in a local setting and they never got integrated to the national infrastructure. That's why they don't survive. Many projects, they do the pilot separated. Sometimes they don't even, maybe they shouldn't call it a pilot. That's another conversation. It goes back to the semantics of the project.
Okay, so now we have an additional panelist. Thank you, Yanis, for coming.
A new member of the panel.
Someone wants...
Self-invited. Thank you. So if they are pilots, they are already in production. They are already interconnected to the national infra, in my opinion. So that's why I mentioned it.
But if we call them prototypes, if we call the outputs
I will make the drone mic, if I may.
Well, yeah. I have a question. There are so many projects and there are so many pilots. Which ones do you think they are going to be implemented in the real world? So maybe I have a proposal. Maybe the Commission should see the results of the projects and maybe choose projects to go further, because I have a question too. How many projects for cancer, and then which one will the national authority adopt? Which one? So maybe we should create a community that see the results, see the effectiveness of the results, or see which adoption is already being done, and then go further for the Commission now, I'm thinking, go to the next step. That's my proposal, because you asked about the vaccines. In Greek, we have the digital vaccine record for child. So in Greek, mothers have their vaccine record and have the schedule for next vaccination period, and it is digital. So when we have already these, then we propose the European vaccine card, you know. Thank you.
Can I make an observation from?
Yes, of course.
Since I'm from the +1, you know, EU have 27 countries. I'm from +1 Norway. We do have what I wanted to suggest. Maybe we should actually discuss this notion of pilots in the wild, because that's essentially what you are alluding to. That we have pilots in the wild. I do think that sometimes integration in national health systems and health infrastructures is challenging, because the maturity of digital implementation varies quite a lot across Europe. I can just give you an example, if I may. I'm not a child anymore, but I do have a vaccination card. But the difference between the child vaccination program and the adult vaccination is also that I have to make the decision to go and take that vaccination as an adult. Parents are more likely to accept and follow the vaccination of their children. Yeah, so there is this notion of information about and sense making. Why is this important? But again, maybe Enrique likes to coin terms. I would take ownership of pilots in the wild. Thank you.
I went to ChatGPT quickly, actually Gemini, to check for the definition of pilot. And of course, there's answers for both. Large-scale integration or small. Anyway, my point is, I think when you raise I have to say, having been in sort of the equivalent shoes in SPMS in Portugal, I remember being bombarded with EU projects, and you get really nervous, because you either say no to everyone and you feel like you're the non-implementer of all the innovation, and if you as a president say yes to everyone, your teams kill you, because they are forced to implement 3 things in slightly different ways. So I completely agree, we need 2 things. We need not just the decision-making of go, no go for Europe, but we need more than that. We need a European architecture, detailed architecture. And we cannot get that, in my opinion. I've said this in other forums, I'll say it, I get the opportunity now. We are getting to the point that we need to have at least a technical architecture / enterprise architecture team sitting somewhere between Iceland and Cyprus, or between the tip of Norway and Madeira, but somewhere, okay, I'm not saying Brussels on purpose, could end up in Sensano. But my point is, we need what we call enterprise architects and technical architects to say, okay, this project has been validated, these assets make sense, they need to be refined, and they go into the pipeline. Now, the Commission, and to conclude, when in Expand we started doing what we called bubbles, so looking at the implementation of the format, we were told you cannot pilot because you are a CSA. There's the innovation. To Catherine, she was told, you're an innovator, a disruptor. You innovate, but that doesn't mean we will ever use anything you're inventing in next year. It's an innovation project. And XTR is a formalization project. You guys make it quasi-implementing acts, but don't call yourselves the authors of the implementing acts. That's us, the Commission. So we are building, in a way, an architecture of these decisions. But I completely agree we lack two things. One that Zoltan mentioned, you mentioned as well, but in different angles. What are the evaluation criteria? Now we say, okay, this was good, this was not so good, this needs further evidence. This is good enough. We can go out and roll out into 27 plus 1 or 2 member states. And finally, I think we also need, especially in the cancer world, for example, we're going to, promoting a little bit, we're going to do a meeting on the online 3rd of June, a quick meeting on interoperability and cancer projects to try to see if we can put the people to talk to each other. That's the first step. But yeah, I can imagine how hard it is at the national level to try to actually implement all the things these projects are coming up with. But for example, I think the button works with the wallet, right? This is something to be refined. In the case of the wallet with I2X, last month we already did joint testing of the 2 projects. So I think also projects are getting a little bit more implementer-friendly by presenting a more all-encompassing solution. I think that's a responsibility of the project coordinators.
But I'd like to go back to something Mrs. Chuma said that I think is quite valuable. She said that we need to go beyond the pilots, and there is a gap there. And this is, above all, a financial gap. And I will share an example. We are talking to Tixalut in Catalonia, and they are doing a real implementation between a private hospital and the public health system, where the citizen can take their patient summary or discharge report and import it into the health system portal. And I was saying, okay, you did it, you will do it. Why not go in production? And the answer I got is that we are a serious private hospital. We don't do things like that. We need to test it. We need to have a call center for the citizen. We need to invest there. So I think you have a very good point, and maybe this could be a takeaway message, that there is some investment and some startup funding for things that have matured to go into production. I am a little bit disappointed that we don't have enough of that. For me, the yellow button was obvious. It's actually obvious, you know, if you want to give citizens a right, the way to exercise their right, you should do it. But things are more difficult. So I would say mind the gaps and also pay attention to details. And we are close. We can make it happen, but we need to be more careful of the details and invest in bridging the gaps. Thank you.
Okay, so one comment from Efthiboulos, and then we need really to go to the final closing statements, because, I mean, they told us that we would not have coffee, so I think it's important. So, Efthiboulos.
If we are over time, that's okay.
Okay.
Okay, I'm just going to answer the question about which projects can be implemented. Okay, we know each other for
long time.
A long time, and also Ghost does. We just have one case that a project was applied and is being used. And that project, okay, is not related to cancer, and the project that we presented here is actually the project that is supporting the local ambulance system in Cyprus. Okay, first it was a decision to apply that project, then it was integrated in the system, and one of the main parts was the acceptability. So if we didn't have this initial decision to apply that project from the management and from the government, and then the integration of that project in the system, not changing the system, that project grown up with the system, and the acceptability from the users, I guess that these are the parts that also go for these projects. Okay. If somebody is not, okay, the project has to be mature, I mean, technologically has to be at a level that should go, security and all those things, that we all agree on that. But if somebody is not taking the decision to start it and then do it seamless in the procedure and all this, I mean, you have no chance. Okay.
That's my, my opinion. Thank you.
Thank you, Efthybulos. I remember this ambulance case, we started it, it was still the last century when we first discussed about the ambulance case. So I would like to have a closing statement from Zoltan, and then we start with Anne, and we close with Enrique.
Regarding implementation, the good news is the Manhattan project will implement the wallet. So by the end of the project, the service will be available for all, as I mentioned. And the good news to Enrique that because it will be implemented, the architecture design is already available in the eGovera system. So please review your email, what you received regarding the analysis building blocks of eGovera. The architecture design is ready. We will continue with the solution building blocks by June. The digital health public service architecture design will be available for all in Europe. Thank you.
Thank you, Zoltan. Anne?
The European Health Data Space comes with a set of rights for natural persons. We saw that from Zoltan's presentation, and we discussed that. And to fully benefit, we need to support the sense-making. What does this mean? So I have prepared and presented and discussed an example where personal health data and trusted health information comes together to support that sense-making. And I think taking advantage of information that is already available in multiple languages and be mindful of user capabilities, health literacy, digital literacy, preferences for use will be an important step forward to make sure that we fully leverage the European Health Data Space opportunities that we have got with that legislation. Thank you.
Thank you, Anne. Alexia?
Ensure the sustainable integration of project outcomes into national health system to move from pilots to real impact.
Thank you very much. Efthybulos?
I think I did the final statement, so...
You're done.
It's okay with me.
Catherine?
Yes, I would like to reiterate my point that we need to look also on how we are going to use the health data space. And it seems to me that a collaboration among member states into care plans and perhaps also vaccination plans as the next steps for priority data categories would be a good idea, especially if it is backed with the methodology of WHO on smart health guidelines, because that will directly involve also the physicians. Thank you.
Enrique.
Well, my statement is a big thank you to this meeting, because I think the joint action, right, in a way, in the presidency, is welcoming projects, and I find that there's always a risk of a gap between the formal structures and the sort of the project, right? These projects that people win and they last for 2 or 3 years, they irritate with a bunch of new ideas, and off they go. Oof, this one is ended. We don't have to pay attention to them anymore, and hopefully their deliverables will disappear into the ether. We are moving out of this logic. We see with the EMSEG, we see even with the joint actions, that there's this proximity. Sometimes it's the same people wearing different hats, and we know they have to behave differently. But why am I saying this? We will go into a next phase of formalization, as the implementing act for the European Health Data Space Board has been now discussed and will be enacted. And I fear, just a fear, a careful fear that I think we can manage easily, that we will have a little bit of over-formalism in the next couple of years. And this gap between the formal structures of the governance of the European Health Data Space, the official structures, the official governance, the official architectures, may be far away, and this then triples down to the national level, same problem, and then moves away from the project. So I think we need to work on this gap, maintain very close and sometimes difficult bridging, continuous bridging. This links, for example, with work that Anne did with Emma for many years in Gravitate. And different examples exist between the formal structures and these, disturbing, positively disturbing, irritatingly innovative, perhaps less structured structures that are called projects. And finally, I also like to talk about initiatives. We also are seeing things like the Connectathon, not because of IHE or not IHE, it became a momentum moment, right? We were there, we talked, we tested, we ran together, we ate together. So it's community building. And on that front, this meeting also was incredible because you brought primary use and secondary use really together. Not just in one panel, but we are starting to mix honestly different partners in different new consortiums that we are forming. And I think these are the next steps, critical steps, to build one European health data space and not two European health data spaces. The primary, once I saw this in some sort of document, I think from one of my teachers, European Health Data Space 1, European Health Data Space 2. And I said, what is that? Delete immediately. This is the biggest risk. It was always there, so let's not perpetuate. So yeah, thanks for the opportunity to, I was also moderator, that's why I abused a little bit of my time. Huh?
So I think we can keep the closing statements of Enrique as a co-moderator. I would like to thank all the panelists. I think the continuation is in the hands of those projects and the future one that will come. I would like to thank the organizers and especially Yanis and Nikki that contributed to the discussion and ground us a little bit into reality. So thank you very much, everyone.
Okay, thank you to our co-chairs and our presenters and our participants, as Alexander said. And we will have a short break for 15 minutes. 15 minutes, yes. I think it's more than enough after the lunch we had.
I have a background sound.
I hope all of you managed to grab a cup of coffee. So let's move on with our final plenary, an EHDs related projects cluster on secondary use. So I will ask our chair, Dr. Maria Papaioannou, to take the floor. Thank you, Maria.
So, welcome everyone who were here to the Plenary 9 on EHDs-related projects supporting the secondary use of health data. And I would like to thank everyone for staying with us during the last plenary. And why the earlier discussions were focused on the primary cluster of projects, primary use cluster of projects. This session turns to the secondary use dimension of the European health data space, which enables the responsible use of the data for research and other secondary purposes. So across Europe, there is a growing number of initiatives that are addressing the key building blocks for the secondary use. And our objective today is to explore how these initiatives can move beyond the project environments and contribute to the trusted, scalable, and sustainable infrastructures across Europe. So we will begin with a series of short project presentations, followed by a moderated discussion and some, if we manage with time, some Mentimeter questions. So our first project contributor comes from the capacity building for secondary users for health data for the European Health Data Space Project. And I'm pleased to introduce Federico Paloa Arvizu from Digital Health Executive. He's a Digital Health Executive Manager at NTT Data, who is with us online. Hello, Federico. And from the same project, we have Dimitri Etan, Health Data and Interoperability External Advisor at NTT Data, who is here with us in the room. I understand that Federico will do the presentation. Is that right, Federico? Can you hear us?
Is it?
Okay, so welcome, and the floor is yours.
Thank you very much. So good afternoon, everyone. I guess you will share now the presentation in a moment. My name is Federico Palau. I work in digital health, and as said, I'm an executive manager at NTT Data. NTT Data's consortium leader, and together with Empirica and PredictBuy, we are delivering DigiSanté's capacity building project for secondary uses of health data within the Ehds-Ai. As said, I'll be doing the presentation online, and then my dear Dimitri Etin, NTT Data external advisor for this project, and many others will continue on site. So are you seeing the presentation? Because I cannot. Okay, yes. If we go to the next slide. I'd like to start with the following idea, which is somehow central to the work we are doing in this project. I believe the outputs of this project, especially training materials, will represent the entry point for a good amount of the professionals and public officials that will be participating across Europe in the Ehds-Ai for secondary uses. Many other projects, of course, and results will enter into play to address the technical depth and complexity, of course, that this implementation process requires, but a central element of engagement and onboarding will be the results of this capacity building effort, and that is why I think this project is important. In that regard, the project has the objective of supporting national competent authorities in establishing HDAPs, in establishing health data access bodies across member states. To do this, we are managing 3 different work streams. First, we are designing and delivering training programs covering 5 key digital business capabilities. The exercise here has been to basically collect and consolidate through a pedagogical lens most of the materials produced across the ecosystem, not only, but especially from TEDx2 efforts. Second, we are putting together practical tools that can support national implementation in the form of a toolkit. This will go hand in hand with the training program. And third, we are monitoring progress so that implementation can be tracked, and such tracking can then inform international operations over time. So what does this mean in concrete terms? If we go to the next slide, we are working on the core components, let's say, required for the secondary use of health data within the HDS. You all know these 5 DBCs: National Health Dataset Catalogs, Data Applications Management Systems, Health Data at EU Connectors, Data Quality, of course, and SPEs. Alongside this, transversally, we also address the fundamentals required to establish and operate such HDAPs. In terms of delivery, the project is already producing tangible results. We will see one in a minute. We are currently starting what we could name, let's say, the last stage of the project. From the training program perspective, we have developed 11 training modules covering 66 learning units, and that, colleagues, is a lot. This is a comprehensive, ambitious training that will make a difference. We are confident about it. And as I said at the beginning, this will be the probable entry point for many people. Plus, we expect to engage a network of more than 500 professionals in the piloting of such training materials. And we could say, let's say that this is not a theoretical exercise anymore. This is already a coordinated effort to build capacity across countries, across Europe. Finally, we are also we will be providing direct implementation support to 15 member states in the following months. So if we go to the next slide, and here we will share the video. We will present a short 1-minute demo of how the training programs, the training materials will look like. A sneak peek of what you will find in the EU Academy by the end of...
the explanation of the icons and labels you will find throughout the modules. This will help you identify and better understand the content. Use the buttons at the bottom right of the screen to navigate forwards or backwards.
Chapter 1. Introduction to Health Data Access Bodies within the European Health Data Space for Secondary Use Ecosystem.
Okay, I don't know if you heard the background music, but basically this was a sneak peek. This is somehow how we are building from the formatting perspective, let's say the training materials, and basically this whole training program will be accessible and ready to consume in the EU Academy. We have tried to make the trainings, of course, as complete as possible, but also as easy to consume and interactive as possible. So I hope let's say that this is somehow appealing and interesting. We'll be kicking off the piloting of these trainings very soon, the first dates being in early September. And finally, the last slide. Beyond these outputs, we would like to share like two key observations that somehow emerge from our work in this capacity building, but to be honest, not only, but also by several other insights coming from across the ecosystem. First, the pace of progress in the secondaries ecosystem will depend largely on national capacity. In practical terms, this means that capacity building should not be seen as a supporting activity. It is really an essential part of the infrastructure. Without sufficient capabilities at national level, the broader objective of the HDS will be difficult to achieve. It is potentially an obvious conclusion, yet support actions need to be defined accordingly. And we think this is an important point to raise. Second, the field itself in secondary use is still evolving, and to be honest, more than that, we believe is evolving rapidly. Best practices are still emerging. Different member states are progressing at different speeds, and as such, the operational reality, right, is changing as new requirements become clearer, as decisions are made, as new resources and budget are put in place, as new governance mechanisms are defined, and so on and so forth. So this had a direct implication in regards of our project, with projects like this to producing technical outputs as we produced our own training materials, but also will of course have implications for the future. So basically the approach to capacity building needs to be somehow dynamic. And training content, tools, and methodologies need to evolve continuously. And if not continuously, at least systematically, right? To remain aligned with the needs of member states and with the new requirements that will come. And that would be it. I'm sure Dimitri will perfectly complement what I just shared during the upcoming panel discussion and respond to any question you may have. Thank you very much for the attention.
So we thank Federico very much for the presentation. And now I would like to introduce Dr. Niki Schutte, Head of Unit Innovation of Health Information Systems Unit Data Governance at Scienzanon, Belgium. So Dr. Schutte, thank you for being with us.
Good afternoon. Welcome, and thank you for the invitation, Maria, to join this panel. Today, I will be talking a little bit to you about data discovery, because as you know, data discovery is the first step in the European health data space user journey and forms the start of life-saving, life-improving research and innovation activities. So what do data holders need to do for this first step in the journey? According to Article 60 of the regulation, data holders would need to describe their data sets. And Article 77 already gives you some clues on how to do this. Title, description, source, scope, and then you also have Article 78, which provides some information about the data quality label that needs to accompany your data sets. So let me take you a bit on a journey to show you how we arrived at a very robust metadata model, helping data holders in the European health data space to fulfill the duties of being a data holder and describing your data. And it's very important to note that this was all developed in a constellation of European funded projects. So we first start in October 2022, just the kickoff of the Health Data at the EU pilot project, which was funded through the EU for Health program. And within this project, we first started with the definition of the requirements. What do we need to do? What is already out there? What kind of metadata models are there? What do people use? And what does Europe want us to use? Then we decided to create a technical working group with experts, linked data experts, metadata experts, in which we discussed lengthy for over a couple of months a new model, an extension of the DCAT application profile as currently being used to describe data sets in Europe. We decided that an extension was needed of this DCAT application profile in order to accommodate for health. Within this technical working group, we organized interactive sessions, surveys, etc. to collect a lot of data. Moving on to January 2024, then we published the first draft of the Health DCAT application profile on GitHub. And later on, we did some small-scale functionality and feasibility testing. But at the same time, another project started. In January 2024, a new Horizon project kicked off under supervision of Enrique Bernal-Delgado. He's also here in the room. You heard him already this morning as an expert from the Front Row Commons. And within this project, they worked on the data quality label. Then later on this year, and we've heard a lot about this, so I will not bore you with the details of the TEDAS joint action that kicked off in May, which also plays a very important role in fine-tuning the Health DCAT application profile. We've been working on this already for 2 years, 2.5 years by the time, but actually what it would need is fine-tuning and validation in the health community. At the same time, the Quantum project was working on technical specifications for the data quality and utility label. Moving on to 2025. The public consultation of TEDAS has been kicked off. This means that everybody in Europe has the chance to comment on the Health DCAT application profile, the metadata model for the European health data space. And in August 2025, under the supervision of my colleague Beatrice Barros, we published the final TEDAS 2 guideline on the Health DCAT application profile. And at the same time, the first version of the Quantum data quality tool was also published, and some label implementation pilots were carried out. Now, finally, the final Quantum tool has been published in March 2025, or actually 2026, and then now recommendations for European health data space quality and utility label are being fine-tuned and will be published. It's not 2024, it's 2026, so very soon. So, concluding, there are a lot of European-funded projects that play a very, very important role in actually operationalizing the European health data space. We've been talking about pilots in the previous panel, but this is actually a good example of really taking it to the operational level within several projects funded through several funding schemes. And this resulted in the 2 guidelines for data holders, one on data description duties using the metadata model, and one will be published very soon on the data quality label. But here it doesn't stop, because you can really work with this and take it further. Yesterday, we heard a lot about the SHAPED project, which is a project funded through the Digital Europe program in really trying to find the interaction between the European Health Data Space and the AI Act. And what is very cool is that we have a task here dedicated to create a demonstrator in which we show how we can leverage AI to augment the metadata catalog. We can make it much easier even to find data, because then a research question is translated into virtual data sets. We can map these needs using rich metadata from the catalogs, and we can generate proxy data to support this privacy-preserving exploration and early design, so really to speed up the user journey in the European health data space. Thank you.
Thank you, Nienke, for this journey through the projects, for these outcomes. So I would like now to introduce Dr. Lifeng Liu, Head of International Team Coordination Council Project, National Cancer Data Node of the Netherlands. So Dr. Liu will present the Council project, and thank you for joining us, and the floor is yours.
Thank you, Maria. Thank you. Good afternoon, colleagues here and online. It's really an honor to stand here and share with you what Candle will bring you. So my name is Lifeng Liu. I'm a medical doctor by training and also epidemiologist. You may ask why you are here. You're a medical doctor researcher. Why you're here? Because I'm a user. So over these 2 days, I heard many colleagues raise the point. How can we bring users' needs into the implementation of EHDs? Here I am, here we are, here is Candle. So, and I think to complement with what Nink said, I think Candle is also a very good example where the European project can contribute to the EHDS implementation. So the core ambition of Candle is very straightforward. We developed the National Cancer Data Node to facilitate the implementation of EHDS at the national level. Let's move on. So let me put a little context into the cancer world, into the world I'm living in. So as a researcher, you may recognize a very common phenomenon. The data are generated from institutions at the member states level, but we don't have a central place to find those data. And we don't really enjoy the application process because it's a tedious journey ranging from months to years. And I took more than half of my research time waiting for my data. And when I have the data, I need to create my own solution for that analysis. But my next door neighbor is doing the same analysis, but he's also trying to find a solution. Do you recognize what I'm describing? I see some people nodding, so I think I'm telling the truth. So I think EHDS brought a once-in-a-lifetime opportunity to streamline this. But it's a legal framework. It doesn't translate automatically into a workable workflow that can help researchers like me. But the Commission sees that in the future, in cancer world to start with, there are two platforms on the EU level will be established. One is called the NCAN.EU platform. This is a federated platform to support research across the border to work together. That's called Understanding Cancer. And the other one on the left side is called the ECPDC. That's European Cancer Patient Digital Center, taking care of the patient-reported outcome, patient information, and also information for the caregivers and family members. And the common denominator of these two platforms is the national node. That's the national mechanism to help to bring the national communities into the infrastructure world and bring these two worlds together. So this is how Candle can contribute. So please don't try to read it, and many of you may recognize this blueprint, right? So this is really a real-world translation from EHDS legal framework into a real workflow. But there are some missing functionalities in this workflow because the holders and users are desperate when they are asked how to improve the quality of my data as source, and what's the tool for my analysis, and how to make sure that my data can be reflected in the European catalog, and where is the common data model? How can I build a national capacity for my institute on my national level? I just saw the demo, which is really a great initiative. I think we can disseminate that training program through the national node in the future. So the aim of national node is really to identify and develop those missing functions for the users community to comply with EHDS scheme. So basically, we envision there are two missions for the National Cancer Data Node. The first one is what I just illustrated. That's the data infrastructure part to help the researchers to get their data right. So you can see that's the lines between the central NCAN platform and the National Cancer Data Node, abbreviation NCDN. And the other one I feel extremely important. That's not because it's my invention. It's because in real life, what happened is that the communities come together to discuss how to use a tool, how to develop a common data model across the border. That's really the place to bring the infrastructure to the community and get tested, validated, and refined, and also share experience and join forces, not to invent a wheel again and again. So in Canada, that's the connection line across the National Cancer Data Node on the outlier of this picture. And in Canada, we already started this community building for we call it the community of practice on the tools for data analysis, for example, as CBIO portal, and we are developing a European common cancer data model together with HL7 Europe. And we also discuss what's the best solution for data linkage and how to scale up genomic data sharing across Europe. And under EHDS, we are discussing with the member state what would be the best place to allocate a national node. Either we could become intermediate entity or trusted data holder or even thematic health data access body, or we completely stand outside of the scheme. So it's on discussion. So in conclusion, we feel that without identifying or fulfilling the user's need in EHDS implementation, it will be a tedious journey. So let's walk it through and really try to find what's the solution for the national implementation of the EHDS. So in summary, EHDS is a framework, and national node is the operational expression of this legal framework in oncology. And I'm very proud to say we are very grateful for the support from the Commission, because they are tirelessly bring Candle into the front line of EHDS implementation. Therefore, on 7th of May, many of you may already receive the invitation. We will have a dialogue with you to see how to accommodate national node and how we can facilitate your work and to help the implementation in member states. With that, I'm very happy to bring back my floor to the chair. Thank you very much for your attention.
So, dear Dr. Liu, thank you for the presentation, and thanks to all the presenters for their valuable and complementary input. So we now move to the discussion part of this plenary, and I would like to invite also Dimitri to join us here. We have prepared one question per each of our panelists here to shed some light on how these project results can further support the EHDS implementation. And so I would like to begin with Linke. And I would like to ask Linke, with your experience so far with all these projects and the implementation of two products that have to do with dataset discoverability, how can Europe ensure the trusted and efficient access to health data for secondary use under the European health data space?
Yes, thank you for this question. And I would like to maybe focus on the efficiency part here. Because let's focus on the metadata and the role that we play in the first step of the user journey. Complete, rich metadata records are of utmost importance. And I hear you all think, well, yes, that will place a very heavy burden on the data holders. But there's a little paradox here ongoing. Because, of course, it takes time to provide rich metadata to really describe your data sets. But it also avoids having to answer a lot of questions on the data sets. And of course the option for maybe data users to generate synthetic proxy data, as we just showed you in the SHAPE project. So this streamlines the whole process and maybe even alleviates the burden on data holders. Less help desking, better data access applications that are successful, higher quality. So I think here there is a lot to win if we focus on maybe even upstream, not really talking about data access just yet, but first on the data discovery part. And I think this is the gateway, the first step of the user journey. Let's make that a success and the rest will follow.
That's a good point, Ninke, and thank you for pointing this out. And moving to the second question to Dimitri. So, according to your opinion, what are the most critical requirements to ensure health data is usable for research and artificial intelligence development at the European scale?
So good afternoon, everyone, and I really appreciate that there are still people staying here, and I'm sure that there are people online. I think that we actually are touching, very complex questions down to the end of the conference, And I just want to say there's one famous Gartner AI hype cycle from last year, where they put the AI-ready data out 10 years from now. So basically, if you are familiar with the Gartner hype cycles, the 10 years horizon is basically that they don't know. That's usually the prediction that goes from Gartner. So even Gartner and then those who actually commission those reports to Gartner, they don't see that we have data that is today ready for the AI consumption. I think it's a bold statement. I think that the Gartner is trying to move market in a way. But also for us to approach this, and I think that we are kind of, as the whole world, we're in the beginning, and probably, maybe if it wasn't the real reason for us all to start the EHDs, but then it became obvious that we are in the right time to try to mobilize data, to make actually some breakthrough with the AI applications that became so hungry and so dependent on the data that is fed into those models. But I think there are kind of two things here. So one is a little bit of a governance element to that, is that what actually we can expect from the regulation, and then what we as practitioners can do on our own end in order to make the EHDs happen and to make it kind of scale. So data sits in the middle of that. But that is one of the misperceptions, and there was a nice conversation I had with Yanis Tolios, during lunch, is about the misperceptions that we have around different types of regulations and regulatory acts, is that what they are actually there to do. And from the EHDs perspective, especially for the secondary use, that we all know that actually we do not prescribe what we do with data itself, right? For the secondary use, we enable the secondary use regulation. If in a way it's an enabler for the researchers to do something with the data. So we help with the finding, so we help with the discovery, probably a little bit with an access. But then whenever we discovered something, it's our own job to figure out what to do with this data and to figure out how to do all those complex things that we are trying to enable, such as federated learning, if you will, right? So data doesn't move. The regulation doesn't say how to move the data in that sense either. So it's up to us, up to the professional community, up to the data users and data holders to actually figure this out on themselves. So I think in that sense, I could have answered that we have a lot of things on the technical spectrum in order to mobilize data, make data usable. There was an interesting discussion we always have with Enrique, here's in the room. So what is that? Do we need to make data a little bit more interoperable on the secondary use as well? Do we need more standards on the secondary use, or we don't need standards? This could go even more, right? Because in the secondary use, we are not only data dependent, we are algorithm dependent, we are secure processing environment dependent. So do we need to standardize those to make this kind of scalable so that we are all on the same level? But probably it all starts, I think, the critical part there is that we don't need to expect that the regulations answers all the questions. But we as the community, as the data users and the data holders, we actually start figuring out these things by ourselves. Practice, find best practice, surface the best practice. That probably would enable things a little bit faster than they're happening today.
Thank you, Dimitri. You put the challenges and the responsibility on the data users as well. And so moving to the next question, to Dr. Liu. I think that you have touched this, question during the presentation, and maybe you can elaborate a little bit more. What is needed to move from project-based innovation to sustainable health data EU infrastructures?
Thank you. That's precisely the point I want to continue to talk about. First of all, I think project-based doesn't mean bad, but it's not good. It's good, but not good enough. So I think the example that Ninka gave and also the Candle project is a very good illustration to see how the project can really fit into the implementation of such an important EU policy. So for me, that's a very important and very good initiative. And secondly, I want to come back to Henrika's project interoperability topic. And I showed you from my second slide the 3 projects that funded under the EU Cancer Mission. We are kind of sibling projects. So every month we have a bilateral to synergize our products and our deliverables. And also we have joint events and joint survey because we are all tired about survey. And those 3 projects just do one-time survey to our common stakeholders. I think it's a very organic way of building our project in the future. And finally, but I think most importantly, is really the embracement from the users' community. When we talk about long-term sustainability, we talk about funding, the next funding round, the other funding schemes, but I think the ultimate sustainability is coming from the fact that it's useful for the community. So if you have something established but no one used, there's nothing called sustainability. That's my answer. Thank you.
Thank you very much.
Okay, can I respond? Can I maybe add to this?
Of course, Mikael.
If I may. Because I actually see some really nice links with the work that we're doing also in TEDAS, and this document is actually up for public consultation, and Beatrice presented it this morning. I think it's important for the sustainability is also to acknowledge the existence of expertise within these other infrastructures. And not only from the technical knowledge that is important, but also the financial organization, organizational feasibility expertise, knowledge on service costs, for example. I think the front row comments was also talking about multi-country applications, cross-sectoral integration, and I think here research infrastructures can really play a very important role in making the EHDS operational. I think we should acknowledge this and really do coordinating efforts to make a full seamless connection between these infrastructures.
Yeah, fully agree. I didn't have the time to show the candle. We do not develop anything. It's a CSA. So what we do is to bring the infrastructure solutions from the European research infrastructures and national infrastructures to combine them and synergize them and then to bring to the community. I feel we have more than enough in Europe now. We don't need to reinvent anything new, just to reuse it to its best.
Thank you very much for this fruitful discussion. And now, before we take the final takeaways from our guest here, we would like to bring the Mentimeter questions for the last ones to close this cycle of feedback received from the people here. So, here is the first question. What is the most important contribution of the European Health Data Space secondary use projects? Improving health data quality, supporting AI development and validation, enabling research collaboration, strengthening health data EU infrastructure, and lastly, supporting public health and policy making. And I don't know, while people is answering these questions, maybe I could have, if you have any input on this, because we've seen a number of projects and how one can leverage the output of the other. I don't know if you would like to make a statement on the synergies happening with these different projects and how we can leverage these synergies in the future.
Yeah, so I think what's important here is that what we show, and it was also very evident from the first panel, where they say, okay, we're piloting a lot, but actually what we should do, and we're doing this already, I think, from bottom up, and actually the Commission also makes more and more efforts to get this done, is to see this work in a constellation of projects. As I will try to show you in my presentation, is that we did not arrive at, for example, a metadata model for the EHDS based on just one project. It is picked up in another project, fine-tuned, validated, brought to the general public, tested, and then implemented in first use cases and then for real. And I think it's important that we do not see this project as just as a project, but really trying to see them as a constellation. And also funding schemes, and I applaud the Commission for this, because more and more you can see it also in the funding schemes where they list that you should build on outputs of other projects. And I think this is of utmost importance. And I think Li-Fang actually provided already quite a nice example of the sister projects. This is what we should work towards too, and what we should maintain.
If I may add, just I vote into the middle bar because I'm a researcher, I'm biased. So for me, I think EHDS most contribution to the secondary use of data is really to promote high quality, practice changing research. Well, when you read some research articles, normally the final sentences is that we don't have the right data, we don't have enough data, so look for another research project. And that evidence level doesn't really powerful enough to change practice. I remember yesterday there was a panelist on the stage saying EHDS means modernized medicine, modernized healthcare. And that's our ultimate goal. We are not stopping at a research level. We need a better research to improve our healthcare. That's our ultimate goal, and we shouldn't forget that. So that's why I vote into the middle bar. And I think Dimitris also mentioned that.
Yeah, I voted for the policy one, but there was nothing there that I actually would have picked based on what I was saying. I think that, especially in the secondary use community, we need to capture as much knowledge and as much experience as possible, because especially on the research side, because the secondary use, there's many things, right? It's not only a research element of that, but on the research side, we tend to be fragmented. And we tend to think from our own perspective on the things. And therefore, these projects give us that chance of surfacing what is happening, even though they may not be perfect, right? And there may be a lot of opinions, but it is also a natural part of any given research project. Like if you are not opinionated, if you're not pursuing your own idea, you're failing. But from the policy perspective, the task is actually to be able to assess properly what are the outcomes of those projects and what could be the next step there. Maybe a harmonization need, maybe launching a little more on a particular topic. I think this is happening, but it's just in the sense that how we look at this project, because some people may, let's say, challenge us and question the way how the funding is being spent. And there's probably many things, and I think it's been brought up already a few times, that maybe we are overspending or there are some redundancies in the projects. I think Enric Martins mentioned about the redundancies, but these are good redundancies in a sense, because we repeat things, and if we see that they are repeating and repeating, maybe they are the right things. Or maybe if we make the same mistakes, also the flags for us to reflect. Therefore, again, I voted for the policy because that's an oversight. On top of it, what is the outcome of this project? Because we do not industrialize these projects. Usually the projects end and nothing happens afterwards. Then there is a decision taking, happening where we decide what's next. This must be based on what were the outcomes of the previous iterations.
I think you all three pointed out and highlighted with bold the same key message for integrating the project results into the real infrastructure. And so the second Mentimeter question and the last one for the event. So let's have the highest participation we can to the last question. What is the biggest challenge in operationalizing EHDS secondary use? Data access procedures, data quality and harmonization, governance complexity, limited technical capacity, or sustainable funding models?
There's a bad news from the panel here.
Our answers are not there.
We picked the closest, probably. At least I picked the closest.
But do you agree on the missing answer?
So you go first this time.
Well, I mean, I kind of left this a little bit into the closing part, but I think that the way how we think we can scale up doesn't exist. We didn't figure out how to operationalize EHDs. Because for now, we are in the funding phase, so we are thinking that we are starting an engine. But in order for that engine to continue, we need fuel. And we cannot sustain it just keeping up putting someone else's fuel. We need our own fuel. And that is missing. I think that is closest was the sustainable funding models.
Yes.
But I think it's not even funding. It actually has to be profitable in a way.
It's the second layer, the funding. The first layer is, yeah.
For me, the real funding is the usefulness from the users. You can applaud here. And honestly, what I miss from these bars is the users'
benefit.
Users' interface and benefits. So you can say this bar is too high, but if the user can jump much high, the bar is not high. But when I hear the HADAP data application form have 235 questions, as a researcher, I say goodbye, I'm going my own way. I don't go that track. So if you want to be successful, you design a product for the user and bring them in the development.
I kind of.
Yeah, that's exactly the point. I was on a plane with just only public health researchers. We were on our way to Helsinki for a public health conference. I said, hey, listen, you want some data? You know, EHDs? And they said, no, we're just going to call our friends at the statistical office and we get our data in. Yeah, that's not how it should work. It should indeed be user-focused. It's the only way to make it work. Make it sexy, make it operational, and we're there.
And it was highlighted again too many times yesterday and today, but I think it's good to highlight it every time. It seems that we need to understand it even better, but this is the core concept to operationalize the EHDs secondary use and primary use at the same time. With that, I would like to invite the panelists to make a short closing statement, if they wish, and then close the plenary. Ninke, would you like to make any statement?
Yeah, very short. You can all make it operational. What you can do, currently, there's a public consultation ongoing of a very important implementing act. Please take a look, provide your feedback. It is very, very, very important, especially because it's about data discovery. Thank you.
I think my marketing final remark is that users' preference, users' fulfillment is key. And the National Cancer Data Node is one way to get there. And I think that's the sandbox where we can get our hands dirty and start working on something. I remember maybe Marcus said in his speech, we are in the chess game, in the middle part of the chess game, and the final part of the chess game, we need a candle. Thank you.
So, as a closing, probably I'll give you another number. So, kind of, I mean, it's a strange report, but that kind of report, you can Google it, it exists, so I don't make the numbers up, says that the reuse of the data market, or we can call it secondary use data market, is estimated around 30 billion today. And it has quite a speed at which it grows. The way how this number is built today is more or less is how much pharma pays to buy a data set. That's a very basic idea of this, how this market was calculated. Of course, I'm simplifying, but this is the number that we can keep in mind, and it will probably grow. So, and then bring us back to what we see in the Draghi's report is that we have to be competitive as the European Union. And now we are building a data space for healthcare. We're building actually other data spaces, but we are building a data space for health. And that probably gives us a way into life sciences, into biotech, into many different industries that must be competitive. Because that's the other cycle. So today, EHDS, as every regulation in the world, is a baseline. It does not make us competitive. Every regulation gives you the starting point, the foundation upon which you act. But in order to be competitive, we need to build something unique on top of that. So that's kind of my message for us, that not to lose the sight, not to lose the vision. So EHDS is only the start. So we shouldn't be thinking about how to operationalize EHDS. We need to be thinking what is there on top of EHDS that makes us as a union competitive in the market.
And Federico, would you like to say a closing remark?
So one simple message, maybe. In my experience in this project and within the active EHDS community for secondary uses, and also working with national competent authorities, especially with the Ministry of Health in Spain and in all Spanish regions, basically, let me end with just one simple message. To create structure where there is complexity should be a mantra in all actions in the way forward. That would be it. Thank you.
Thank you, Federico. And thank you, all of you, and what a wonderful panel we had here. And let's applaud the three panelists with the valuable input and close the plenary. And thank you, everybody.
Just to say a big thanks to all. Thanks a lot for being here. Thanks a lot, Marcus, Sofia, Naomi, and Henrietta, Terpsithea, Melanie, Marina, Andreas, Christos, for all your help in making this conference a reality. Thanks a lot, everybody. Thank you. So, Melanie,
So this one brings us to the closing of day 2 and of Ehds-Ai Connect 2026. Over the past 2 days, we have explored how the European health data space and trustworthy AI can transform healthcare across Europe, from policy to real-world implementation. On behalf of the organizers, I would like to thank all of our distinguished speakers. Big applause, please. Our participants here in Limassol, and our online audience for joining us, and also the speakers, of course. The presentations of the speakers will be available at the website next week. And if you want to revisit all the material that it was presented here in the conference, you can visit our YouTube channel. And I wish everyone a safe journey back, and hope we can meet again soon for maybe the Ehds-Ai Connect 2027. Who knows? Thank you.